what accounts largely for the fasting hyperglycemia. Then, of course, the incretin story, you still remember it when the GLP-1, the incretin, that hormone that they say increases enhances, increases the insulin production, was later referred to as incretin and established to be due to GLP-1 as a stimulator of beta cell to produce insulin and as a magnifier, as it were. And the story is very clear for those who still remember that basic biochemistry or those studies where IV dextrose did not elicit as much insulin production as the oral glucose. Then lately, as we grew up in capacity in this biochemistry, we learned that about 30 to 40% of that circulating blood glucose is actually from the kidney, both from neogenesis of gluconeogenesis as well as reabsorption. And that has changed many things. The muscle, very large in terms of size in the body, uses a lot of glucose. So if you have a lot of insulin resistance there, then the uptake is reduced. Then we now know that even in the brain, the appetite, the orexogenic and anorexogenic areas, a gastro-neuro link, very important in appetite and energy intake. So that is the ominous octet. And these are areas that have had therapeutic approaches, GLP-1 receptor and DPP-4, then of course the others. Next. Looks like I'm unable to change. So diabetes is interesting in the sense that it is extremely heterogeneous. You're too fast. Diabetes is extremely heterogeneous. Type 1, we have established in our own setup in some old publication that we did in this African Medical Journal that there is type 1A and type 1B. And the A was the autoimmune, and then B was the non-autoimmune, probably toxic. But type 2 is what we want to talk about today, and it has a lot of heterogeneity, but they all overlap within the gestational, monogenic, and then the pancreatic type, and this is still an area of activity. However, with development, now we know and we appreciate that we also share a lot of the predominant type 2 diabetes, which is obese or weight-driven type. And that accounts for anything between 55 to about 65, 68, 70% of our diabetes. So that you remember, bear it in mind as you see the patients that come in front of you. Next. So this is the current thinking. We'll keep back and forth because that is really the essence of our talk this morning. That we all start with lifestyle education and support to our patients, whoever they are, in that heterogeneity. Lifestyle that aims at enhancing physical activity to burn glucose or burn energy, and of course, to make the tissues much more efficient. And in the same breath, you use that opportunity to reduce a beta cell insult by the glucose. Then, of course, education to enhance one's capacity to adhere to treatment. Then, of course, the support that is necessary. But now we know we want to reduce symptoms when patients come to you. But even when you reduce symptoms, you want to use specific approaches. And these symptoms, you reduce them, but now we have agents that can optimize symptom relief, but at the same time, with the end in mind, reducing cardiorenal risks. And that now you can do even with the emphasis on glucose control or glycemic control and weight reduction, the agents that help you achieve cardiorenal risk reduction by at the same time controlling blood sugar. Next. So this is where we used to be. And it doesn't look too clear, but the message is that we used to start with a step 1, step 2, step 3, step 4 to target glucose reduction, and was what we call treatment to failure. That if this one fails, add the next. If that fails, add the next. So the failure-driven therapy has been given up to much more pragmatic approaches. And like I said, the American Association of Clinical Endocrinologists advise that, again, we still look at the lifestyle, very important because it cuts across the it's part of the continuum from preventive to the end when patients may not be able to, but even then, you still have to prescribe specific, context-specific lifestyle approaches. So we maintain and achieve optimal weight, and choice of the glycemic control agents must bear in mind the atherosclerotic cardiovascular disease, potential of heart failure, chronic kidney disease, and of course, weight control. Obesity comes with the non-alcoholic fatty liver disease. So all this you must bear in mind, because agents like GLP-1 receptor agonists actually reduce that. So the choice of therapy, therefore, is driven by those that I've talked about. The target is still quite tight, 6.5% ideal. And then it is important to individualize, because when the atherosclerotic cardiovascular disease or cardiorenal disease or controls set in, or the age is an issue, as we shall see, then you need to adjust your targets. Then the conscious attempt to avoid hypoglycemia is important. Continuous glucose monitoring is best for type 1, but we tried it in, one of my students did it in type 2. It works. It helps identify the postprandial hyperglycemia, but how often is it a daily affair or a periodic or sporadic approach? When one slips off, that is something which needs to be established, and of course, when resources allow. So comorbidities are important, as we shall see. And next. So what we are talking about has been exemplified in the Verify study. The Verify study quickly was meant to ascertain the value of early combination therapy. And indeed, it showed that early combination therapy is something that we need to do very early, and we need to make it standard of practice. Why? Because of the benefits that it brought that we shall talk about shortly thereafter. But this is coming, this was started in 2019, and you remember where we came from the UK PDS, that even when we did the glucose control so well, still we had residual complications. So remember the Verify study, and I still want to stress this. Why? Type 2 is heterogeneous. In the patient, the insulin resistance may vary in your patients. It is a progressive beta cell failure, so they may require multiple therapies quite early. And then, of course, the liver component has been well dealt with the therapies that we have in place. However, the heterogeneity is not just the biology, the behavior. is just as heterogeneous. So you need to remember this and address those in the therapeutic patient education. But that is not enough, because there's a health system where the healthcare provider, the doctor, also has exhibited a lot of what now is called therapeutic inertia. It used to be called clinical inertia, but now you call it therapeutic inertia, that we are slow to intensify treatment either by habit and or capacity. We may be failing in that area because we lack the capacity, or we have made it a habit, or a bit of both. And my old teachers told me habits die hard. So if you knock off H, there's still a bit of it remaining. If you knock off A, the bit is still there. If you knock off B, it is still there. So habits die hard. Habits die hard. So we remember this, because this is the essence of our continuous medical education. And I just gave you a bit of a history. UGDP, University Group Diabetes Program, treated with sulfonylureas. And this is what informed, in a story like colleagues are meeting, informed the UK PDS in 1970s. And 1970s, 1977 to be exact, when they started the UK PDS, then glibenclamide and metformin, and then of course the other agents came in, and multiple approaches. But still, it was glucose driven. You know, the story of UK PDS, then adopt story, very important, because we are going to finish with a slide regarding adopt and the heterogeneity, why it is important. Again, looked at metformin, glibenclamide, also called glyburide elsewhere, and rosiglitazone. Rosiglitazone, you still remember the story. The younger ones may not know, but it was abandoned because the story was encapsulated to tell us the beautiful things and not the side effects. And the farmer was fined significantly. Then grade, looking at those multiple agents, steno2 I've talked about, and then we are saying single agent stepwise is not the approach, and we have to approach it differently. So the standard approach initiating therapy in type 2 diabetes is now an early optimized metabolic control, that you must ask, how quickly can I expect to control my disease, not how quickly can I reduce glucose, because the disease is multi-system. And then controlling diabetes is important, because when you achieve remission of the disease and restore beta cell function, the endogenous insulin is advantageous, and that is very important. Then, of course, those are the targets, and we want to establish a legacy of normal glycemia or euglycemia very early, because that has long-term benefits. And that involves early intensification of combination therapy. You'd rather start with several, but scale down as required. Individualization is central in our therapeutic adventures or activity, so that when you set your target, you are guided by the kind of patient in front of you. There may be older one. You avoid hypoglycemia, because hypoglycemia is also associated, or rapid lowering of glucose to relative hypoglycemia, let alone absolute. Some patients become symptomatic for hypo at 5 to 6. But if you do it gradually, then you may achieve that very well. So the elderly who get hypoglycemia may get arrhythmias and actually have a sudden death, or they get confusion and you may not know that. You may actually diagnose dementia, memory lapses and abnormal behavior, yet it is because of your therapeutic zeal to control the sugar rather than treat the patient. So age is an important aspect. The BMI, I know this is a debate, which is the best way to tell obesity, but we still use BMI because culturally, we have been talking about making guidelines of type 2. Do we use waist hip ratio? But you are not going to start examining your patients, the women, that you just want to do their waist rather than do the weight. Otherwise, people would wonder your newfound zeal. So then, of course, motivation of the patient. Sometimes the doctor is very motivated, overzealous, but the patient is laissez-faire. And if they are the elderly, they are wondering why you should be so ambitious with them when they have been named in their grandchildren. So those are your actually options. The metformin, but the hatched lines are possible combinations, but the solid lines are actually established, well-validated combination approaches for that patient. And the evidence for all this is there. This talk could not accommodate giving unique evidence of the SGLT2 GLP-1 receptor agonist and a few DPP-4 inhibitors. The sulfonylurea glycoside is, especially the MR, is the one which is doing so well. So these are quick slides that we are going to, or that want to show you, that the typical UKPDS slide of initial improvement, then slow deterioration for multiple reasons occurred in different phenotypes. And there's a standard phenotype, but you notice the ACE, the metabolic, the various, the insulin deficient cluster 3, then of course the cluster 4, I'll show them to you in the next subsequent slide, and cluster 1. But these are more of the phenotypes. Let's move to the next, show you. So I've deviated a bit because that is the slide that we are going to finish up with, especially in the adopt phenotypes. So we have said that you remember there's a progressive disease, and then of course you start with the lifestyle, and your therapeutic attempts must remember the disease modifiers and include them in your initial therapy. Again, this is what we said we avoided when we start with monotherapy. You can combine, not necessarily monotherapy, but you can combine even 3 agents and scale down if necessary when you have done what we call risk stratification, because at times. So this is a summary of what happened in the Verify, that when you start early combination therapy, as opposed to metformin monotherapy, at the end, there is a significant achievement in terms of sustained beta cell function compared to the others. And you gain more time, about 4 years before many of those people get beta cell failure. So these are the phenotypes that we are talking about. There's the insulin-related phenotype, which is very insulin deficient. Then, of course, the obesity-related. Then there is the age-related based on the age of onset, especially the elderly. And then the others, which may be lean and insulin deficient and obese, but also insulin sensitive and obese and insulin resistant. So these are patients that are going to come before you, and you will see them in the subsequent slides. So these are the 5 phenotypes that have been seen and published in multiplicity. So then, if you go by the genetics of insulin or beta cell genotypes, There are genotypes that actually affect the beta cell destruction to just dysfunction. Few cells functional to many cells dysfunctional. So the genetics are various, but the ones that destroy beta cells are largely in the type 1. And then, of course, there's an overlap with type 1 and type 2 diabetes. And the weight seems to define, weight and age seems to define those phenotypes much better. And then, of course, why we do education is to modify the environment, especially of diet and physical activity. We might be here up to evening. So then, if you remember that heterogeneity, then you go through the various phenotypes, the insulin deficient at the upper end, and then, of course, the resistant strains. Then you can go through what we call the precision diagnostics, the omics, and many things that you can do. But we can also do it with symptoms and signs that we see every day, and we shall talk about that very, very briefly. And exercise seems to encourage the burning, the metabolism of glucose. And of course, if you reduce beta cell insult from diet and exercise, you can achieve so much. And you remember the Daching study of the 90s, and that cohort is still under follow-up. So then, at the end of it all, your precision treatment will target insulin secretion, but again, off insulin, to enable the little insulin to work, you may have to use the new agents, the SGLT2 and the GLP-1 receptor agonists. We still have a role with pioglitazone because the rosiglitazone is coming back a bit, but pioglitazone is the one which has been fairly safe, and that combination seems to be the one that is going to be much more popular. So this, if you look at the survival probability, the phenotype that seems to have the lowest prevalence of cardiorenal disease have better survival. And the phenotype that has a lot of that cardiorenal disease have poorer survival. And you can see the pink line on that Kaplan-Meier construct. So what are we saying? That the patient in front of you is a phenotype. How will you know? Age of onset, the weight, and the other behavioral things will allow you to risk stratify that patient for cardiorenal risk, and then optimize treatment from the earliest. And of course, this is how they behave in terms of their biochemistry. Again, that's just phenotypes, but what is important here is the glycemic control in certain phenotypes, very challenging. So your combination therapy must target other sites beyond beta cell stimulation. And this is what I was saying, that there will be a lean, obese. The beta cell mass initially may be very significant, but eventually, when they have a risk for type 2 diabetes, the beta cell mass will always be down. By the time they are manifest, about 50% of that is gone. And it means a lot in terms of circulating lipids, circulating other things, and the risk of cardiorenal disease. So then, this is the approach. We want now to be complication-centric and driven by the physical features that we see in our patients. And physical added to the age of onset, and then the behavior of that patient in the daily life will guide significantly And you can see the standard approach when you look at the body mass index of less than 25, 25, 27, and this would vary. In the Asian community, their figures may vary, but the African community will still mirror the African American because that potential is there. But the education is nutrition, physical activity, and the other interventions, especially the choice of medication and its safety and efficacy, and then, of course, the coping skills with diabetes. The rest is just the fine details. So that brings us back to where we started, that do what we call risk stratification, and the risk of cardiorenal complication. And then as you do your glycemic control, weight control, you will achieve cardiorenal risk reduction in those high-risk patients. And this is important using GLP-1 receptor agonists where necessary, and SGLT2 inhibitors. Next. And that's the same thing we are coming from treatment to failure to, even when you are glucose-centered, you have individualized, and you are de-emphasizing initial monotherapy and starting with combination therapy, which you can scale down. And that would be the sequential approach. And you notice cardiorenal risk reduction is so critical, and atherosclerotic cardiovascular risk disease, a risk stratification of who is high risk and who is low risk. And I will hint about what we are doing in that front when we are doing the renal complications sometime later. So we get off sequential, but if you're sequential, start optimizing therapy very early, and you can scale down and find the winning combination or the controlling combination or the controlling agent down the continuum of disease control. That is the same old story that we have summarized. In spite of our very good efforts, we still have difficulty controlling diabetes as a disease. I don't know, but whether it is in the patient or the doctor or combination of both is yet to be known fully. But we've just published a paper. I've just received a copy in a small journal, British, one of the journals, British Health and Research, Journal of Health and Research, indicting us on the quality of control, or quality of cardiovascular risk factor control, the ABC, A1C, glucose, BP, systolic blood pressure, C for cholesterol, that we do so badly that we wonder how patients survive. As my old teacher used to tell me, patients survive in spite of the doctor. So we're doing so badly in terms of quality that we need to change. And that study we did, my student did in our setting in Kenyatta, we did the audit, but we also did the knowledge of the care providing doctors. So now I sneak out to go and talk about the doctors, but we've realized that the person, the clinical officer who sees patients every day, seems to be better than my registrar. So it is an indictment on the teacher that we need to do something very, very rapidly. So in spite of our best efforts, our patients still don't get the best of us. That's just a reminder of what diabetes is. There's a progressive disease. And while I'm here, my brother went with, he's a diabetic. So he went with the prescription I gave him, I think a year ago. We meet so often. I say, I'm okay, I'm okay. And the other day they look for me while I'm here, panicking, the blood sugar of 18 and fasting blood sugar of 18. Then when I send one of my nephews who is a doctor, he found the meal that was given is eat fruits, eat dates, the bananas, and everything was there. And this man is. So diabetes is progressive. What you do about it must also be very right. So this is just a reminder that at one point you may need newer therapies, newer approaches, and new ideas. If I still have any. Yes, so this is now evidence that the GLP-1 receptor agonists achieve so much. SEMA, or semaglutide, is both oral and injectable. SEMA has been misused. In Brazil, the girls use it for weight loss. We don't have doula here, but Lira is around, but it's very costly and has achieved a significant weight loss, blood pressure reduction, and of course, cardiovascular risk reduction. Then with the renal benefits, even at very modest glucose A1C reduction. And of course, this is a major win. The only problem why SEMA will be very popular is because it's oral, but it has mitigation on stroke, which we don't find with the SGLT2 receptor, SGLT2 inhibitors. Next. Again, this is now as SGLT2 inhibitors. CANA, DAPA, and EMPA have been shown to achieve weight loss, pressure reduction, and then, of course, composite major adverse cardiovascular event mitigation. The renal benefits are enormous, but there is a bit of stroke enhancement. And the risk of hypoglycemia is quite low, but my experience with the SGLT2 inhibitors is your patients can walk with a lot of fatigue, beautiful sugars, but they are fatigued all over. Whether it is the neuroglycopenic sensation or a dehydration, not particularly sure, but there are patients who, surprising, I will tell you, DAPA is not as strong as EMPA, so you'll use DAPA every day. You may have to go down on the dose. Instead of the 10, if he's elderly, you may have to go down to 5, because now we are 5 in Kenya. EMPA is too strong. It is not in the evidence, but I use it sometimes twice in a week in those elderly, or 3 times in a week. And a Monday, Wednesday, Friday. You can try that, especially for glycemic control. But your patients will be fatigued a lot of the times because of fluid deficit. Next. So this is the ADOPT study. The ADOPT study now in that cohort, forget about the color patterns. We are saying that the cardiorenal risk complication, or the cardiorenal complication, or the risk of complication varies within, and therefore the outcomes are varying within those phenotypes that I showed you, defined by weight, defined by age of onset. So before you is your patient who will require an initial therapy that we are saying optimize early and know your patient. When did it start and how has it been? Obese, non-obese, or sometimes they are non-obese, they look it, but their physical activity levels are very minimal. So then they are inefficient in burning glucose, and therefore they have a higher risk, cardiovascular risk profile. So this is probably my last slide, and we shall end there. Is there any other slide? Okay. Oh, in conclusion, the pharmacologic management of type 2 requires an individualized approach. Choose an agent which is efficacious, based on the mechanism of action to guide your rational combination. Based on that ominous octet, remember the cost? The spirit is willing, the pocket is weak. The side effect profile, adherence to treatment burden, depending on what your patient is also taking, then that will also carry the comorbidities and the other non-glycemic effects. Then, of course, appropriate selection of medication results in improved glucose control, favorable effects on obesity, the atherosclerotic disease, heart failure, and chronic kidney disease. And I would like to stop there. The things that we are doing in terms of risk stratification, we just have hinted a bit in the next presentation that will come later. Because we fail to help our patients, why did we fail? From our own study in KNH, we realized we don't document. And as I used to tell my young colleagues as we train them, that when you round up things and say NAD, nothing abnormal demonstrated, is actually not actually done. NAD means not actually done. So documentation will take 3/4 of the people in this room to jail, because then you realize what was not documented was not done. And that was our major finding in that. It was so bad that in our publication, we looked at the positive end, that documentation should be a quality improvement initiative, when we should actually walk to KNH and look for the teachers and their students and suspend all of them for shoddy work done. Your patients are not controlled, your documentation is poor, and all those things. So with all due respect to my Dorcas and Kevin, documentation is our biggest undoing. And this was done when you people were with us. Not necessarily you, but this was 1 year a retrospective audit of our functions. Thank you very much for listening.
So now I would like to call our second speaker of the day. That is Professor Dr. Mohsin Siddharth. He is Community Health Department, Faculty of Medicine, University of Eduardo Mondlane, and a member of Board of Trustees of Merck Foundation, Mozambique. The stage is over to you.
Thank you very much. Good morning to everyone. And it's a pleasure and honor to be here. And I thank my colleague to give me floor before him. I have another talk to another place, so I will have to leave afterwards. That's why they are just adjusting the slides. Meanwhile, let me say that Professor Otienne facilitated my life, my presentation, because my topic will be related to epidemiology and prevention of diabetes. And when I was preparing the slides and proposed the topic, I proposed it because I work mostly within the scope of public health, and I realized that, as Professor said very well, doctors are more interested in prescribing, and if the patient is not under control, they prescribe more and continue prescribing. And he mentioned a few interesting things in his presentation that we need to take some time as clinicians to also look at other aspects that can help patients to control and not just prescribe. So I will pass some slides quickly because many of these things were mentioned already. So I work for Eduardo Mondlane University in Maputo, Mozambique. Please. So this slide is very busy, but I just wanted to highlight that the burden of diabetes is increasing, and this publication, the group Global Burden of Disease group, has been publishing regularly data about different medical conditions, and they have been showing, particularly for chronic non-transmissible diseases like diabetes and others, that there is a clear evidence of increasing burden. Some countries or some regions more affected than others, please. You can see this slide from International Diabetic Society that all regions will have increase in diabetes. And you can see Africa, for example, by 2045, will have perhaps a much greater increase than other regions. And you can see, for example, that the number of people living with diabetes in 2021 between the age group 2079, it was estimated that there were 527 million in African region, and this is sub-Saharan Africa, according to WHO Afro classification, which is only excludes Northern Africa. And you can see by 2030, the increase, and see how much increase we'll have by 2045. It is estimated that we'll have in Africa about 1 billion people suffering from diabetes. Number of deaths estimated in 2021, we had 416,000. But look also at the expenditure related to diabetes. That between estimated expenditure was for 2021 was 12.6 billion, and let me say that among all other regions, Africa is spending less compared to other regions on diabetic care, but not only diabetic care, also for other non-transmissible diseases, please. So as you can see in this slide, Africa has second lowest diabetes-related expenditure compared to other countries. And of course, this slide emphasizes the growth of the burden that we'll face in next few years. Please. So Professor mentioned also a bit of what I'm going to say, that the age of onset of type 2 diabetes is becoming, particularly in African continent, it's becoming more earlier. Although we don't have precise data on the exact burden of the type 2 diabetes in Africa, there are some surveys that have been done, particularly promoted by WHO. Perhaps you have heard STEPS, and some countries has already done 2 surveys, populational surveys, which actually gives you an idea about the burden and the growing burden of diabetes in African countries. The major risk has been, as was mentioned before, obesity, overweight obesity, please. And the economic burden of diabetes in African region is growing. There is limitations of estimates, but the burden is not only for the health system, as you can see on the figure on the side, but also the costs that are bared or incurred by patients. Last year, when I was talking to the media people, one of the questions they asked me after I was talking about prevention, and they asked me why it is expensive to treat non-chronic transmissible disease. Of course, if we tackle the problem early, it's less expensive. If we allow the problem to grow, to progress, the disease, as Professor mentioned, where we have to add other increase combination therapies with more complex regimens, where we have to also tackle other comorbidities or complications, then of course the cost will increase. Hello? Okay, please. So that was a declaration call to action from African region, provide adequate, appropriate, and affordable care in general, create healthy environments to prevent, also disseminate information, education, communication to empower people to self-care, and particularly in chronic diseases. Professor mentioned the doctors need to, a part of prescribing also, to talk to patients. But what evidence has been showing is that we need to empower patients to self-care. That's the better way of controlling than just depending on the clinicians. As also was mentioned, we need to have integrated approach, different specialties integrated, and also government commitment to spend more, to take care, and particularly to screen, to create conditions at primary healthcare levels to screen. Professor mentioned something very interesting, which is not clinicians not registering, not documenting what they see, but we have seen also in my country, the biggest problem is that clinicians not screening for patients, even measuring blood pressure or screening for diabetes when opportunities arise, when patients are at the health facilities and when they're identified risk factors and they miss that opportunities to screen, please. So this is very generic slide, which everyone knows that usually we define risk factors and among those that are modifiable and those that are not modifiable. So modifiable risk factors are related to overweight, obesity, and mainly diet, but also others like consumption of tobacco, unhealthy consumption of alcohol and others. So we need to tackle on factors that are modifiable, but we need to be aware also on factors that are non-modifiable. And Professor mentioned the phenotypic profiles of patients, which we can recognize within our clinical setting and tailor our approach to the patients, please. So this slide I brought just to clarify our understanding about some of the concepts, what we mean by health promotion, which is encouragement of activities that facilitate healthy living and well-being. So this is not just education, but also legislation, for example, provision of services and provision of infrastructure, facilities, such as, maybe you have seen in some countries or some places where we have public availability for public to do exercise openly in parks, etc. This is what we mean by health promotion. Health protection is safeguarding the public against external threats. And now, for example, in some countries like Australia, there are big campaigns to protect people against commercially made available products that are, we know they are harmful, soft drinks, others, and they are making compulsory to have labels where we can actually know what contains and know, or that idea that I cannot reveal because this is protection against competition, etc. It doesn't work now. We need to say exactly what it is. So this is to protect our population. This is one example. Then we have disease prevention, and this prevention, we can do it in different stages, from early detection up to the prevention of complications, please. And here I just want to show different things that we can do, particularly related to diabetes. You have seen that diabetic disease is a progressive disease, and we need to tackle a part of medication. We need to think about other things. For example, before the onset of disease, we need to see the risk factors, the social determinants, and try to intervene, try to influence, to modify. And one thing Professor said, very important, that, you know, we eat what we feel it's nice. We do what we feel it's good for us. And it's very difficult. Professor mentioned also, it's difficult to change habits. So we need to have this dialogue, this conversation with patients, and see what we can achieve together, which is the best, not ideal perhaps, but the best to control, modify to modify social determinants. And remember that people, I mean, they also want to have some pleasures, and sometimes we need to allow and have this conversation. So when the disease sets in, we need to detect early to limit its progression, and this is by screening. So if you don't screen, we face the risk of having patient for the first time diagnosed when he's under coma or with complications when they come to our health facilities, which is bad, which is failure of the system. And this is sometimes patients that have been in contact with the health system many times, and we lost opportunities to do the screening. And finally, we can intervene. This slide is just to show that we can intervene in all phases, including when we have advanced stage of the disease, where we can prevent complications. So prevention is not only, as the word implies, not to get the disease, but prevention can be done in all stages, even when the disease is already affecting the patient. Please. And different groups can intervene, government agencies, et cetera, et cetera. This slide summarizes very well, you know, primary prevention, mitigating risk factors, secondary prevention, slow down disease progression, detect early, intervene, introduce medications, introduce lifestyle changes to delay progression. And of course, we need to, someone asked about this and Professor responded very well. We need to tailor to the patient. It's a young patient, middle-aged patient, old patient. We need to accordingly do our interventions. And tertiary prevention, reduce disease impact, reduce complications. A patient who comes to the hospital for leg amputation or foot amputation, or becomes blind because of diabetes, or develops renal failure, it's a failure of system. It's failure of our profession, doctors. We fail to prevent, and these are all preventable things. And if we start working early, the costs here are cheaper than intervening later. Having someone to do hemodialysis is more expensive than preventing someone to develop chronic renal failure. Next. Okay, so this is just levels of prevention. Again, repeating, we can do at all levels. It's never late. Patient presented already with diabetic condition, depending on its level, there's still something we can do. Please. Okay. So investing in lifestyle. Professor mentioned this many times, and it's good to have a talk before. So you can also, there are now good evidence. If we tackle early, if we detect early and we intervene, changing lifestyle, perhaps we can achieve remission. And we can maintain this remission until the patient remains in a healthy lifestyle. This is very important. And this can impact in costs for the health system, also for the patient, reduce the burden of expenditure that the patient has to spend for the diabetic care. So this is possible, and there is emerging, you see, this is a recent publication, emerging evidence that there are successful cases that were achieved with lifestyle changes. Please. Oh, I think this went back. Yes. Just going back. So these are some, this publication summarizes some of the studies that were published showing impact, sample size and type of intervention that was done and duration of remission. So I'm not going through all this, but just to show that there is plenty of evidence that shows that it is possible. Next, please. But there are also some questions, and I think this is related to phenotypes again. This is related to lifestyles also. So it's not easy to generalize. So we need to tailor based on the patient we have in front of us. Okay, please. So remission is most likely with type 2 diabetes in short duration. This is what this publication that was produced recently says. Evidence shows that effective weight management should be provided to all people with type 2 diabetes as soon as possible after diagnosis. Even if it is possible before onset of diabetes, and weight loss of more than 10 kilos can have lasting impact on diabetic patients. So I think I'm almost at the end, please. Next. Okay, once again, just to summarize that we can intervene in terms of prevention at all levels, before onset, primordial infection, awareness programs, screening, etc. If the patient is already diabetic, we still can do something, early detection, lifestyle modification, introduction of monotherapy or combination therapy, secondary prevention, having good control, educating patient to take self-care, etc. And then monitor patient, have a good monitoring of patients to avoid complications. So patient don't have to go through all these complications, please. Okay, some of the things that have been mentioned about interventions that can be done at the society level, at the community level, individual level, etc. And I think these are applicable to all diabetes, as well as other non-chronic transmissible diseases, because they are same risk factors for cardiovascular diseases and others. But there are many things that we can do. Next, please. And actually, WHO considers these interventions for non-chronic diseases that they call it best buys. There are 8 interventions that have proved, there is plenty of evidence that and they are very cheap. If we intervene, we can prevent all these complications. Okay, thank you very much for your attention.
Thank you very much, Professor Mohsin Siddharth, for the insightful lecture. Now I would like to call upon stage our third speaker, that is Dr. M. Sudhakar Rao, consultant cardiologist, Manipal Hospitals, Bangalore. He will be addressing the area of heart failure management in 2024. What is new? So the stage is over to you.
Thank you, Merck Foundation. So I'll be discussing on the 2 topics today, hypertension and heart failure. I think my previous 2 speakers have talked on diabetes. So these are the diseases which are, we can call it brothers, sisters, and we can tell it brother from another mother, because we deal with them simultaneously, hand to hand. And I don't think so you can anytime separate diabetes and hypertension and heart failure away from each other. So what I was given a topic is heart failure management in 2024. What is new? In the last 10 years, I think we have been talking a lot about hypertension, from the advances in the management to the guidelines, newer medications, newer interventions, newer advances, and how do you manage heart failure? So the last 10 years, even from I studied medicine to I am being a consultant now, there are a lot of changes. And in the next half an hour, maybe I'll take through what is new in heart failure, maybe not in 2024, but what in the last half decade, please. So it will be injustice if you talk about heart failure and not talk about the definition of heart failure. So heart failure is defined as a clinical syndrome with symptoms and signs caused by the structural and functional cardiac abnormality, corroborated by elevated natriuretic peptides, and objective evidence of pulmonary or systemic congestion. So in the last few years, we have seen a lot of definition changes in heart failure. Before we used to use the Framingham criteria, and now we do not talk about the Framingham criteria. It's just a clinical syndrome. You just need to know the symptoms and signs of heart failure, plus an elevated natriuretic peptide. And that NT-proBNP is different for different ages. Like you have less than 50 years, it is 450, 50 to 75, it is 900, and more than 75, it is 1800. These are the cutoff for NT-proBNP for different ages. Maybe in another country, we may not use NT-proBNP or use only BNP, where the cutoff levels are 300. And there are many other factors which depend the NT-proBNP apart from heart failure. These are the sepsis, atrial fibrillation, cardiomyopathies, various trauma, infections, and many others. So not going into that in detail, but you should also have a systemic signs and symptoms of congestion, and let it be a orthopnea, PND, crackle, pedal edema, and many other weight gains and many other signs or symptoms. Please. Now, this slide again emphasizes the importance of, we have moved over from NYHA class. Many of you would have heard about the NYHA class, but we no longer use the term NYHA. We are only use the thing staging. The problem with NYHA was people may move from NYHA 4 to 3 to 2 to 1, but you cannot move a stage C to stage B or stage A. You can only progress. You cannot come down or back to a previous stage. Staging helps in the prognosis. Staging helps in the management. NYHA is more for a clinical cardiology, where we talk about the case presentations and other. So stage A, we know it's all about patients who are at risk for heart failure. And these are the people with diabetic, hypertensive, with some form of nephropathy, urine microproteinuria, or some form of left ventricular hypertrophy. People who are on chemotherapy drugs like the anthracyclines and other, who are at risk for heart failure. They do not need any medication, but they need the proper control of proteinuria, sugar control, and hypertension aggressive control. Moving to the stage B, they have a structural heart disease. They may have some form of LV dysfunction, but they never had any symptoms. And these are the patients who need to be treated with ACE inhibitors or angiotensin receptor blockers, because they do not have the symptoms, may need not have diuretics. Beta blockers are optional in such patients. Moving to the stage C, they may have a structural heart disease and the current or a previous symptoms. And apart from the ACE and ARBs, they should be on all 4 disease-modifying drugs, including the ARNIs, beta blockers, MRAs, and the SGLT2 inhibitors, plus diuretics for systemic congestion if they have any. Moving to the advanced, that is the stage D heart failure, we may have to treat it with AF management. If you have LBBB, you may have to put CRTs. Then you may have to use ICDs if they have any evidence of fibrosis. Moving ahead, mitral valve repair or replacement. Moving ahead, you may have to do revascularization if they have associated blockages. And then we have advanced form of treatment known as the LVADs and cardiac transplant, along with the use of inotropes for a palliative treatment. Please. This slide actually says it all. We have been seeing this slide. Most of you will be seeing when you talk about heart failure, you press images in Google. This is the first slide which comes. How does a heart failure trajectory declines? So this is very unique slide where it tells that once you have the first hospitalization of heart failure, the decline starts from there. So the first episode or the first hospitalization of heart failure is the place where you have to be aggressive on your management, including all the treatment, including the 4 pillars of heart failure, because that is where the subsequent hospitalization, your MACE starts, and your mortality rate has started increasing from that point of time. Please. So what is new in heart failure? There are 2 important things. The medical management. We have moved from the 3 pillars to the fantastic 6 of heart failure. We have also should know how do you titrate these drugs. You should know about the side effect of these drugs, when to start these drugs, when not to start this drug. Apart from that, when do you refer to a heart failure specialist is another important question. Apart from that, we have some adherence issues. How do you manage in special cohorts, medication cost and access? In increasing complexity, how do you manage heart failure? the comorbidities, and the hospice care. Please. So the first important thing remains, how do I initiate, add, or switch to evidence-based guideline-directed medical therapy? Now, this guideline-directed medical therapy has changed over last few years, and we'll see over the next few slides. Please. So this is what I was telling. When I was studying my residency in cardiology, there were only 3 pillars of heart failure, and those were the ACE inhibitors and the angiotensin receptor blocker, the beta blockers, and the mineralocorticoid receptor antagonist. When I passed my residency, the new drug which started was almost the ARNI, or the angiotensin receptor neprilysin inhibitor. The important trial was the paradigm heart HF trial. I don't want to discuss it, but over a period of years, the diastolic heart failure, we started with the Paragon, we moved to Parallax HF, then the Paradise HF in acute MI, and we have moved to a point where people are talking about ARNI in pediatric heart failure, where it is not much successful in the Panorama heart failure trial. Please. So from the Fantastic 3, we have moved to the Fantastic 4, and these are the 4 pillars of heart failure, which is currently, and this is still not the new thing. I'm still talking about 2021, maybe the 4 pillars of heart failure. This were the ARNI, beta blocker, mineralocorticoid receptor antagonist, and the SGLT2 inhibitors. Lot of discussion on how do you initiate these 4 drugs. Do you want to initiate one by one and increase to the maximum dosage over the next 6 months? Or the current followed pattern is rapid sequencing, where you start 2 drugs, mainly the beta blocker and the SGLT2 inhibitors, moved within the next 2 weeks to angiotensin ARNI, MRAs, and within 4 weeks, you should be on the full drug dose of these 4 drugs. So this is called the rapid sequencing. Please. But the missing is the 2024, where it's not the Fantastic 4, it's the Fabulous 5 and the Fabulous 6. So what is the Fabulous 5 is the vericiguat, which is the cyclic guanine cyclase stimulator. This has come in the last 2 to 3 years from the Veritas and the Victoria trial, which has been talking about a lot. People are talking about worsening heart failure. So what is worsening heart failure is people who have recurrent heart failure hospitalization 1 or more within the previous 3 to 6 months. They may need the increased dose of diuretics on IP patient or on the outpatient basis. They may not be able to tolerate your other 4 pillars very comfortably, and worsening of renal failure. But this should not be confused with acute decompensated heart failure, where people have left their medication, not compliant on medication. They have other triggers like the fibrillations or the infection, which can precipitate the worsening of old heart failure. This is purely worsening heart failure in the absence of any other cause, which is found only in 5 to 10% of all heart failure patients. So in this group of patients, the vericiguat, which is a group of drug which has been started in the last 2 to 3 years, has moved from class 2B guidelines to currently it is class 2A in the guidelines. Please. Now, what I was discussing, it's not the Fabulous 5, but it's the Fabulous 6. And the 6th therapy is the iron deficiency. Treatment of iron deficiency in heart failure. Without treating this, it may be difficult to come down on the recurrent hospitalization, MACE, the quality of life, plus minus the mortality, which is not being discussed much with the iron therapy treatment. So all the heart failure patients should have, if their hemoglobin is less than 15 and more than 8, we should screen for iron, TIBC, ferritin levels. And if your ferritin levels are less than 100, it's called absolute iron deficiency, or between 100 to 300 with TSAT saturation less than 20, it's relative iron deficiency. And all these patients should be treated with iron carboxymaltose with a dose of 500 milligram or 1 gram or 1.5 gram, depending on the hemoglobin and the weight of the patient, and should repeat a dose after every 6 to 8 weeks, repeating the ferritin and the TSAT levels. Because not doing so, we may not improve the quality of life. We may have recurrent hospitalization. And this is evidence from various trials like the AFFIRM heart failure and the iron out trial. Please. I may not go too much into that, but we should know that if a patient of stage C heart failure is already on a ARNI, a beta blocker, mineralocorticoid receptor antagonist, and the SGLT2 inhibitor, what are the newer things which we do not talk about much? You may have to treat your patient with adequate diuretic, because 1/3 of the heart failure patients may have something known as diuretic resistance. They may still have volume overload symptoms on the adequate dose of diuretics, which means the high dose of furosemide more than 80 milligram. If they are not able to tolerate, always try to add a drug like a chlorthalidone, metolazone, or a hydrochlorothiazide. We are not adequately using the acetazolamide, which has started from the last few years based on many of the trials. So those are few things which may be able to break the diuretic resistance. Also, SGLT2 inhibitors have a good role in breaking the diuretic resistance. Mainly in this population, I would like to discuss in symptomatic African American cohorts, people who are not tolerant to a ARNI or ACE or ARB, the use of isosorbide dinitrate plus hydralazine. This is some drug which is not used commonly, but a drug which should be used at its adequate level to gain symptom from heart failure because of its effect both on the preload and the afterload. If your patient has a heart rate of more than 70 on full dose of beta blocker, or if your patient is not able to tolerate beta blocker, ivabradine is one of the drugs which is used for heart rate management and symptom reduction in heart failure in reduced ejection fraction. Its role in heart failure in preserved ejection fraction with angina may not have a much role. Again, as I discussed, in people who are already on the 4 therapies of heart failure, if they have worsening heart failure, the next drug which we have to think is the vericiguat, starting from 2.5 milligram and going up to 10 milligram. Now, the role of ARNI, most of you would have heard about angiotensin receptor neprilysin inhibitor. Before, we had a thought that only in people who are receiving ACE inhibitor or ARBs should be started on ARNI, but that is not the current concept. If the patient is treatment naive also, you should start on ARNI. If your patient is on a good dose of ACE or ARB, like a 10 milligram per day of ACE inhibitor or a 160 milligram of ARBs, you can directly start from a treatment of 100 milligram twice a day. But there are some limitations if the patient is treatment naive or not on this dose of drug, or a patient is more than 75 years, or the patient has some hypotension to start with. You should start just on the 50 milligram twice a day of ARNI. Next 2 weeks, you can go back again to the full dose of ARNI if there is no systemic hypotension or worsening renal failure or increase in potassium or creatinine. Role of ACE or ARB, only people who are not able to tolerate ARNI. Some people have a lower baseline blood pressure where ACE may be a better drug compared to ARNI, and later you can switch over to ARNI if the patient is able to tolerate a ACE inhibitor. Mineralocorticoid receptor antagonists are good drugs which you may be able to add later in the disease course, starting from 25 milligram per day and checking the creatinine and potassium. And if the patient potassium over a period of time is less than 4.8, you can move from 25 to 50 and over a period of time to 100 milligram per day. I will get on to the further slide where the newer non-steroidal MRAs like the Finrinon are currently in the race for having a place in the guideline. SGLT2 inhibitor need not talk much because we know it is one of the important drugs, not only in the heart failure population, in the patient with CAD, and in the patients with worsening heart failure or proteinuria, where we are using dapagliflozin and sotagliflozin if your creat clearance is up to 25. EMPA from various trials even has a place with a creat clearance of up to 15. So this is one important thing. Please. So as I already discussed, beta blocker, I think we have started from the era where the beta blockers were in the first in line. Now we do not talk much about beta blockers, neither in the hypertension nor much in the heart failure. But when you start beta blocker, you should be ready to increase to the maximum tolerable dose based on your heart rate. And the drugs you can, I do not think so that there are any drug which consider that you should use bisoprolol or you should use nebivolol or metoprolol or carvedilol. Each of these drugs, based on their patient comfortability, you are a young fellow or an old fellow, have a bronchial asthma or any other effect, any of these drugs can be used based on that regime. Diuretic, I have already discussed about the diuretic resistance, the add-on of other drugs, and how to break the diuretic resistance, and similarly the use of isosorbide dinitrate and a hydralazine. Ivabradine, if your patient is not an old patient, has a good heart rate, you can start directly from 5 milligram twice a day and can go to a maximum of 7.5 milligram twice a day. If you have a patient who is elderly with a age more than 75, you can start 2.5 milligram twice a day, and your target heart rate should be 70, if not more. Again, coming back to the vericiguat, it is a drug which should be started as at the first instant where your patient has a first hospitalization of the heart failure, or your patient is having any other thing like renal failure or low BP, where you are not comfortable starting any other drug but vericiguat, because it doesn't cause much hypotension. You should be only careful if a patient has significant anemia. So you can start with 2.5 once a day, but you should make sure that over the period of next 4 weeks, you should be able to reach a dose of at least 10 milligram, which is the maximum tolerable dose. Please. Again, going back to the same thing, I won't be repeating if this is the current indications of all of these drugs, and similar about the ARNI, when to start 50 milligram twice a day and when do you go for 100 milligram twice a day. Again, one important point is in a patient with severe renal impairment, creat clearance less than 15, and severe hepatic impairment, childbirth C, you should not use ARNI. Please. Now, it won't be a justice if I tell you about the when to start, but when not to give these drugs, because these are some important consideration about the ARNI. As we all know, if the patient is on ACE inhibitors, we should stop it for 36 hours because you already have an ACE component in that. See, similarly, if a patient has angioedema, similarly, because of the bradykinin component, pregnancy and lactation should not use. Severe hepatic and renal impairment should not use ARNI. And if a patient has significant hypotension and decompensation of heart failure with cardiogenic shock, should not use ARNI in this population. SGLT2 inhibitors, we know already about the side effects. One, it is not much approved for the use in type 1 diabetic because of the risk for ketoacidosis. Less than 25 for DAPA and SOTA, less than 15 for EMPA, we should not use SGLT2. If a patient has mycogenital infection, definitely should not use. Patients who are undergoing any severe, important high-risk surgery in the next 3 days, you should stop SGLT2 inhibitor because they may be fasting and are at increased risk of euglycemic ketosis. People who have severe renal infections or pyelonephritis, again, should not use, but it's not an absolute contraindication. Again, very rare with the use of canagliflozin, we had seen necrotizing fasciitis of the perineum, or called as the Fournier's. Very, very rare side effects, not seen much in the practice. But urosepsis, pyelonephritis, and worsening AKI, where the patient has some acute insult and renal failure, should not use a SGLT2 inhibitor at that point of time. Ivabradine doesn't have, we have a feeling that it's a very safe drug, but there are a group of indications where we should not use it. And these are the angina with preserved ejection fraction, atrial flutter, atrial fibrillation, patient already having a long QT syndrome and a low resting heart rate, and severe sick sinus syndrome, which inhibits its use. Vericiguat usually doesn't cause much hypotension. So even with a systolic BP of around 90 to 95, without symptoms, you may be able to comfortably use vericiguat. Only in patient with severe anemia, we should be little careful with the use of vericiguat. Please. Now, I was searching what to talk about heart failure because I think most of this you should have already heard. So what is new in heart failure? Then I started searching my Google pages from 1 to 10 and beyond and saw the updates and what. So there are something which we do not talk much, but still has a role in heart failure. And the first drug, what we should think is the semaglutide in preserved ejection fraction. A lot of evidence has come from the use of semaglutide in preserved ejection fraction. So in patients with heart failure with preserved ejection fraction and obesity, therapy with semaglutide and lifestyle interventions for weight loss, rather than lifestyle alone, has in patient with higher BMI, has more benefit from GLP agonist therapy than those with a lower BMI. So this is something which is coming on, and the recent SOUL trial which is coming has an important role. Only thing we are not sure whether we can use in reduced ejection fraction, because this drug also have a role in increasing heart rate, causing tachycardia, which has an impact in heart failure with reduced EF. Then we have moved to the role of aficamten. We have already heard about the role of mavacamten in heart failure, which has a mortality benefit in patients with LVOT obstruction, hypertrophic cardiomyopathy. Aficamten is another group of drug. It doesn't have much role in mortality benefit, but it definitely improves the symptoms, quality of life, in the patient with hypertrophic cardiomyopathy with LVOT obstruction, though the rates of atrial fibrillation are not as high as patient with mavacamten. Acoramidis is the next treatment for the patient with ATTR amyloidosis. We have talked a lot about tafamidis in patients with heart failure because of ATTR amyloid. Acoramidis is another group of patients. However, again, unlike tafamidis, it doesn't reduce mortality compared to the tafamidis, but the future we may see this drug coming in heart failure. The drug which I was talking about was the Finrenon, which is a non-steroidal mineralocorticoid receptor antagonist. It has already started coming into our guidelines 2B, 2A, and slowly in some of the guideline, it will find its way to class 1, because in patients who are already receiving optimal therapy with diuretic, SGLT2 inhibitor, without semaglutide, class 2 to 3 heart failure, adding a Finrenon will definitely reduce the progression of EGFR, decrease the progression of EGFR. Please. Now, what other things which are new? Maybe smartphones for the heart failure diagnosis. Then again, as I discussed, mineralocorticoid receptor antagonist and worsening renal function. Now we are talking a lot about primary prevention and ICD, where the role of ICD in ischemic cardiomyopathy and non-ischemic with EF less than 35. But there are fewer current trials which says that if your EF is around more than 35 but still less than 40, the role of ICD may not be much, and should we defer ICD in such patient? Moving to the patient need for mitral valve interventions, mitral valve replacement in patients with moderate to severe functional mitral regurgitation, where the role of MTR may be there. This slide, again, I have already discussed about the what is new in the epidemiology, what is new in the pathophysiology of heart failure, comorbidities. Again, the role of semaglutide in preserved ejection fraction, SGLT2 inhibitors in heart failure, the DAPA-CKD, the EMPA-CKD trials, and also the iron supplementation from AFFIRM-HF and Ironman trials. Regarding the diagnosis and the therapy, already discussed, and the monitoring, I'll discuss in the next few slides, please. So, in the last slide, as I told you, the DAPA-CKD, EMPA-CKD, and the meta-analysis of this has showed that these drugs definitely have a role in decreasing the progression of EGFR apart from its mortality benefits in patients with chronic kidney disease. And so is the fidelity, which is about the Finrenon pooled meta-analysis, which has again showed that in patients with renal failure, Finrenon is associated with not only mortality benefit, but decreases the progression of EGFR. As I discussed, the iron therapy has gained a position from class 2A to class 1 in the recent guidelines. And this has been proved by the AFFIRM-AHF, the Ironman, and the heart failure HD trials. Advances has gone to that level that we are now talking about the left atrial pressure sensor, IVC area sensors, pulmonary artery sensors, to find out whether the patient's pulmonary artery compliance or resistance has decreased in patient. And this is actually, we have already seen in our CRTs and ICDs, they have a remote monitoring which can see the thoracic impedance and find how much volume overload is the patient. So the newer implants which have a remote monitoring sensor, I think we should use all that to at least know, is our patient doing well, and is the thoracic impedance is low, we know that the need of diuretic may not be much. Again, the repetition of the same thing, the use of the drugs like the MRAs, semaglutide. The newer drugs are the in ATTR, maybe vutrisiran, efficamten in HOCM. MTR is one, again in patients with functional mitral regurgitation, the role of valve replacement therapy. Now, once we have reached the optimum dose of this drug, how do we achieve the optimal therapy, and how do we know whether our patient is doing well based on your filling pressures and the biomarkers? Next slide, please. I think the important take home from this message is, if your patient is doing well and is not euvolemic, in that patient over a period of 3 months, you should be on your full dose of your medical therapy, including a 200 milligram of beta blocker if a metoprolol, 100 milligram of aldactone, SGLT2 inhibitors, and your ARNI, 200 milligram or 100 milligram twice a day. So at the end of 3 months, you have to decide now whether your EF is still more than 35 or less than 35. If it is less than 35 on 3 months of optimal therapy, this is where the role of heart failure specialist comes, and you should refer your patient to a heart failure specialist. If the patient is not euvolemic, then you may have to intensify the dose of diuretics. And once the patient is euvolemic, then intensify the other drugs. So when do I refer my patient for a heart failure specialist is, if you think the dose of intravenous inotrope, you are needing frequent hospitalization for IV inotropes or IV diuretics, that is the time you may have to think. So the mnemonic is I need help. I stands for intravenous inotropes. N for if the patient has worsening heart failure over 3 months, NYHA 2 to 3 to 4, multiple hospitalization, your NT-proBNPs are not decreasing. E stands for end organ dysfunction, the worsening renal failure, the cardiorenal is worsening. Ejection fraction at the end of 3 months is still less than 35. If the patient is on ICD, you are getting recurrent defibrillator shocks or having a more than one hospitalization over the previous 3 months. Edema despite the high dose of diuretic, which is the more than 80 milligram of furosemide on chlorthalidone hydrochlorothiazide or plus minus acetazolamide. Low BP always has some form of low BP and high heart rate. The heart rates are not getting controlled even on optimal dose of ivabradine or beta blocker, and on prognostication medication that you're not able to give the full dose of the drugs because of a lower BP. So these are the patient who should be referred for a heart failure specialist. Please. So that is what the next question is. Now, is it the time to refer to a heart failure specialist? So apart from this, there are other indications that if you have a bad coronary anatomy, you need to refer for a revascularization, or you have to decide that the MRI doesn't show the viability, then what should I do next for this patient? Also, if you have a patient who may benefit from a valve repair or a valve replacement, or the management of severe MR using a mitral valve or a mitra clip, those type of indications, then you should definitely refer a patient to a heart failure specialist. If you think that patient needs a advanced therapy like a cardiac transplant, patient is not getting benefit with any of this, then you have to immediately refer for a heart failure specialist. Or any other new heart failure where you think that the patient may need endomyocardial biopsy, or like a giant cell fulminant eosinophilic myocarditis, diseases like the anthracycline toxicity where a endomyocardial biopsy is a must. These are the patients you should refer to a heart failure specialist. Not forgetting the need for indications like ICD or a CRT placement. Now, the optimized care coordination. Now, this is something very important. You should know the essential skills of a heart failure team and what infrastructure we need. Like most of our heart failure clinics have handwritten records. I think we should start replacing with the electronic records. Like we should have a preformed proforma and start filling those proforma for all the patients using a electronic record. Monitoring devices, as I told you, apart from your weighing, scaling, weighing machines and all your implants should have a remote monitoring of heart failure. We should give them the option that these are the devices, you should go for that, because this is how is the future, the remote monitoring of heart failure. Wearable activity monitors and the smartphones and other mobile technologies we should use to monitor the patient weight and diet and other things. Now, to improve adherence, what to be done? Now, there are many things we can do to improve the adherence. And I actually, it is not, I may not tell you all the things because we know what are those things. So it starts with patient's perspective. You have to think about each time about how to make the modification in the medication. The first time when the patient starts the admission, I think you should be on put all the 4 pillars of heart failure, because that is the best window where you can start the treatment. The next time patient comes on outpatient, it may be difficult to initiate those therapies together. So start all the therapies, then you can titrate on outpatient basis the management. Patient's perspective is very important, because you should also know the medication regimen, especially in older patient, cost and access, the need for, I think we have moved to a stage where we now get the medications which are at the lower cost, polypill, polypharmacy. Those are the things which we should consider apart from the behavioral support and all these things. These are the things which I need not tell, but they are the important component of improving the adherence in heart failure. Now, coming to the specific patient cohorts, the African American population, older adults, and people living with frailty. So this is one important thing which all the heart failure things in the African American cohorts, more than ACE inhibitors, it is the isosorbide dinitrate and the isolazine, which has a better role in heart failure. Now, but still, whether ARNI is better compared to the isolazine or isosorbide hydralazine is still, and definitely the current evidence is ARNI is definitely better than isolazine in this cohort. So in older patients, we should also think about the things like hyponatremia, potential falls, worsening renal function, polypharmacy, financial toxicity, and our guideline directed therapy should be based on that. And similarly, in patients with frailty, how to manage comorbidities. Heart failure doesn't come alone. It comes with together with the comorbidities, which includes, please. So these are so many comorbidities which you have to manage in a patient with heart failure. Coronary artery disease, as I discussed, you should know when to send for revascularization, management of atrial fibrillation. Do you need AV node ablation, pacemaker, CRTs? Do you need cardioversion in such patient? Mitral regurgitation, the role for mitral valve repair replacement, or in elderly patient, the need for replacement or a mitral clip. Aortic stenosis, how do you manage in elderly patients with heart failure? The need for low flow, low gradient AS, how do we diagnose and what to be done? Surgery versus TAVR. Hypertension management in heart failure is again an important consideration, and so is the dyslipidemia, peripheral vascular disease, and cerebrovascular disease. The how to manage chronic lung disease, thyroid disorders, viral infections, diabetes, as we discussed much about the role of SGLT2 inhibitor, GLP-1 analogs, chronic kidney disease, the lot of discussed about the drugs, dapagliflozin, EMPA, and the sotagliflozin. Sleep disorder breathing is not talked much. All the patients with heart failure should undergo a sleep disorder breathing, because almost 40 to 50% may have a central sleep apnea in this population, and treating this may have prognostic implications. Iron deficiency is already discussed. All the patients with heart failure should have an iron profile and being treated if they have an absolute or relative iron deficiency. Malnutrition, anemia, hyperkalemia, the role of finerenone, and obesity and heart failure are further important things. So what are the guiding principles from our talk? This includes the GDMT is the foundation of heart failure, and GDMT with highest expected benefit should be prioritized based on the evidence and the guidelines. Target doses are associated with the best outcomes. You may not think that I have started the patient on a given drug, now my role is over. You should be able to reach the full dose or the titrated dose of that drug to give the adequate benefit to the patient. Start GDMT immediately and titrate during each counter. Every counter you have to see that which drug I can increase on that based on the heart rate, renal failure, or potassium and other things or variables. Attention to the clinical, social, and financial barriers to achieve the GDMT, which includes, I'm not sure in our countries, we have received a lot of generic medications which have now replaced the higher version of this based on their bioequivalence and all other things. Diligent management of volume status based on the diuretic dosage, the diuretic resistance, and the use of newer drugs should be there. Tolerability and side effect depends in part on how and when GDMT is prescribed. Primary prevention of with ICDs and CRTs should be considered if on optimum dose of all the GDMT at 3 to 6 months, your EF still remains less than 35%. Transcatheter, either the aortic valve replacement, mitral valve repair like the mitra clip, should be considered in patients with moderate to severe MR despite the optimum dose of the drug. Always should focus on patient symptom, functional capacity, and cardiac function. The value of a therapy to a patient is the combination of benefit and burden as they related to that patient's values, goal, and preference. And team-based care is critical to optimizing GDMT and may include frequent follow-up visit, telehealth visit, and remote monitoring. Thank you.
Thank you very much, Doctor, for the compelling talk. So now I would like to invite upon the stage our next speaker, Professor C.F. Otiano. So Professor C.F. Otiano is Associate Dean, Faculty of Health Science, University of Nairobi, Kenya. The topic for his lecture is renal complication of diabetes mellitus. Over to you, Doctor.
Cardiologists are very sophisticated. Diabetologists are very simple. Very, very simple. And I didn't know what the organizers had in mind, so I had a bit of leeway to look at renal complications my way. And a rallying call to the diabetologists who are here, because diabetologists are preventive cardiologists, they are preventive nephrologists, they are social scientists in education, they are neurologists, they're everything. So I have opted to look at this with a lot of emphasis on albuminuria, because again, diabetic kidney disease is so heterogeneous that you don't get much by just going into the fine details, biopsy and Kimmelstein kidney, and then comorbid acute glomerulonephritis or chronic glomerular disease and all that, or hypertensive nephrosclerosis. Now, who is diabetic, who is hypertensive, who is old age, who is aging and polycystic kidney disease that you see in aging, all that. And because I'm no nephrologist, I opted to steer clear before I am marked by nephrologists outside the room. So this is briefly the outline. They are back and forth. The focus is poor, but we are saying that in spite of what we are doing about diabetes care, the prevalence of kidney disease remains and is significant, about 20 to 40%, depending on your health grid. The definition, again, is predicated on an EGFR and albuminuria or both. And I opted not to go the EGFR way because it's not so much of a reporting schedule in many labs. They just give you a creatinine and the other things, then you opt to calculate or look at it and interpret. So I went for what is quite clear that we don't look at too often, but so significant because it touches what the cardiologist has just talked about, and it touches what the nephrologist would like to talk about. And the Steno group in 1985, thereabouts, proposed that when you see albuminuria, then it's a cardiovascular damage, marker of cardiovascular or endothelial damage. So then EGFR below 60 and albuminuria should be chronic kidney disease. Anything below that, albuminuria with low EGFR below 60 is chronic kidney disease, and it is a sign of many things. So that is what the KDIGO, the Kidney Disease Improving Global Outcomes, the KDIGO classification goes for. And you can see the initial ones just had EGFR going through normal, then from stage 3A, that is less than 60 EGFR, less than 60, 3A, 3B, and up to the end stage kidney disease. Then the recent times, especially the KDIGO guidelines, now load albuminuria, A1, A2, A3, and any albuminuria now is thought to mean bad things for the body, and therefore A1, A2, A3, but what used to be called microalbuminuria, the A2 and above, is actually more of severity grading, and any albuminuria means a lot. So it's like mild, moderate to severe, because they mean outcomes. We want to look at it in terms of if we now, from the beginning to the end of this talk, you perceive albuminuria and low eGFR below 60 as chronic kidney disease, then we want to look at it in terms of the risk factor profile, because in diabetology, these are the risk stratification approaches. So that you start with the modifiable risk factor of hyperglycemia, very well documented in type 1 disease. If you don't control sugar well, you can be sure over time and early enough, you'll get chronic kidney disease that can move into end-stage kidney disease. It's as predictable as that in type 1, and it is driven by hyperglycemia. Hypertension now in type 2 is so critical that at one point when your patient comes to you, is diabetic and is hypertensive, hypertension literally takes over the drive. And sugar is now like the fog that blurs the driving, but the hypertension is the perpetual driver of chronic kidney disease. So when there are two of them, hyperglycemia poorly controlled and hypertension also insufficiently controlled, then you are in serious danger. Dyslipidemia hasn't been particularly shown as documented as a critical factor, but if you look at it from the atherosclerotic cardiovascular disease perspective, the SHARP study didn't quite isolate dyslipidemia, but towards the end, I will tell you why dyslipidemia is significant. Then obesity and metabolic syndrome, very, very critical. The perinephric fat, just like the pericardial fat, are bad things. And these are features of obesity. The energetics, the energy metabolism in these individuals, if you go to the basic science studies, are interesting. They have not been particularly heavily studied, but their presence mean bad outcomes. Cardiologists will tell you about the pericardial fat. Similarly, the perinephric fat is a bad thing. And you will learn if you go read much more around it. The perinephric fat, pericardial fat are driven by sugars, refined sugars, including fructose for that matter. So when your patients tell you, I love fruits, fruit sugar is a driver of those perinephric, pericardial fat. Then of course, smoking, cigarette smoking, shisha, I know is a preference for some high maintenance ladies and young men, but it's not in that category. Then of course, I included the exposure to nephrotoxic agents, and critical here are non-steroidal anti-inflammatory drugs. So we talked about age, people who come with arthritis or pain for whatever nature, and whatever they take may give them. A lot of meta-analysis is trying to talk about some PPIs, especially omeprazole or esomeprazole, but still the jury is out there. Then the non-modifiable risk factors, old age, above 60, ethnicity, the Black African are much more vulnerable. Then when the women become honorary men, when they become after menopause, the risk factor profile seems to favor or not favor, but be a disadvantage to the women at that point. Then, of course, the family history, the ACE anti-converting enzyme insertion, deletion, and response to ACE inhibitors, lipo 1 as a existing genetic makeup, ApoE gene, and so a whole lot of them. Then, of course, non-modifiable longer duration of diabetes comes with that risk. So remember this story, because that's really the essence of our involvement. What can we change? What can't we change? And how do we use them for the benefit of our patients? So diet is critical. Diet, I'll summarize it quickly, that we are what we eat. And there's something now very prominent called the gut microbiome. The gut microbiome starts very early, and the most glucose uptake and glucose intake or starch intake and fat intake are very major influencers of gut microbiome. And then, of course, then the amount of protein. Sometimes people are not as privileged, but the amount of protein may not influence so much, but the fat especially seems to change that gut microbiome. So then it drives glycemic control, blood pressure control, weight management, and then, of course, the cholesterol. And down here, the digestibility of what you take in, that is fiber intake, is so critical, extremely critical, because then that is where the gut microbiota lives. And then later in chronic kidney disease, then the tryptophan and other amino acids are so critical, because when the gut microbiome is unfavorable, they actually break down the tryptophan to the uremic toxins that you have always talked about. When you say uremia, some of them actually, most of them actually come from the gut, as converted by the gut microbiome. And the nephrologists who are here can tell you about the tryptophan, about p-cressyl and indoxyl sulfate as critical gut microbiome sources that are very strong progressors of kidney disease. So that's diet. Then, of course, when you say the prognostic, that the nutritional intake or patterns of patients have significant determination or influence on the outcomes of kidney. And then you can see from that slide, they call it prognostic nutritional index as a risk factor for, and the prognostic nutritional index is calculated from other processes. But I just wanted to highlight the role of nutrition here, that you can go ahead and do what you call prognostic nutritional index calculation to determine, because it has a bearing sorry, that's an alarm. Sometimes I don't know whether I'm supposed to wake up at midday, but it's okay. Yes. So then this is a pathophysiologic background. Like I told you, when the science is there, you use it to understand many things that happen. And at the roof, I said metabolic glucose predominantly, hemodynamic blood pressure. And then they find a common level that comes down to change the permeability, the perfusion, and therefore the intrarenal response to those hemodynamic and metabolic challenges. And they come to produce these key cytokines that are fibrogenic, that whatever they do, hemodynamic, the intrarenal pressure challenges, and metabolic reactive oxygen series, they express themselves as cytokine production, predominantly transforming growth factor beta and VEGF, which are fibrogenic. And then once they change the increased extracellular, they change the extracellular matrix, then those now cause permeability changes. And those permeability changes, if they are glomerular, they give you nephrotic like. But once you start with that protein leakage from the glomerulus, then down at the proximal convoluted tubule, then you get those glomerular tubular feedback mechanisms that interfere with the permeability, and that protein load also goes to damage the tubular, the proximal convoluted tubules, and that protein is what you see, and that's the bad protein that brings issues. There's the protein of nephrotic that may have its own consequences, but the protein in diabetes is the proximal convoluted tubular protein, and that is a sign of bad things because the proximal convoluted tubule is a very, very loaded system with a lot of influence on energy feedback, that is glucose reabsorption and status of the metabolism, and many other things that we may not go into. But electrolytes, glucose, and all that, you know, happens there. Sodium, glucose exchange, a lot of things. Let me not go into that direction. So then, what are the consequences? Again, grossly, the people who love the science can go ahead but grossly, the metabolic disturbance, we've talked about hemodynamic, we've talked about. Then the other bit that makes treatment of these patients very difficult is the inflammatory bit. And that inflammatory is a consequence of interactions here, and there's also a lot of what is very individual specific, the genes and those other behavioral dietary discretions that now alters the internal systems of response. So then the metabolic disturbance we know about, the hemodynamic we know about, and we actually treat them. But then the thresholds and the amount of inflammatory response of each individual may vary significantly based on the genes and the behavior of diet that we have talked about. And the inflammatory factors are these. These are general, but interleukin 18 is interesting because it's been used as a marker of kidney damage, especially acute kidney injury. The tumor necrosis factor is critical, but has been more in the type 1 that people, you can read about them. But here, the connective tissue growth factor, transforming growth factor have been very, very important in the pathogenetic profile or process of type 2 disease. And then, of course, type 2 diabetes and diabetic kidney disease. Then those are now the issues that challenge the kidney to shrink, to become fibrous, and then eventually go into that contracted kidney. But the hyperfiltration phase is where the kidney gets more almost hyperplastic in order to accommodate the hyperglycemia and how the body gets rid of that extra glucose. And hyperfiltration phase is also a defining phase of the subsequent kidney damage. Next, yes. So this is just a summary of what we've talked about. Hemodynamic. This is what the hemodynamic raises, the transforming growth factor beta. Then, of course, the metabolic, predominantly advanced glycation end products, the AGEs. Then reactive oxygen series, because when the sugar is excess, there's abnormal metabolism. Then the the inflammatory phase, transforming growth factor is still critical. And then healing with fibrosis, those are the products. So intracellularly, distally, they initiate that process, and that as a consequence of glomerular damage, mesangial expansion, and protein leakage, tubulointerstitial fibrosis that we've talked about, then the other fibrotic processes. The Kimmel-Wilson kidney is typical of finding all these. But like I said, the way we behave in terms of diet, pressure control, adherence, and all those things make us develop these things at different rates in different mixtures. So that the combination of risk factors, therefore, the risk factor loading, their presence and then loading and duration of exposure will determine the magnitude of what we are seeing as the end product. Next. So then this is the omics, and there are too many things in terms of looking for markers, what we call the biomarkers, the clinical laboratory biomarkers that can help us do prediction early in terms of that continuum that Professor Sedat from Mozambique talked about in terms of the stages of primary to tertiary preventive approaches. So these are things that people, the phosphatinins there, the 21, the 23, even von Willebrand's, but you can see the where the coloring is strong is where you can see the cystatin C is actually being used as a product that the kidney processes very successfully, and you can use it actually to calculate the EGFR, and that's what it is. The N galactin, the fatty acid binding protein, the NT-protein. So the cardio and renal links are very strong, and that's why the cardio-renal risk profile for survival of the patient is both a personal affair for the patient and the doctor, and a public health affair for the governments and the communities. Again, this is now cellular contribution. Bone marrow is a very interesting player in this, and you had the cardiologist telling you about iron. Erythropoietin, iron, and the heart, erythropoietin, and the kidney, and the marrow. This is a long story, but the rest are significant players. The mesenchymal stem cells, the nephrologist will tell you about the mesenchymal cell transformation, epithelial to mesenchymal cell transformation, as promoted by the internal milieu of that cytokine response. So the cardiorenal syndrome, you can see the coronary artery disease when patients have a coronary artery disease, there is a percentage that also seems to have some chronic kidney disease. When they develop acute MI, that goes up. And when they go into heart failure, then the kidney component comes in. So I want us to move together as you see coexisting diseases. You also think about that risk factor profile, so that the control of the primary prevention before you get into this is going hand in hand. And you recall our first talk earlier, multiple risk factor reduction approach. So this is just a spline overview just to tell you how the risk factors behave. The more you move on the weight, the higher you get on the risk of developing the diseases. And then, of course, the LDL, but you can see the spread Triglycerides, I will tell you something towards the end about it. Then systolic blood pressure, you notice, is almost linear. Actually, it's as good as linear. The higher you go, the risky it is. But you can see even retrograde hypertension also comes with its own challenges. So the other important thing that people don't talk about is uric acid, also a nephrotoxic component. You see more of it in metabolic syndrome, but you look for it because sometimes when everything else is well, I have a patient whose pressure is well controlled, sugar is good, but his uric acid is on the higher side. Even when we've given him some febuxostat, he still persistently seems to be, within the last 2.5 years, 2 years, his proteinuria has moved up, and his serum creatinine has moved from about 125, it's going towards 200, but it's driven by uric acid, even when his blood pressure is actually about systolic about 125, diastolic of 70, sugar is beautifully controlled, A1C of about 6.5 to 7 or 7.2. So uric acid driven, but that might not be the only one because he's 65 years old. And I'm wondering, why should this uric acid sufficiently treated, but not normalizing? Again, at 65, his LDH is good. I'm looking for a high cell turnover. And at that age, malignancy or myeloma may be a critical thing. But you take them slowly. They are already happy with the sugar. You cannot start telling them that you may be having another cancer. We've looked at the outlet obstruction, and PSA is good because sometimes obstructive uropathy also seems to work against whatever else you are doing. Either it is PSA or neurogenic bladder or something else. So yes, so this is now the risk contribution, and this is a summary of the risk contribution of, you see HDL, in a normal one is mitigating, but anything that side is a negative risk for the causation of kidney disease. BMI, A1C, systolic blood pressure, even diastolic, yes. Total cholesterol, neutral, triglyceride, a bit of it, and I will come to that later and towards the end. Then, of course, LDL increase and uric acid, as you can see, the contribution. The beauty of this is not rocket science. These are things you can do in a clinic setting. If you risk stratify your patients or you see them in their phenotypes and you do these basics, you can actually achieve so much. So this is, it's something I used to see and ignored, said people are trying many things in diabetology. So then I have some old data that I'm working on that we'll talk about at the last minute in one slide. Triglyceride glucose index, reported by a team of one Brazilian and some other people, and it's becoming so prominent as a marker of insulin resistance. The triglyceride glucose index. The original one used to be a calculation of fasting insulin and many other things. The HOMA, IR, HOMA B, HOMA, whatever. But this one is so simple. The log of triglyceride, fasting triglyceride in milligrams and fasting blood glucose. And I had data, but they were generated way back in about 2017, 2018. And this was just coming, so it was being tried. So as part of my data that I'll talk about, I don't have the whole data, but just a summary. This has become a very prominent marker of insulin resistance that you can actually use on your patients. But you can see what it tells you. If insulin resistance is related to glomerular hyperfiltration, the podocyte damage, inflammation we've talked about, and the tubulointerstitial damage, then it must be a good marker that we can try using. Again, this is telling us so much in terms of when you have diastolic hypertension, that is how high the risk loading, or that's the additional risk above 30% additional risk, but you can see the confidence interval is anything between 6 to 62% increase. Hypertension, isolated systolic hypertension adds a risk by 36%, and you can see the interval, confidence interval of 12 to 64%. And then combined systolic and diastolic hypertension, this is critical damage because your patients, the elderly may come with 150 over 70, or 150 or 160 over 80. But if you look at the Framingham studies of the 70s, they were the first studies that showed a linear association of stroke with systolic hypertension. But this message is critical, that if you have a pressure of 150/90 or 140/90 or 145/92, that is now systolic, diastolic hypertension, and it adds the risk by up to 40%. And then, of course, that when you add it to the triglyceride glucose index, that is now insulin resistance, that is additional information. So that slowing kidney disease progression is a very important therapeutic goal. In that primary preventive, you have diabetes, which you have not prevented or you can't prevent. But if you have the patient before you, when you have the patient before you, then you can control pressure, you can control sugar to prevent chronic kidney disease, both in its onset or if it is already there early, you can slow the progression. So that should be a very important therapeutic goal for us. Hypertension control, therefore, is paramount. And we now know the ARBs, AC inhibitors, are critical in this regard because they have unique mitigatory effects within the kidney itself, as well as blood pressure lowering. Hyperglycemia control is critical, and we agreed in the morning that SGLT2 are very paramount here, but also GLP-1 receptor agonists, in as much as the lower insulin resistance that I've just hinted to you about are very important therapeutic choices at that level. We now know that SGLT2 inhibitors, GLP-1 receptor agonists reduce albuminuria. And of course, the ARB AC inhibitors from renal study, demand study, ABCD studies, OVO, were demonstrated the therapeutic gains of ARBs and AC inhibitors. So that when you control sugar, you have agents. When you control pressure, you have agents that you can combine strategically to reduce albuminuria that we said is a marker of endothelial damage and therefore an overall cardiovascular marker of risk and damage. Because patients with eGFR below 60 and albuminuria have very high event rates and mortality rates. So I've added hyperuricemia reduction and an address of triglyceride glucose index as a marker of early chronic kidney disease. So then this was a study that was looking at the causes of rapid decline in kidney function. And then, of course, the contributions came from pressure, glucose, protein, and anemia. And you can see anemia encroaching on the heart, as the previous speaker gave you, and anemia, the nephrologist will tell you. So these are established. You can see the pressures there. The higher you go on the systolic, the higher the risk of progression. And similarly on A1C, and then of course, hemoglobin, proteinuria as well. And these are modifiable risk factors. And this is the same story given to you. And the risk of progression declines when you control your pressures well. So that is also extremely important, and they are modifiable from where we started. Again, this is now adherence to therapy, that people not taking blood pressure lowering medication, you can see if they have normal pressure, they're okay, if that is the relative. But once they have elevated pressures and they don't take their medicines, then the risk of progression is even higher. So adherence in the process of communicating with your patients, that is important. But you can see the difference. When people are taking blood pressure lowering medications, then the risks are much lower. In fact, if they're in stage 1 hypertension, then they are even better, much better than somebody who is taking drugs for stage 2 hypertension. The risk is lowered compared to this, which is more than 2 times risk of progression, and that one is much less. So adherence to therapy, very critical, and you as the care provider should actually be at the center of this. But of course, this is in relation to the proteinuria reduction. And again, the dipstick that you can use for monitoring. Again, this is the trajectories, but another thing about kidney disease in diabetes. In our clinic in Kenyatta, we have seen 3 phenotypes. But again, this is a crude. Crude in the sense that we get, one of my students did now progression. We found slow progressors, intermediate progressors, and rapid progressors. The rapid decliners, within a year, you could actually see the eGFRs declining very, very rapidly and losing up to about 4 to 8 milliliters per whatever of the eGFR within a year. We could not establish the reasons for this rapid progression, but this is the world over. And sometimes it's in the context of your care, so that there are people who, because we don't care for them very well, that might happen, yet they are the vulnerable group of people. So it is important, again, to try and categorize your patients and monitor them. And you can see now I'm implying the conflict in guidelines, that you can see your patients that do proteinuria once in a year or annually. You can do a UND or the renal function profile annually. How would you pick progression if you did it annually? So you can see how consensus guidelines sometimes can be very misleading because that is a public health approach. But next, let's just move on. Actually, many slides, but that's just the same story we have given. Fast decliners, intermediate decliners, and moderate or sometimes slow decliners. But like I said, nephrotoxic agents pressure control, sugar control, and habits like smoking, aging are important things to look at and choose what you can modify. Next. So this is largely what I was talking about, that if you have uricemia and the odds ratio of, you can see high pressure and hyperuricemia events rate, hyperuricemia, pressure, events rate, and all that. So then you need to control your risk factor profile in their numbers and control it well. Because then, if you don't, especially hyperuricemia, blood pressure, then the proteinuria persists. And proteinuria, we have agreed, is the marker of underlying endothelial damage and associated with mortality, both cardiac and renal or cardiorenal. Next. This is largely the same, where you have hypertension, diastolic or systolic. When it is both, the risk of proteinuria, heavy proteinuria is highest, and it reduces as the pressure are normal, both, and if that is the referent, then if you go up on diastolic, you can still see, even with normal systolic, you are raising your proteinuria by 26%. If now the diastolic is normal, but you have a systolic high, that is what it means. But you can see if the diastolic is very high, systolic is also very high. That is what you see in terms of proteinuria. So risk factor control, very critical, and as many as you can. Next. Same, next. There were too many slides, so we need to move faster. Next. So then this is albuminuria. There must be a better slide than this. This looks, or you'll see it later. But that is how albuminuria is serious. Toxin, tubulointerstitial damage, and when you control it, control it well, you get maximum benefits. Next. This is now the mechanism of what we've been talking about, and we have talked about it earlier. Insulin resistance is there, endothelial damage, cardiovascular disease, but they all feed into cardiovascular disease or proteinuria, and they are literally comparable from that pathophysiologic approach. Next, we've seen that. Next. Yes, this is the one that I was talking about. That this is how sensitive albuminuria is in predicting kidney damage and other outcomes. The data I have, the albuminuria is not as predictive as triglyceride glucose index. But my explanation is that it is not as predictive of kidney disease because it is in itself kidney disease. In fact, the area under the curve is just about 0.53, as opposed to this one that you are seeing is 0.8. And for me, albuminuria in our setup means kidney disease, period. Because these were patients that were basically asymptomatic diabetics. Then we find in the process of just looking, we were out to define the prevalence of cardiovascular risk factors. Then we took albuminuria. But now that has sensitized us to do something else that I will mention in summary. Next. So then what albuminuria therefore is telling us, because it's so easy to do with a dipstick, when you find it, it could be a measure of acute kidney disease or chronic kidney disease or high risk of heart failure or acute heart failure. So I'm using this opportunity to highlight the importance of doing a dipstick proteinuria. And its presence is both a risk, and if you do it frequent and see it increasing, is a mark or a marker of follow-up or progression or regression of risk, depending on what you're doing. If you get no proteinuria, then you're doing well. If you get less, you're also doing well. But if you see it increasing, then it is not a good sign. Next. So then, this is what we are saying, that when you have declining EGFR, you have a 67% chance of getting or of having a concomitant coronary artery disease or developing one if you didn't have. The risk of MI goes high. The risk of stroke, especially if it is pressure driven, is even higher. Then when you have albuminuria, you are talking about a combined increased risk, almost 100% cardiovascular mortality, even double that for heart failure in the women we talked about. So what are we saying? That albuminuria is a missing link of our patient care to tell chronic kidney disease, either its presence or its evolution or risk of progression, but its additional message is it is a marker of cardiovascular, atherosclerotic cardiovascular disease, and therefore it is something we should be looking for all those reasons that I've talked about. Next. And this is exactly the same thing that when you have it, the marker of decline in EGFR, when it progresses, it shows what you've just talked about, but above all, it portends mortality in your patients. So then, when you see albuminuria, it betrays predominantly a presence of diabetic kidney disease. But that doesn't mean that absence of albuminuria does not mean presence of kidney disease, because albuminuria is not always there. But when it is there, it means what we have talked about. And you can see the higher it goes, and you have albuminuria, mortality, impaired EGFR, additional, both, you can see what happens to your patients. Next, same thing in diabetics, when you have albuminuria, a change, and EGFR, you can see the hazard ratio, the event rates are very high, whether it is mortality or cardiovascular morbidity. And this is the same message in that table. Next one. And trying to give you the same message in multiple ways to see that if you have a low baseline proteinuria over years, the event rates, especially progression to kidney disease, is much lower. If the higher you get, the worse the progression. And this is the same thing that is demonstrated in that publication. Next. Literally the same cardiovascular events, and the higher the albuminuria and the EGFR, the higher the cardiovascular events, and that has also been replicated the other end of the spectrum in kidney events. So kidney and cardiovascular events, if you do albuminuria and calculate your EGFR, then you can actually risk stratify your patient. There is hope in intervention, and the hope is ARB, AC inhibitors, the finerenone, the SGLT2 inhibitors. They reduce pressure, proteinuria, and inflammation, so that your patients, when you review them, evaluate them, try and see if they're benefiting from that combination. There are too many studies around. I don't think I have, I picked many examples, but this is just the summary slide to show you that indeed the cardiologists gave you these as central, whether they were fantastic 2 or 3 or what, they're here. So cardiorenal approaches are fortified back to back. That finerenone is now in the market. SGLT2 inhibitors are now available. AC inhibitors, ARBs, for purposes of pressure control, reduction of proteinuria, and addressing the inflammation that we talked about in the pathophysiologic pathways. Next. So we've talked about that. And this is mechanistic in trying to slow down a comparison of the aldosterone and the non. This is the steroidal aldosterone antagonist, and then the non-steroidal mineralocorticoid type. And of course, these are the mechanisms involved in the benefits. And apart from the risk of hyperkalemia, they are beautiful agents in your therapeutic armamentarium. Next. This is now the evidence where you have DAPA. This is now SGLT2 inhibitors, DAPA, EMPA, and then of course, DAPA again in the liver, and then of course, both heart failure and the kidney disease, and their mitigating effect. The mechanisms are, again, meant to reduce the metabolic stress of reactive oxygen series, but at the same time, when you reduce the fluid, the reabsorption, then the intraglomerular pressures are also mitigated. So you achieve both hemodynamic and metabolic benefits in the treatment of the kidney component, but the heart, it is probably much more fine pressure, fine fluid, but the energy balance, depending on the molecule that is used by a stressed heart at that particular time, those agents are of benefit. And similar, so then there is the HbA1c glucose lowering mechanism, but also the intra-organ, intra-tissue benefits that we may not have sufficient time to talk about. Yeah, but then it prolongs the time for the kidney before it goes into complete failure. Again, that's largely the same, trying to just give you the confidence intervals of intervention as you change the albuminuria. And these are the agents. If you remember the irbesartan study, the amlodipine, the on-target, which used olmesartan, and diab-HICA, I think it used AC inhibitor. The advance also used, it addressed pressure and glucose. Then of course, the more you reduced the albumin using these approaches, the better the hazard ratios of progression went down in that range. Amlodipine achieves much more through effective 24-hour blood pressure reduction rather than specific address to the albuminuria. So you may add it because of its 24-hour cover of pressure control, plus the other agents that have effects, direct effects on albuminuria. So then you don't seem to achieve complete reversal or complete benefit because of that inflammation bit and unique in intra-individual approach or challenges. So then you can see how the immunoglobulins have been attempted to try and address that inflammation. But at what stage of disease evolution? We don't know, but these are the trials, and there are reported benefits on albuminuria. So then, what is the message? Multiple risk factor reduction simultaneously and sustained is the minimum. And there's evidence in the ABCD, appropriate blood pressure control in diabetes study that was in the 90s and early 2000. Then Steno 2, which was published initially 2003, then 2008, then 2021. That cohort added about 16 years to their life by modeling. So that is the standard approach. If you forget everything you have had, please remember that ABC, my students can bore you. ABC, airway, bleeding, whatever. I'm saying A1C, systolic blood pressure, cholesterol, and the other things. Then intensive glucose control lessens progression in type 1. That was shown in the DCCT trial. Then, of course, choice of antihypertensives is very critical. The monitoring of albuminuria and EGFR, extremely critical. But I'm asking, in who? In individuals at highest risk, but how often should we test? Which one spot albuminuria change is the best surrogate marker of change? So how would we optimize good outcomes in heterogeneous population of diabetes that we talked about earlier, who exhibit variability in responding to risk factor loading and variable progression patterns? Because it's either slow, intermediate, or fast. Who amongst those with those risk factors would respond? Those are questions that the young ones like Dr. Ndede from Kenya are going to pursue very, very vigorously, and Dorcas is also in the neighborhood. How often should individuals be seen or be reviewed? In our study, over 60% of our patients were seen once. Then the other 30 were seen twice. Then the other small percentage was seen either 3 times or 4 times. So what is the ideal time that you must review? And I'm asking this vis-a-vis the guidelines, which I'm told are lines that guide. That is the same thing that we showed you, but this now, when you do pressure reduction using those agents or in those studies, you will tell the difference. But over the time, we have been getting better. You remember that was sugar. This is pressure. This is again lipid study. And where's the HPS? The heart protection study, the one that lowered the LDL thresholds, but you can check much more. There are so many of them there. Now, it's like we've been talking about which butchery sells the best cut and all that. We are not talking about the cook. Thank God we are talking to the cooks. Models of care, the process of shared decision-making, integrated care rather than go to the kidney. But doctor, no, go to that kidney doctor. But I'm also feeling, I think that's the heart, go to the clinic. I was there, they booked me for in 6 months. It's okay, go and sort it out with them. And how do I go to the education? That's what we do to our patients. So that they're literally in the hospital every day, or as often as you can, but they don't receive care. They just directed to. So the diabetologists should be the ones who are the prevention nephrologists, preventive cardiologists. They are the educators. They are the who that patients. So that's why we're talking about models of care in a health system. And you're the ones who are going to give advice, and you're the ones who are going to optimize care before you refer to the cardiologist, as you are told, or before you refer to the nephrologist. Our nephrologists in Kenya are very good people. They chat with their patients very nicely, so their patients will share your review. The cardiologists don't talk to their patients that well. They are a fantastic who? Or six, or
Fabulous.
or fabulous six. So they're either fabulous or fantastic at the that guat. What was it? Verisi guat. You can count them, but at the end of it all, they cardiologists have, with due respect to them, our students don't examine patients. They just want echo and all that. So when the echo comes, it is either preserved ejection fraction or reduced ejection fraction, and they're looking for what to give and take those. And the cardiologist showed you how you dip, come up again after the word, dip again, and you can see the journey to the grave as before. So risk prediction, you must do what we call risk assessment. There's a good study in the Hong Kong study, the ramp series. I don't know which ramp it is, but it's a risk assessment of patients so that it will tell you how well you perform, and it will expand your view about what you do for your patients. Then the next thing is, even that ramp study did not segment their studies, their patients into who is high risk, intermediate risk, and low risk for cardiorenal disease, either in evolution or progression. So I'm asking, would this be a strategy? Now is actually a standard of care. If we haven't acquired it, then we must. But the way we work in our hospitals, there is no team. There is no clear-cut communication between the nurse who does the pressure for you, the educator who looks at the feet for you, the ophthalmologist who saw the patient once in a year as guidelines said, and told you this is, because sometimes they have their own different files there. Or the doctor said, I don't like those confused files. We have our records here. In fact, we are paperless, but the paperlessness is not communicated to the diabetologist who has papers where the nurse, the WHO, and whoever records. Because the nutritionist is peripheral, does his or her work, and then brings the paper into the main file. So that's now systemic health system affair. Predictive equations, how often do we use it? UKPDS had its own, Framingham has, and several other predictive equations. And longitudinal risk prediction of chronic kidney disease in diabetic patients using machine learning and AI designs. Do we have real-world longitudinal data in designs for point of care? Now, that's my imagination, and the little data that I have, that is what we are trying to do. We have, we want to present simultaneous risk prediction by giving those information bits that we talked about, modifiable risk factors, and of course the non-modifiable risk factors, and try and predict who is more at risk, higher risk. If you are too detailed, you get it wrong. If you're too shallow, you get it wrong. So we are trying to use those that we started off with, risk factor profile, to try and determine, yes, start with the family, determine individual risk. You do CKD screening using proteinuria, dipstick, and EGFR, and then determine whether there is a kidney disease or no kidney disease, and then you do your risk stratification. I already have the data for kidney. One of my students is doing for me the heart side, where they're going to define the heart endpoints. Then you've seen here that we actually share a lot of risk factor profile. The genes might vary, but we are going to say who is at a higher segment or at a higher risk. So give that upper segment. And these are people we may see differently for the heart or the kidney or cardio-renal combined, but still will be the diabetologist who is doing the bulk of this and share the care back and forth. Next. So what it's people are already trying to do this, but they are too detailed to the extent that I suspect they're going to be wrong, because echoes, we now know, even from the solved studies of 1986, that when you give AC OARBs, AC inhibitors OARBs, there is a left ventricular regression. And if they take, like we've shown you, they take their medicine well, the risk should actually reduce. But sometimes the things we do, we might maintain our patients at a certain risk level without a lot of, without a dynamic approach where they should be changing risk depending on what we are giving. But this is the cycle that you start with person, and then you take your history and clinical evaluation and a bit of lab, and then you use that to input that data into information and use it to phenotype your patients based on those biomarkers, either laboratory generated or clinically generated, and determine who is at high risk of developing complications, cardiorenal complications. So maybe we are moving towards the end. We are looking at a healthcare system where we want to make life easy with a patient flow sensitivity and segment those patients from what they have or what you have collected from them. And you, as the physician, you are there, and we want to kill that therapeutic inertia so that you don't just see everybody at the same time. But when the information flow is designed so that the doctor has literally everything, those multiple risk factors we are talking about, then you know what is driving this risk. And you can segment and say, high risk, intermediate risk, low risk. I'll see you in 6 months. I must see you in a month or in 2 months, depending on what is there, and gently given. I think we are moving towards the end now. There were too many. Yes, so I was saying my current work that made me give this talk this way is that we are trying to do a cardiorenal risk stratification. The kidney data is there. Where have we reached? We have reached a young man that is like my taxi driver. I tell him, I want this. So we are doing risk factor ranking. And how do we do it? You saw the curve of albuminuria. So we're doing area under the curve using random forests. I must confess, disclaimer, I am thoroughly analog. I don't like computers. So I tell the young man, this is what I want, and he does it for me. And it doesn't come out well. I say, no, we do it like this. So he does it, and then we have ranked. And that's how I learned that EGFR as a measure of kidney damage for our data is comparable with albuminuria for area under the curve. But the next high scoring value that was a risk stratifier was actually triglyceride glucose index. Major contribution into that risk loading, because now we are pulling risk factors to see which one is or will have the highest area under the curve, whose controls are critical. But it's also heartening, why I'm saying this, that systolic blood pressure, triglyceride glucose index, and albuminuria are already high on the list. Very easy to do things. There's no echo here, but the heart side has an echo, because we have to define the endpoint of the heart It's not clinical. It is the EGFR, the EF, and the diastolic dysfunction in these patients. So then we shall combine a cardiorenal with pooling of these patients and actually ask our system, machine learning, AI, to give you something that you look at and the touch of a button and say high risk, intermediate risk, low risk, driven by. So that is the work we are doing now with some young man, and actually two men. One is statistician, and the other young man is, he says, he's a computer wizard. So he's designing things. If they are not usable, I tell him that is out of context. But it is a self-sponsored project, and we hope that there will be innovation out of it to try and see if we can help ourselves in a daily clinic activity. Somebody enters that, but they are collected and a screen, and you can talk to your patient gently and well with everything in front of you, like a meal. We don't give you rice now for lunch and you come for your chicken at 4 p.m. and soup tomorrow in the morning, because you'll ask, how do I take this? And I request you to end there, even if there are other slides. Thank you very much.
Thank you very much, Professor C.F. Otiano, for the wonderful presentation. So now I request Dr. M. Sudhakar Rao, consultant cardiologist, Manipal Hospital, Manipal Academy of Higher Education, to address the area of evaluation and management of uncontrolled hypertension. Over to you, doctor.
Hello, welcome again. So this time I may not take much of your time because I may come between you and the lunch, and I'll try to mostly summarize it. The evaluation and management of uncontrolled hypertension. I think this is an important topic. I'll try to take you through two case presentations. So this is the outline of the topic. So this is the first case was of a 16-year-old boy, our own case, some 6-7 years back, presented with acute pulmonary edema, and BP was very high. When I say, I think 170 by 110, I know most of you knows it's a resistant hypertension. On full dose of metoprolol, prazosin, amlodipine, moxinidine, and furosemide, echo showed severe concentric left ventricular hypertrophy, no coarctation, EF normal, and persistent pulmonary edema refractory to treatment. And this is a second case, a 33-year-old radiologist, headache, fatigue, woken up by patients for sleeping halfway through, in threat of losing job, irritable, threat of losing wife, BMI of 33, sugars and lipids and RFT are normal, telmisartan, amlodipine, thiazides, again refractory hypertension, blames thiazide for his symptom, and the single investigation and therapy can keep the employer and the wife happy, and we know what is the diagnosis, but I'll come to it at the later end. So what is resistant hypertension? I think by most of you by now we know the definition. If the BP remains high on the optimum dose of 3 medications, and the one of them being a diuretic, the first will be a calcium channel blocker, the second will be a ARBs or the ACE, the third will be the diuretic, and the BP despite this remains more than 140 by 90, we call it resistant hypertension. So the goal of control based on current guidelines, ideally 3 agents, one of them being a diuretic. If your patient BP is controlled on this, it is called controlled resistant. 3 drugs, 1 diuretic, but BP is less than 130, 140 by 90, 130 by 80. It's called controlled resistant hypertension. Now, I won't go into detail. This was the definition which has changed over from the JNC 7, AHA. Currently, definition is 140 by 90 and more on 3 drugs, one being a diuretic. So we talk a lot about resistant hypertension, but we don't talk about refractory hypertension, which is uncontrolled on 5 or more class of drug. The 2 other agents are chlorthalidone and aldactone. It can be hydrochlorothiazide or chlorthalidone. plus aldactone and BP is still more than 140/90. That is refractory hypertension that represent only 10 to 20% of resistant hypertension. So the incidence of resistance is 1/10, that is 10% of all hypertensive, and in that also refractory is only 10% of resistant hypertension. Now, why we are talking so much about it? Let it be uncontrolled. What will happen? The chances of cardiovascular events, CAD, CVA, and heart failure are more. Target organ damage like albuminuria, as we discussed before, chronic kidney disease, and LVH are more. And they have a chances of CAD 2 times as compared to the essential hypertension according to the Framingham score. So if you see this slide, of all the uncontrolled hypertension, only 10% are resistant hypertension, and in that resistant, only 10% are refractory hypertension. So when we call uncontrolled hypertension, it can be because of inadequate treatment regimen, treatment inertia, patient is not taking proper adherence of the drug, doctor is not giving full dose of the optimum medical therapy, undetected secondary hypertension, which is 10% of all hypertension, or true treatment resistance, which is 10%. Next. Yeah. So at this point of time, before calling it resistant hypertension, you should rule out pseudo resistance. And when I call pseudo resistance, it can be any of this: improper blood pressure measurement, not patient has smoked, walked around, ran around and came to your OPD, not in a peace of mind, mental stress, not slept properly the prior day. Or it can be a white coat hypertension where at home his BP is good, but when he came to the office, the BPs are more than 140/90. And this is usually 37%. So how do we know it's white coat? You can just simple test, do a ambulatory BP monitoring. Put a 24-hour ambulatory BP monitoring, and you know whether in office and in the home, how are your blood pressure recording. And you can diagnose the white coat hypertension. Non-adherence is usually difficult to diagnose. Either you have to stand in front of the patient and give him BP medication, which is not possible, or practically what we do is see urine toxicological analysis, which is practically we do not do. It is about seen in 50% of the patient. And use the term apparent treatment resistant hypertension if you have no data on any of this. Okay. Now, how common is the resistant hypertension? If you see the criteria, 2 to 40% will fit, but grossly it is 10%. 5 to 10% of all hypertensive are treatment resistant. Now, why it is important? See, if you see of all the CKD patients, 37% were only controlled to 130/80. Of all the diabetics, 1/4 are only controlled. It is more common with systolic blood pressure than diastolic blood pressure, and 12 to 18% on clinic-based studies. That is probably they are apparent treatment resistant hypertension, as you can see in the slides. Now, why it is important? There are 5 important points why it is important. It increases the cardiovascular events by 2-fold, increases end-stage renal disease, ischemic heart disease, heart failure, and stroke. All are increased by almost 10 to 50%. Prognosis is impaired. Mortality is 6% in this group. Cardiovascular risk factors like diabetic, hypertension, sleep apnea, LVH, CKD is more with resistant hypertension. And it's worth intense therapy. When you see you have a treatment resistant hypertension, your target level should not be then 130, 140. It should be as low, 110 to 120 beyond your J curve for CAD. Now, how do I approach to a resistant hypertension? Now I know my patient is resistant. I have ruled out pseudo-resistant. I have ruled out other causes. How do I approach? So as I discussed with you, is it really resistant hypertension? Check the clinic blood pressure at appropriate time. Make him sit for some time. Make sure he's well, he slept well overnight and all. If you make sure your 3 recording and the 2 lower recordings you have to take, not the higher recording, the last 2 lower recording you have to take, then you rule out white coat. That is very difficult. If your patient is telling my home recordings are 110, 120, you are telling now it's 150. Tell him do an ambulatory BP monitoring. Do an ambulatory BP monitoring. If those are fine, now you have ruled out your resistant hypertension. After that non-adherence, it is very difficult to diagnose. Toxicological analysis. Make sure you have to ask him clearly, are you taking the drugs properly? Is he on full dose or optimum medical therapy? Not missing any of the drugs. If all the first three steps are correct, then you can call him resistant hypertension. So all this poor BP measurement technique, suboptimal therapy, poor adherence, white coat effect, and there is something called Osler's effect, what we used to call in our clinical cardiology, pseudo-resistant hypertension. This is mainly seen in older population, stiff arteries, Monkenberg's arteriosclerosis. How do you diagnose? If your cuff diastolic BP is more than 15 mm higher than the intra-arterial, most of the time we don't see intra-arterial, but if your cuff diastolic BP is more than 15 mm higher than intra-arterial, or you are getting a large pulse pressure, that is one important thing. Your pulse pressure is high. Then how do you know if your central pulse pressure is more than 55, or if you do an ambulatory BP monitoring and your pulse pressure is more than 63? This is one of the things where you can tell that my patient may have a pseudo hypertension, also known as Osler effect. It can be one of the cause of not a true resistant hypertension. And we don't see a carotid femoral pulse wave velocity more than 10. So the important thing is you're getting a high pulse pressure, think that you may have a Osler effect or a pseudo hypertension. Now, at this point of time, you should also see any correctable causes, like is the patient is taking the diet or a DAS diet, compliance to your salt and not, no intake of alcohol, no smoking, lack of sleep, drugs like, I'll show you the list, lack of drugs like NSAIDs and many other drugs, and then older age, the Osler effect, kidney disease, diabetes, high salt intake. So these are other factors which we should take into consideration before telling is a true resistant hypertension. And sometimes the genes matter. If you have mutation, back one slide back, if you don't take into consider, if you have a mutation in any of this ENaC, that is the Liddle syndrome, or a CYP3A51, again associated in African American patients, they have higher systolic blood cell. They are the things which may again have a pseudo resistant effect. So you may also have to take these things into consideration. Not very practical though. Next point. So these are the list of drug, a lot of list of drug, but important thing what you have to see is patients should not be on an NSAID drugs, steroids, antidepressants, cyclosporin, those type of drug, contraceptive drugs, sympathomimetic like the cocaine and all, and your alpha adrenal. Some people take nasal spray for the congestion, phenylephrine and all. So those type of things you have to rule out before calling it true resistant hypertension. Now 10% can have secondary hypertension. You have to rule out. Now when do you suspect secondary hypertension? Any patient less than 40 years of age, high BP, not getting controlled on the drug, that is the time you have to think of secondary hypertension. The common cause, as I told you, is obstructive sleep apnea. In any patient with young hypertension, one test you have to ask them is a sleep study. It's very common. 30 to 40% can have sleep apnea. It's a very easy test. If you diagnose mainly in obese patients, short neck and all, snoring in the night, early morning somnolence or decreased fatigue and all, do a sleep study, because that is one of the reversible causes of hypertension, resistant hypertension. Again, you may not miss this because all the patient will do a renal study. So creatinine, urine, albuminuria, severe. If you have a disproportionate LVH in a young patient, left ventricular hypertrophy, think of secondary hypertension. Some diseases are rare, like primary hyperaldosteronism. At that point of time, you have to think that if your patient BP is sodium is high, potassium is low, low potassium, low magnesium, high sodium, these are the time, or a metabolic alkalosis, high BP, you may have to think of primary hyperaldosteronism, where you may have to do plasma aldosterone to renin activity ratio and other metabolic factors which you may help him. Renal arteries, all the patient young hypertension, do a renal Doppler, see for a renal bruit. That is important thing. If you find you have a doubt, see for a renal bruit, do a renal artery Doppler. Easy test. It may give you some evidence of renal artery stenosis. Uncommon things are pheochromocytoma. We don't see commonly. Anxiety, palpitation, headache, episodic hypertension. Not a very common disease. Obesity and hypertension always rule out two things. Sleep apnea is one of the thing, and Cushing's disease. Easy test, early morning 8 a.m. cortisol level, or you can do a low dose dexamethasone suppressant test. It's very not very common to do a 8 a.m. cortisol level. Very high cortisol levels may give you an idea. Thyroid is the most common thing which we usually don't miss out. Hyperparathyroidism is very rare to cause resistant hypertension. Coarctation, if you suspect,
Hello.
I can talk. Yeah. So if your echo shows some, your clinical examination shows some murmur, the BP difference in the upper and lower limb, the BP difference between the two limbs, see for coarctation properly on your echocardiogram. So when to suspect? Now, this is some of the important clues. If your patient on ambulatory BP has less than absence of 10% nocturnal dipping, normally night you are supposed to have a dip of the blood pressure 10 mm systolic and at least 5% diastolic. If you have a non-dipping or a reverse dipping, you have to suspect things like sleep apnea, renal artery stenosis, renal failure, and primary hyperaldosteronism. Unexplained hypokalemia with metabolic alkalosis should be suspecting primary hyperaldosteronism. Flash pulmonary edema, suspect renal artery stenosis. Again, snoring, daytime sleepiness, headaches, poor concentration, sleep apnea, you have to suspect. Pediatric population, if you have a hypertension, one thing which you have to think is renal artery stenosis, which can, or a fibromuscular dysplasia causing renal artery stenosis. Obese patient and resistant hypertension, think about sleep apnea, think about Cushing syndrome, and think about hypothyroidism. If you have on your echo LVH, left atrial enlargement, and pulmonary artery hypertension, think about sleep apnea as one of the important causes. Next slide. So these are the key tests. In all the patient with resistant hypertension, young patient, high BP, apart from your echocardiogram to rule out coarctation, do a thyroid test, do a renal function test, 24-hour urine for urine metanephrines, or a simple plasma metanephrine whose sensitivity may not be high. Primary hyperaldosteronism, a small, simple test, serum aldosterone to renin angiotensin activity. One sleep study you can do, renal Doppler you can do, ultrasound to see for any renal parenchymal diseases. So these are 7 or 8 tests which are very easy tests to do to rule out a resistant or a secondary causes of hypertension. So what is abnormal? Just before going into very small, in a renal Doppler, if you see high peak systolic velocity, high acceleration time, and a resistive index is high, there are chances that 60% of stenosis you can pick up on that, means correlate with 60% stenosis. The sensitivity and specificity may not be high. If you have a doubt, you can correlate with MR angiogram. Primary hyperaldosteronism, if you do a aldosterone to renin activity ratio and the ratio is more than 30, or with a 20 with aldosterone levels more than 16, they are highly suggestive of primary hyperaldosteronism. You may have to do, if it is unilateral or bilateral to know, it may be done by CT or adrenal vein sampling. Pheochromocytoma, easy test, 24-hour urine metanephrines. Sometimes they may be false positive because of some other reasons. Cushing syndrome, early morning 8 AM cortisol, or overnight dexamethasone suppression test you may have to do. Hit heart and achieve target levels. So initially start with the current ones are ACE or ARB plus a calcium. We don't believe in single drug anymore. That is the concept. No single drug, except when you have a borderline cases, you want to start very young person, you may have to start, or very elderly person. These are the people where you may start single drug. In all other cases, there is no role for single drug at present. Start with ACE or ARB plus a calcium channel blocker, which is long acting. It can be anything. Plus a diuretic is the next line. Diuretic also, it depends on the dose. If your creat clearance is more than 30, you can choose a chlorthalidone. If you're more than 45, hydrochlorothiazide. But as per me, with the practical wo, chlorthalidone works better than hydrochlorothiazide because the BP reduction in the studies are more than the hydrochlorothiazide and longer duration of action. The maxima is the diuretic therapy. After these 3 drugs, if sometime your BPs are still not at target, the drugs like beta blocker or aldosterone antagonist are a good drug. Because if your mechanism is hyperaldosteronism, then your aldactone can have spironolactone can have a good effect. Start with 50 milligram, can go up to 50, 25, 50, and 100. Beta blockers are one drug where, again, you can have, in young people, be careful with your drugs like metoprolol. Better choose a drug like nebivolol or a bisoprolol, which has a lesser effect on sexual woe, which has a decreased effect on lipids, depressive effects and all. So the drugs like bisoprolol are and nebivolol are better than metoprolol. They are very selective. The selectiveness is quite more compared to carvedilol and metoprolol. And combine agents with different mechanism of action that I'll come on to it. So this was one of the older studies which showed that if you have a patient with resistant hypertension, the addition of a aldosterone receptor antagonist may have a very good role, because some of this patient may have hyperaldosteronism as an important pathophysiology, where this drug can have a good benefit starting from 25 milligram going up to 100 milligram. Now, patient with true resistant hypertension uncontrolled on standard triple therapy. When I mean triple therapy, these are calcium channel blocker full dose, ARBs full dose, and diuretics. This diuretic can be a chlorthalidone or hydrochlorothiazide. We do not prefer furosemide directly as the first choice of antihypertensive in most of the agents. Now, if your dose is optimized, sometime what we do is, if your chlorthalidone is not working, we change over to hydrochlor or the reverse, vice versa. Add spironolactone is the next drug. The next best thing after the triple therapy will be a spironolactone, and can go up to the maximum of 100 milligram. And still, if your targets are not met, either you add beta blocker or you refer to a heart failure specialist, where other addition of the next drugs like a beta blocker or drugs like prazosin or drugs like minoxidil, or your drugs like direct vasodilators like the hydralazine and all will have a role. So let's see when to use the other 4 drugs. So now you are on a ACD combination, that is a ACE-ARB or calcium channel blocker and a diuretic, and you still have a resistant hypertension. And if your serum potassium levels are more than 4.5, double the dose of a thiazide like diuretic. And you can consider the addition of either a alpha blocker or a beta blocker. It depends on the old patient, PBH and all condition. You can add a young person and all, you can add beta blocker. CAD patient, beta blocker. Claudication and all, avoid beta blocker. So it depends on you. In the end, you may have to think of drug therapies like moxinidine, where the maximum dose you can go to the 600 microgram. If your potassium levels are low, you can think of drugs like MRAs, where you can start with 25 milligram and go up to the 100 milligram. Amiloride can be used in our clinical practice. We do not use amiloride much. Addition of a beta blocker is again one of the important considerations. We can go to the. So this is a very congested slide, but it actually tells if your BP is not on target on the triple therapy, or if you have already switched chlorthalidone and hydrochlorothiazide, addition of a mineralocorticoid receptor antagonist is already there up to maximum tolerable dose. Your heart rates were high, you have already added beta blockers like your nebivolol, metoprolol or a carvedilol, and the BP is not on target after this 4 to 5 drugs. You can either consider adding prazosin like drugs, or clonidine like drugs, or hydralazine like drugs, or a final addition of a minoxidil. So these are the next 4 drugs where on 5 drugs, your BPs are not met. ACE inhibitor, ARB, you have used calcium channel blocker, you have used a diuretic, you have used a mineralocorticoid receptor antagonist and a beta blocker. So it becomes a refractory hypertension. So at that point of time, the drugs are prazosin, moxinidine, minoxidil, and hydralazine. So still we have a large amount of drugs to be considered. There are 9 different drugs which we can consider after a refractory hypertension. So I am not going much to the individual dosing. I think by pharmacology, we know the most of the dose to be the clonidine, like the Moxovos type of drugs. We go up to 300 twice a day or 600 microgram daily. And other drugs, we know the dose. So I'll skip this slide, please. Important non-medical measurements are weight reduction. Your 5% reduction in weight can have an impact on to 5 to 8 mm Hg systolic. DASH diet, dietary approaches to stop hypertension, which actually has a low sodium diet, less than 2.5 gram per day, physical activities of 150 minutes per week, decreasing the alcohol, only moderate alcohol intake, potassium intake should be increased, and other therapies like meditation, yoga, and all other things can be considered. Now, problem with targets, as I discussed, too much coming down to targets less than 100, 110 may have an impact on J curve, mainly in the CAD group. The coronary perfusion may come down. This doesn't hold true for the cerebral or the renal curve. So as I discussed, 10% resistant or refractory to treatment. They tend to have higher sympathetic activity, higher heart rates, and higher systemic vascular resistance. So this was all about the medical management. Just 5 minutes to 10 minutes I'll take. How do we manage in future? Now, we are in the future. Now, what are the device-based interventions? There are a lot of being discussed about device-based intervention, carotid receptor stimulation to renal denervation, coupling arterial and vein, creating a fistula, and other things. Let's just discuss in short about those. So all these concepts have started when people were doing lumbar sympathectomy in the past, and they used to have a good reduction in blood pressure, hypotension. But the problems were the orthostatic hypotension was more, impotence, bladder bowel dysfunction. So because of this management had gone, people were using in the past, and now these are obsolete. And we have moved to device-based interventions, which includes one of them being a carotid receptor stimulation. There are 2-3 things people have gone, either put a carotid receptor stimulation in the bifurcation of the carotid body, or they have opened up the carotid and put up a devices which can stress the carotid receptors, causing a decrease in blood pressure. The most common what cardiologists do is renal denervation. It can either be a radio frequency based, which is the most common thing, or alcohol mediated, which is not done commonly. So the radio frequency based renal denervation currently is the best thing what we are doing for decreasing the systolic and the diastolic blood pressure. Other things have come, not being used much, are the central iliac arteriovenous coupler. It's just like creating an arteriovenous fistula. Your blood pressures may come down, but the problems with your RA pressures may increase, PA pressures may increase, pulmonary hypertension. These are the side effects. So I won't go into much. These are the problems why resistant hypertension was happening, because of the efferent sympathetic was causing the increased renin release, increased tubular sodium reabsorption, and decrease the renal blood flow. So we may have to find options where we can do renal denervation. So the true patients are the people who are actually on 4 to 5 drugs, still BPR 130, 180 and all. Their kidney renal functions are well preserved. In a CKD patient, decrease kidney size, we don't do renal denervation. Renal artery stenosis, already a renal stent, we don't do renal denervation. If you have ruled out everything, you find a suitable patient on 4 to 5 drugs, still BPs are high, patient has some albuminuria, high, good LVH. Those are the suitable patient for renal denervation. And the evidence has come from the spiral hypertension of Med trial. The initial studies were with the Simplicity 3 trial, where it was a failure. However, the subsequent trials showed that it had a significant effect on renal denervation. The number of medications may reduce. Your BP can have effect from 5 mmHg to up to 30 mmHg reduction. Safety concerns were there initially of the renal stenosis, renal perforation, but it is very safe procedure to be trusted. And then we move to, not much about thing is discussed about this BAT therapy and carotid receptor stimulation. As I discussed, I won't go into detail. It was only about you have to stretch the carotid receptor, which cause a decrease in systolic blood pressure. It can be done percutaneously, or can be done by surgical. You have to put a carotid bulb expansion device. Next slide. And the final was the central AV fistula, creating a AV fistula. How did it work? One, it increases the ANP release, causing vasodilatation, increase the heart rate, and peripheral sympathetic inhibition. On the other side, it can increase the cardiac output and decrease the SVR. However, it came at increased cost of, it can cause the stenosis at the venous side. It can cause high output cardiac failure, pulmonary hypertension, right atrial pressures may increase, LVH may increase, it may cause Steele syndrome. So these were the various side effects, not talked much, still in the studies experimental way. And finally, a summary. I won't go into it. I think I have talked more about this. So your take-home message will be resistant hypertension, rule out pseudo-resistant, rule out other causes. If you have true resistant hypertension, we have a battery of drugs, 9 classes of drugs. You can reach the optimum dose of this, and consider interventional therapies only when you have a patient who has actually not been controlled on any of these drugs. Thank you.
Thank you very much, Dr. Sudhakar Rao, for this profound lecture. Let me now have the pleasure of inviting our next speaker, that is Dr. Omari Said Ubuguyu. He is Assistant Director and Head of Non-Communicable Disease Section, Member, and Board of Trustees, Ocean Road Cancer Institute, Ministry of Health, Tanzania. So, over to you, Doctor.
Asante, sir. I'm not sure if you can see me from the podium. I always hate this podium because people can't see me behind the podium. Okay, you see me. Okay, thank you very much. As I've been introduced, my name is Omari Said Buguyu. I'm an Assistant Director and Head of Non-Communicable Diseases, Mental Health and Injuries from the Ministry of Health. It is very unfortunately that I'm giving a talk on the last day after meal, and I'm not a physician. I'm a psychiatrist. So I could probably boring you, but you have to forgive me because of those three reasons. Can we start? So my talk won't be on the science behind diabetes and whatsoever. I'll be a bit different from Professor Otieno, what he was presenting today. And I know, physician, you were very happy hearing pathophysiology of renal diseases, pathophysiology of so many issues in diabetes. But the only problem that we have, this cut across all medical fraternity, is we are missing one key component, which is one, autonomy. We don't give power back to the patients. We know a lot of issues, we know a lot of things, and we assume that once we know, we can work for them. But unfortunately, I will cover that on diabetes self-care, which have been one of the key components within management of these chronic conditions. In African setting, it is very unfortunate we've been dealing with acute condition, infectious condition. We were missing these chronic conditions, and probably that was some of the gap that probably touch on. I'm not sure if I'll be able to cover all of those, but just giving you some highlight, please. And the following, next. Forget about my background, but now go back to my position as an head of non-communicable disease section at the Ministry of Health. When we did our STEP survey in 2012, the prevalence of hyperglycemia, mind you, it wasn't diabetes, but hyperglycemia was 9.1, and it was quite significant. And much worse with those prevalence of hyperglycemia, 3/4 of those who were found to have hyperglycemia, they didn't know, they were not aware of their status at that particular time. Only 1/4 who knew that they had high glucose levels, and some they were on medication. But it is only a half of those who were aware of their diabetes status, they were on medication. And mortality, when it comes to mortality, diabetes is among the top 10 causes of mortality among adults, of course overall, but it goes around top 5 most causes of mortality among adults beyond 25 years of age. So diabetes is one of the diseases of public health importance in our society. And then we have to keep an eye on these two conditions, diabetes and hypertension. This is just a profile of Tanzania. It's one of the big countries in Africa. It is among the top 10 highly populated country in Africa, even in terms of size. In East Africa, we are now the second largest country in East Africa because of DRC now has joined the EAC. But we used to be the biggest country within East Africa in terms of population and size. It is closer to 100 million square kilometer in terms of size. But there are a few issues that I want to highlight in this profile. One, number of inhabitants. The second one is on tribe. We have 126 tribes. So generalization, especially on issues related to behavioral modification, behavioral risk factor, it is not possible. So whatever that we are doing when we generalize is just prox to what we think Tanzanians are. But actually we need to deal with 126 culture when we talk of behavioral risk factors. you need to deal with 126 different behaviors rooted within our culture. Again, life expectancy has increased from 48 years in 1960s to 66 years current in 2022. So the disease pattern also has changed because of that change in lifestyle. There are two other additional issues that I want to show you. One is on maternal mortality. It is not 380, it is 104, from 555 to 104 over the past 20 years. It has declined, and the HIV prevalence is around 4.5 from 16 to 20% in 1980. Later on, I'll use some of these statistics to build a case, please. Our healthcare system is hierarchical. I know different countries use different modes. Some they're giving them in levels, but ours, we're just naming dispensary, health center, council facility, hospitals, regional referral hospital, and zonal and national hospital. So down here, these are primary healthcare level, and then we have regional referral hospital as a secondary and the tertiary from zonal and above. What we have seen now, we have around 10,000 health facilities in the country, more than 8,000 at PHC, actually more than 9,000 at PHC, just 100 plus at a zonal, at secondary and tertiary facility. And 82% of our patients also attended at primary healthcare level, where there's no physician, just assistant medical officer, clinical officer, or nurses. And there are more than 1,000 health facilities manned by only a nurse. So whatever that we are discussing here, that I think also of our workforce that we have in our society, please. When you look at the diabetes care in Tanzania, we have recorded around 700,000 patients. When we compare to those with hyperglycemia in 2012, and we did a recent step survey, the results are not yet out. We have around 3 million people with diabetes in Tanzania, and only 700,000 who attend health facilities. So just 20% are accessing care at our health facility. The rest, they are on the street and they come at a very late stage with some complication. All diabetologists and other physicians, you say that 1 in 10 of all our patients with diabetes are from type 1 subcategories. Unfortunately, with the facilities that we have at the moment, only 6,000 type 1 diabetes who access care. So the rest also succumb, or the other issues related to that. Again, this is for sub-Saharan African. When you look at a cascade of care, out of 100 people living with diabetes, less than 50% are diagnosed with the condition, and just a third are in control. So the rest are not. So all that Professor Teno, you said early on, we have a big bunch of our patients succumbing from all those facts. And it is just us, physicians, just as clinicians, who know about that. The population of the community at large, they are not aware of what is transpiring. And then this year, actually, we just provide some of our facility with HbA1c machine, and we ask them just to screen the patient that they have, because generally what they are doing, they are asked to check RBG only when you prescribe or when you educate your clients. You tell them, do random blood glucose. This is what they are doing in most cases, and we are ourselves to call it monitoring. So when we did this, especially to type 1 diabetes, who are given medication free of charge, glucose monitoring tools without any cost, this is what we found out. Only 22% are in control, 78% are not in control. There's no issue related to cost, nothing. Everything is provided free of charge. but this is the picture. Except for few with type 2 diabetes who had to buy some of those street. But unfortunately, when we are looking across healthcare spectrum, where the problems are, what we found out that I give you the hierarchy of care from dispensary to the national hospital. There's not much differences when you look at control, glucose control among the patients who are attending primary healthcare facility and those who are attending tertiary facility. I'm sorry for this. In a nutshell, those who are under care of nurses or clinical officers has not much difference for those who are under care of endocrinologists and diabetologists when it comes to control. And those who are the health insurance coverage and those who don't have, there's not much difference again. So in terms of cost. But when we ask a patient themselves, what are the perceived barrier on those? Those were three key barriers. One, they were reporting cost, though when you look at data, there's not much difference on cost. So one was cost related to treatment, especially for those who were insulin. Again, many, they say that I didn't have any symptom, and that's why I didn't continue taking medication. And that was just superimposed with a lack of knowledge because we didn't tell them enough that the control in diabetes is not having symptoms. So they are just looking for the clinical symptoms and rather than concentrating on a measure of HbA1c. And almost 80% of our facilities, at the tertiary facilities and the primary healthcare facilities, HbA1c is not one of the key components when it comes to assessment of glucose control among our patients. We are also relying on RBG, which was very unfortunate. When we were looking at the providers factor, we assessed, and as I told you, I'm a psychiatrist, and I want to take this opportunity at least to blame some of my colleagues physicians on this. You are not used to deal with the difficult cases. As a psychiatrist, we are dealing with two most difficult patients. One, those who are using substances, they are always in denial, and in most cases, they don't accept that they have a problem. So it takes a lot of time to make them understand that whatever that they are taking at that particular time, it is a problem, and then they have to look back and see how best they can change, because they are the ones who need to change. And there's no any provider who can make them change, except it has to come from within. That is motivational interviewing. When you talk to patients, you don't give lectures, you don't preach, you don't blame, you don't ask why. You make them ask why themselves and understand what are the gaps. And what we are just doing, just facilitating them going through the difficulty that they have. That is a skill, and somebody needs to be taught in class. The other issues that we are dealing with always is those with psychosis. Many don't have insight because at that particular time, they are not well. So you need to work for them, but you need to be a little bit intelligent on that. So we had an opportunity also to interview some of our patients, and 7 out of 10, when they are asked, when you were told that you have diabetes, what was the reaction? 7 out of 10 say that I was a bit angry, I was feeling sad, I was blaming myself. A lot of issues coming across their heads, and it is very difficult for them to comprehend. But unfortunately, again, as clinicians, we forget that even a diagnosis of diabetes, also somebody needs to be counseled, because it is difficult to comprehend that you are sick. And to many, they know that if you are sick for life. So many of us think that if it is not HIV, you don't need to do some counseling. And counseling is a skill. You need to have a time when you want to counsel somebody. And in this case, nurses, social welfare officers, psychologists of any nature, be it clinical, non-clinical. They do it best than doctors, not because we don't have skills, but we don't have time. With 50, 100 patients queuing, so you don't have that time. And then you need somebody, not to support you, to support patients. They don't support us, to support patients. And Professor Otieno, we were talking about data. In most cases, the data they are at the facility level. The individual don't have their number, their own numbers. When we deal with behavioral issues, they need to understand. I was working with a methadone clinic in Tanzania. We are one of the pioneers in East Africa. And those people with a substance use disorder, they always tell us, nothing for us without us. So we have never developed any guideline if they are not involved. They need to be there. When we design intervention, they need to be there. And those were donor funded. We were supported by Global Fund and PEPFAR. They are complaining. If you don't involve them, then the funder will know, and then you'll be summoned. So whatever that we are doing, we have to call them. We develop a guideline together with them. Mind you, there are people who diagnose as substance users, but we need to sit with them just to understand what are the issues on their side and then put them on the guideline. So we also need to talk with a diabetic patient. Again, in Tanzania, the shortage of human resources is 50%. And as I told you earlier, more than 1,000 health facilities are manned by nurses, especially at the dispensary level. So, we need also to cascade the knowledge that we have. But naturally, in most of the African and sub-Saharan African countries, that our healthcare system, they are very proactive, very reactive. We are just dealing with the malaria, these infectious conditions. We have an epidemic, and then epidemic goes down. So we are very reactive. When there is an epidemic of cholera, we just deal with the cholera, then we are done. With the cholera, then it is malaria, so we keep on. But with the current trend of disease, these are conditions which are chronic in nature, and then we need to sit down, understand the trend, and reorient our healthcare system to accommodate those changes. You can't work as Professor Otieno, you can't deal with a 40 patient queuing on your door daily. That is next to impossible, because you'll be doing injustice to some of them. Because there are those who need to come back to you, and there are those who can be handled by even an intern or clinical officers. And it is very expensive to see you, Professor Otieno, in your facility. The consultation fees for you goes in Tanzanian shillings, goes up to 50,000, just seeing you. And this is just for repeat prescription. Everything is under control. And opportunity costs. The best place where somebody can be treated is closer to your home. As a specialist, in most cases, we are not there closer to somebody's home. We are somewhere very far. With all of these, again, we haven't yet defined our essential healthcare package. So whatever comes, we just introduce within our healthcare system. It has become expensive to healthcare system itself. It has become very expensive also to patients themselves. So also areas of defining what are the essential packages. These are critical to our clients. Okay, next. So with all of those on our background, two key issues come with our Tanzanian strategy. One, to have a diabetes care pack as one of the key and essential components that we would reach consensus. At the moment, Minister of Health, some colleagues like myself and other colleagues are now working to see what should we put on our care package. And of note is diabetes self-care. I know there's a lot of theories nowadays that diabetes is reversible, and the component within the reverse, I don't know, consensus among yourselves. In mental health perspective, we are using control. Somebody can have a depression and then you can treat them. Never say that somebody is cured, but we declare that he is or she is under control. And what we do to them, we say that we give them drug holiday. So a drug holiday is also prescribed. You have a drug holiday for 2 weeks. After 2 weeks, please come back. We ask some certain questions, then give him a month, 3 months, 6 months, a year, and then said, if you see any symptoms, anything, just call me or come back. We will assess you. And then with that, we're not declaring somebody is cured. We are not saying that depression is reversed, but we say somebody is under control. And you can be under control with or without medication. So there's a lot of people who are mental unwell, but they are under control and they are functioning. We can declare somebody is being cured after he or she died. You had a depression, we treat you 70 years ago and never get to relapse. So probably you are cured. But any time, if you get similar symptoms, we just say that you get to relapse and it is the same condition. So within diabetes community, I don't know, what are you calling it? There are people calling the VAS or whatever. But all in all, we know diabetes can also be controlled with or without medication. And without medication, what we need now is on self-management. You will never be in control if somebody is managing you. You need to control on your own. So we are working on this. We know that American Association, Diabetes Association of America, and in Europe, they have diabetes self-management and education and support. And it is just a prescription, like when you go to see a psychologist, your prescription is just education. And in our settings, cite Tanzania as an example, when we say giving education to the patient, we just call them in a group and tell them, this is diabetes, what you see, A, B, C, D, and then you go into your room, starting prescribe and saying that you gave them education. With education and support, somebody has to come into class. You teach them different components. There's one component related to the symptoms. There are component understanding risk factors and how to mitigate risk factors. There are issues related to emotional control. You were talking about the endocrinology, and you know, in depression, the cortisol level goes high. So the rest, you know, when the cortisol level is almost always high, what will happen? When it comes to control of diabetes and other endocrinological conditions. So somebody has to come into class. So in Tanzania at the moment, we are just teasing out the American DSMEs module and seeing how best we can utilize that and prescribe it. The next move is make the insurance companies fund for such a service because it is a standardized service. Through the Merck Foundation and the team, we can also look at that an African context if we can adopt some of those. Again, as a chronic care model, you always need to integrate. I say that 80% of our patients are seen at primary healthcare level. There's no physician at primary care level. The one that you see at OPD is the gynecologist, pediatrician, surgeon, endocrinologist, does everything. So verticalization of our care, it is next to impossible when it comes to PHC. So our care package also has to incorporate that. And in pediatrics, we used to have integrated management of childhood illnesses as a simple pack. Now we are developing the simple package, just algorithm to identify case and simple set of skills somebody can provide care. This is my call to my fellow doctors and specialists. I give you a country profile early on. Yes, I wanted to convince you. I told you in Tanzania in 80s, our HIV prevalence was in some region goes as high as 25%, and those with the lowest prevalence was around 16. Today it is 4.5. Our maternal mortality was around 600 in 80s, and now it is 104. The biggest workforce that we were working with are nurses. They've been trained, they were given algorithm, and they were told when to refer, when to prescribe. So task shifting was very important and is a game changer. In Tanzania, with 3 million diabetes patients, with less than 1,000 physicians, it will be a miracle if we be able to attend all of them. So the simplest is just to accept among ourselves that we need to do some task shifting, empowering our colleagues within the medical fraternity, and develop some simple algorithms, simple tools for them to intervene early. It is not difficult to manage diabetes when we start early. If we delay, and then they'll come to you, Professor Otieno, we'll give them all the pathophysiology of end-stage renal diseases, and you put them on dialysis, you do them renal transplant. By the end of the day, we'll miss the opportunity of just prescribing them a simple medication early on, just prescribing them self-care interventions. So that is the key issues. And lastly, let us be guided by data. It is very unfortunately, most of the scientists in Africa, we are like politicians. We are just moving with the wave rather than being informed by data. And that's why I don't know about other countries. I can refer my own country. You go to the facility, you ask somebody, I want data from your facilities, and it is a service provider who tells you that these are not reliable. So you collect data on and on and say that they are not reliable. So how do you make a decision if the data that you are collecting yourselves are not reliable? So let us use data. Let us make others also see that we are using data so that they can respect, and we don't leave this health management information system to ICT and M&E personnel. We are the ones who need to utilize those data. So I'll end up here because I've been told that there are other speakers who are online. So thank you very much.
Thank you very much, Dr. Omari, for the profound knowledge, what you have shared. Now I have the privilege of inviting our next speaker. It is Professor Steve Davis, consultant endocrinologist, medical director, postgraduate diploma MSc courses, University of South Wales, UK. So he'll be joining us online.
Yeah. Thank you very much. Would you like to put the on, please? Or shall I share? Okay, great. Thank you very much. So I'm Steve Davis. Thanks for the introduction. I'm a consultant endocrinologist based in a very cold Cardiff. And I'd like to try and convince you this morning that menopause is important, and also to discuss some of the data relating to it, and then implement that evidence into practice with some cases, please. First of all, let's start with the menopause. And this is a World Health Organization definition, and it says natural biological stage in a woman's life characterized by the termination of menses due to loss of ovarian follicular activity and decline in estrogen concentrations. That is also 12 consecutive months since the last menses, and the typical age for the menopause is between 45 and 55 in the UK. So I want to focus upon the natural. It's please. So this graph illustrates with the yellow line there. Unfortunately, I can't put a marker on it, but the yellow line illustrates what happens on the x-axis about the age of 50, where there's a rapid decline, huge drop, as you can see there, in estrogen concentration. But also, please be aware that testosterone, as illustrated in the blue line, also declines. But look what happens beyond the age of 50 to, as is illustrated there, by cardiovascular risk, which goes up with the dotted gray line, and also diabetes risk, which goes up quite considerably, associated with the menopause. So really, estrogen decline, okay, it's a natural process, but it's associated with unnatural risk. So let's go to the, please. The importance of estrogen deficiency. Well, it's an important and one of the most important sex steroids in a female. So a deprivation of that results in symptoms, and these include flushes, sweats, so-called brain fog, interference with cognitive function, accelerated aging, and a decline in libido, and of course, infertility. Now, associated with that, there's a systemic impact as well, which includes vaginal and breast atrophy, thinning of the skin, which is associated itself with an aging process, but also a decline in cognitive abilities, reduced bone mineralization, weight gain, and importantly, a decrease in vascular function, which contributes to that risk. All those factors are contributing to the risk that we see in diabetes, metabolic risk, and also cardiovascular risk as well. Please. Can we go to, right, okay. So the relevance of the menopause, if you can go to a slide share of that, please, would that be okay? Can you do that? Make it a slide presentation. Okay, I'll talk about this slide anyway. Unfortunately, I was hoping that it would be displayed to you that much better. But what you'll see on the x-axis is time. So at 1900, in the year 1900, the average life expectancy of a woman in the UK was 50 years of age, about 53. Go on another 120 years, and life expectancy now in the UK is roughly 83 for a woman and 82 for a man. So in 1900, a person was living 3 years post-menopause. Let's, for argument's sake, say that the menopause occurs at the age of 50. Now, however, it's 33 years. So that deprivation of estrogen has a considerable amount of time to impact with regard to comorbidities. And what we see here is the increase in life expectancy also translates to Africa as well, with life expectancy for a female increasing between 65 to 70 years of age. So women in Africa also are living 20 years in a menopausal state. What does this translate to? Well, I've kind of intimated at the issues associated with the associated comorbidities like osteoporosis, diabetes, mental well-being, and cardiovascular disease. So those are quite clear-cut, but there's also an economic impact to a country. And in the UK, we're looking at about $2.2 billion annually that is a detrimental impact of the menopause as a consequence of 14 million lost work days annually. And 1 in 10 individuals, menopausal individuals, leave their job early due to the symptoms, and 26% take time off. So that is a significant economic impact for a country, and we need to be aware of this. So I want to go on to the, but can you take me on to the, please? It's not really working with the control panel that I've got. Okay, so I explained this, and this illustrates what happens at the menopause, but also it translates into what's happening with women in comparison to men. Belt and braces approach here. So as you can see on this slide, at the time of the menopause, unlike men, where there's a gradual decline in testosterone concentration, there's a rapid decline in estrogen that impacts upon a precipitous drop in bone mineralization that continues to then evolve as one gets older, the age-related bone loss. Now, it's very interesting in the right panel there, as you can see, in the right panel, as you can see, there is, at the time of about, around the time of the menopause, cardiovascular events rise above that of men. And this is somewhat surprising to the majority of individuals. So HRT, it's very easy. As an endocrinologist, we're always replacing hormones. And this is one of the easiest things to do. I won't dwell on this slide very much, but in essence, there are equivalents of different types of estrogen formulations. It's very easy then to add various types of progestogens into that as well. And the common preparations that we use will be either patches, oral preparations, or potentially gels or nasal spray. So what I want to do here is then talk about HRT and the improved symptoms associated with that. Because when one treats with HRT, because those symptoms are related to the hormonal deficiency, treatment with HRT improves the symptoms, flushes, libido, cognition, anxiety, and indeed that translates into improved quality of life scores. And in this particular Kaplan-Meier curve on the right, this meta-analysis from the BMJ revealed that individuals who were treated with HRT over a long-term basis had also a reduced mortality. And that's an important part to recall. I'll come on to that later on in the talk as well. So if we look at HRT and all-cause mortality, what we see here, again from this Lancet article, is that, and a more recent Lancet article, is that whatever you're looking at, the systematic and the meta-analysis here, the systematic review, reveals that there's a reduction in mortality associated with HRT. However, many physicians are not so keen on using HRT because they worry about risk. This is well established in the literature. And the predominant one is breast cancer, but there's also issues about blood clots, stroke, and coronary heart disease. And they're a small risk, and I'd like to take this forward in the following slide, because the biggest problem that I encounter as an endocrinologist is from physicians suggesting that the issue is around breast cancer. And this is a great way of demonstrating that with the British Menopause Society. And what you can see is if I manage, and I'm hoping that I can show it, if I go to this here, okay, in overweight or obese individuals. So we're looking at about, if I go to the back, we're looking at about 23 cases of breast cancer diagnosed in a UK general population in 1,000 women between the ages of 50 to 59 over a 5-year period, okay? That's what we're looking at. That's the base level, 23. We're not treated with HRT. If we go down to this bar here, we see that if people are overweight or obese and they're not on HRT, there's about 24 extra cases. If you treat patients with HRT, you get roughly, as is illustrated here, 4 to 5 extra cases. And that's the thing to remember, over a 5-year period in this age group. So actually, when you look at it, lifestyle factors like alcohol, smoking, and obesity are more important than HRT when you put it into that perspective. And this is an important way of translating risk to the patient and also for the clinician as well. And this is a big issue with regard to why people aren't being prescribed HRT. So this is a paper, a publication in the UK, the Mail Online, saying, why do so many GPs refuse it? And of 3,000 menopausal women, 60% who presented to the GP with problems had not been offered HRT. Yet, as I demonstrated, there's a rationale for treating patients who present with symptoms. In fact, 66% of this population had been offered antidepressants. So that's problematic. Now, when you delve deeper into this and you look at the other side of the equation, 52% of GPs said that they've not been given enough support to monitor and treat patients presenting with the menopause. And in fact, 1 in 3 GPs lack the confidence to prescribe HRT, despite this being incredibly simple as far as I'm concerned, being an endocrinologist. And this is one reason why, as the director of courses, we established a postgraduate certificate in menopause medicine, because ignorance amongst us as clinicians is not a reason for not treating our patients. So let's start with a patient, because I'd like to bring this evidence and implement it into practice. 51-year-old female. She came to see me because of mood swings, sweats, difficulty concentrating at work. It was impacting on her employment, but also her relationship was poor. And this was impacting upon her relationship as well. Last period was 2 years ago. She gained a little bit of weight as well with a BMI of 29.8. So are there any really investigations required here? And how would we treat this patient other than giving her antidepressants? No, that's wrong. No investigations are required. So World Health Organization indicate and guidelines, British Menopause Society guidelines, no investigations are required to confirm the menopause. At the age of 50, individuals having mammography anyway in the UK as part of the UK screening program. But in her anyway, and there are a number of, I won't elaborate the point, but there are a number of ways of looking at an individual's breast cancer risk. Important for her, give lifestyle interventions, because as her weight goes up, so all the other comorbidities associated with overweight and obesity. So diet and exercise. And for her, what we would use is this continuous combined HRT, i.e. non-stop estrogen and progestogens. The last period was 2 years ago, and she doesn't want withdrawal bleeds. We discussed this with the patient with regard to the choice, and her preference is 1 milligram of oral estradiol, starting off at a relatively low dose there, 1 milligram oral estradiol plus 0.5 milligrams of norethistone, because she still has a uterus, so you want to avoid withdrawal bleeding. 3 months later, she comes back, better still, some flushes, libido is rather poor. So at that stage, we can increase no withdrawal bleeds, which is great, no spotting, which is great. So it can increase the dose of the estradiol and norethistone, taking that up to, this is the kind of maximal dose, but some individuals in the UK have recommended higher doses for patients. I prefer to stay in guidelines. So this is the maximal dose, 2 milligrams estradiol, which is equivalent to 100 micrograms of a transdermal estrogen patch. Arranged to see her 3 months later, flushes settled, excellent. That's why I increased the dose of the estradiol, because it will improve those symptoms of flushing, the estrogen-related flushing. She's thinking clearer again, cognitively. That'll improve her function as well by getting estrogen concentrations up to a decent level. But interesting, libido remains problematic and is causing relationship issues. Can we do anything about that? Yes, we can. Because, and this is why I mentioned about testosterone, testosterone is actually the dominant sex hormone in women. Many people, this may come as a bit of a curveball for a vast majority of the audience, but it's the highest sex hormone concentration in a female. Testosterone concentrations typically normal range 1.5 to 2 nanomoles per liter, 1/10 that of males. Estrogen, picomoles per liter, i.e. 0.3 to 0.8 nanomoles per liter. So it's important to remember that, because testosterone concentrations are in fact twice that of estradiol. And therefore, at the menopause, as we've seen, testosterone declines quite abruptly as well. And therefore, the impact of that is particularly related to libido. And this is I won't labor the point, but there's something called female hypoactive sexual desire disorder. There's a questionnaire established for that. So when your patient comes along, you can potentially submit them to the questionnaire, establish the diagnosis, and then consider adjunctive treatment together with HRT to improve this particular problem. And we use a testosterone gel formulation providing 5 milligrams per day versus the typical dose for men. As I said, it's 1/10 that. So it's very easy. You give 1/10 of the dose that you would typically give a man, which is 15 milligrams. And we should measure testosterone concentrations because some women are very slight, and so that concentration may be slightly too high for them. However, 6 months later, she's much happier with sex life, improved libido, testosterone concentration on the testosterone gel 1.2 nanomoles per liter, so perfect. And she continues with the estradiol and testosterone. The follow-up then is with the general practitioner. And what we suggest is continuing with the HRT for 5 years, and at that point, reconsider treatment based upon what the patient wants. And typically the patient will want to continue with HRT, but it's important to discuss risk with them. Second case, and there's only one more case to do, a 46-year-old female attending complaining of flushes and mood swings. 46 years old, so she is within that time of the menopause, but her last menstrual cycle was about 2 months ago, but she's complaining of flushes, and the periods have been very intermittent. That's her problem. That's why she's come along, flushes, mood swings. Estradiol concentration is normal. FSH is slightly high there. These results were handed over to me. How should we manage this patient who's actually in climacteric, as we would call it? Well, for her, and this is a contrast, rather than a continuous combined estradiol, it's sequential HRT. Commencing, what she wants is the estradiol spray, which you start off with one spray, together with sequential progestogen, in this particular case, norethistone, 5 milligram per day for 14 days of the latter part of the monthly cycle. 3 months later, she wants to stop, unfortunately. Symptoms of the flushes had improved, the estradiol-related symptoms improved, yet she'd had problems with unscheduled bleeding, breast tenderness, bloating, plus mood swings. Now, these are almost PMT symptoms, and they typically relate to progestogens. So for her, as I suggested, it's a norethistone that's likely to be contributing to the PMT symptoms. Now, we can increase the dose of the estradiol spray, but on this particular occasion, we can remove the impact of systemic progestogens by utilizing a Mirena coil. So 3 months later, so that was undertaken. The Mirena coil, if anyone's unfamiliar with that, is the progestogen implanted IUCD. 3 months later, symptoms much improved, really happy with the Mirena, and she continues with that treatment. Returns 5 years later, this time she's 51, and comes back, continued use of HRT. Breast cancer risk is fully discussed with her. There's no family history of that. In such patients, consider from the starting point of 50 rather than it being 46 or 45, and explain, as we do, about 22 cases with 5 years without HRT versus 27 to 36 cases, depending upon BMI, with HRT. And of course, risk does increase with age. But this is really important. Rather than plucking numbers out of the air, it's important to convey this risk, 22 cases per 1,000 over a 5-year period. And explaining that kind of risk cogently to the patient, she wants to continue. So that's great. And she can continue for another 5 years, have annual review. She has the mammography as part of the screening. The final case is a 52-year-old woman with flushes, brain fog, mood swings, together with low libido, who wants to discuss HRT. She had the menopause 3 years ago. She informs you that her mother had breast cancer. So here we introduced the concept of breast cancer at the age of 59, for which she underwent surgery and is currently on tamoxifen, but is cured. And she's now 70, her mother is 74. So the question really is, can we treat this patient with HRT? And what I do in this particular case is, obviously, let's refer to what the guidelines have to say. And these are primary care guidelines established in September 24 by National Institute of Clinical Excellence, so-called NICE. And what they suggest is that refer to secondary care endocrinologists or the gynecology team, any patients who have a first-degree relative who's less than 40, or first and second-degree relative with breast cancer at any age, and another with ovarian cancer. or 3 first or second degree relatives with breast cancer. So in this particular case, there's no real need to refer to me as an endocrinologist, but the patient can be started on HRT, but it's important to clarify that risk and obtain 3-year mammography. So that woman was treated with continuous combined HRT because her periods were 3 years ago, and she did very well. And I think the important thing to remember is that when patients present with the menopause, it's not about refusing it, it's actually providing them with treatment, because the evidence is overwhelming with regard to the impact of HRT, particularly as we are all living longer. Treatment is easy, it's effective, and it's safe. And we do our patients and society a disservice through ignorance towards the management of the menopause. In particular, we contribute to the economic burden that the menopause presents if we don't treat it effectively. And I've just illustrated here, for anybody interested in learning more about the menopause, we've got a postgraduate certificate from the University of South Wales. Thank you very much indeed.
Thank you very much, Professor Steve Davis, for the insightful information and talk on clinical area, very crucial clinical area. So thank you very much. And thank you very much, Professor Steve Davis.
Pleasure.
Okay. So we now have with us Dr. Justina, consultant endocrinologist and diabetologist, University Hospital of Wales, UK.
Hi, everyone. Thank you for inviting to this talk. I just try the screen sharing. Hopefully it works.
Yeah, you can go ahead with screen
yeah.
sharing, doctor.
Can you see my slides?
Yes, we can see.
Okay, that's great. Thank you very much. So I'm going to be talking about endocrine emergencies, which is quite an important subject because although they are quite rare, they only account for about 1.5% of hospital admissions. They do happen, and you don't want to be caught out when they happen to you when you're on call, because you kind of have to know what to do, or where to look for help. The things that we will most often see are diabetes-related emergencies like severe hypoglycemia, DKA, HHS. But the pure endocrine emergencies, as such, are the adrenal crisis, acute severe electrolyte disturbances such as hypo and hypercalcemia, severe hyponatremia, pituitary apoplexy, thyroid storm, and mixed edema coma. Guidelines are available, and in the UK we use Society for Endocrinology guidelines. That's the link, that's the website. They're very practical and simple and easy to use, so you don't have to read 20 pages before you get to the conclusion. You get to find out pretty quickly what you're supposed to do step by step. So in a moment of panic, when you're stressed about your patient, refer to that, because it will help you to consolidate what you meant to follow. So let's just go through cases to illustrate a few important points. And these are all real-life cases that I came across over the years. So let's start with this lady. She was 19 years old when she presented to the medical assessment unit in Wales. And she presented with a few days history of severe occipital headache, what she described as photophobia, confusion. She didn't have any past medical history as such. The dad had type 1 diabetes. The patient herself only took a contraceptive pill. And on examination, she was found to be quite slim. GCS was slightly reduced at 14. Blood pressure 100/70, but tachycardic. Pale, but there was no abnormality on the cardiovascular examination or the chest examination or the abdominal examination. It was found that her neck was tender to palpation, and nobody at that point was able to visualize her fundus properly, because apparently she had a photophobia for what was described, but there was no power or sensory deficit. There were no rashes. So what happened to her next? What was the differential diagnosis? So people who admitted her for, is it a subarachnoid hemorrhage? Could it be some kind of CNS infection, pituitary apoplexy, maybe really bad migraine, or sagittal sinus thrombosis, or something else? The bloods came back. She was slightly hyponatremic at 129. Otherwise, inflammatory markers were not too impressive. Glucose was 4.2 millimoles per liter. She had normal coag, normal LFTs, a slightly raised calcium. She was found to be tachycardic on her ECG, but chest X-ray was fine. She had a urine pregnancy test negative. There was no sign of infection either on the urine dip. So she went on to have a CT head, and there was no evidence of any bleed, ischemia, tumors, and then the doctors had with her proceeded with lumbar puncture, which did not add much to the story. Opening pressures were fine, there was infection, xanthochromia came back negative, and the glucose was appropriate to what in respect to the glucose from the vein. So she was treated with some analgesia, IV fluids, and improved symptomatically. She was seen by neurologists the following day. They did manage to visualize her Funday. They were fine. There was no other abnormality neurologically. So she was diagnosed with a migraine and discharged at home. However, that's not the end of the story, because she represented a few days later, and the headache was worsening, and apparently she still had neck stiffness or tenderness, but she developed severe agitation in the department and started hallucinating, and the GCS was dropping rapidly from 14 on admission down to 7, and she became hypotensive. Therefore, ITU colleagues were involved, and they intubated her and managed with IV fluids and antibiotics suspected, and she was transferred to ITU unit. And as you look at her bloods, her admission sodium was still low as previously, but it dropped rapidly to 116 a few hours later. The CT head was repeated, which was again the same, and LP was repeated as well, because there was a thinking, oh, did we introduce infection with the first LP? White cells were raised, virus PCR was sent off, but obviously that rapid drop in hyponatremia had to be investigated further. And you can see that the urine and serum osmolarities were sent off, urine sodium, but more importantly, a hormonal profile, which showed that her cortisol was 34 nanomoles per liter. So what does it make you think about, and what would you do next? Obviously, this lady needs steroids ASAP. She was managed with 100 milligrams of hydrocortisone IV, and the fluid resuscitation continued. And with that treatment, the blood pressure and the serum sodium have stabilized. Subsequently, she underwent MRI pituitary because it was it all a pituitary apoplexy, some sort of tumor that was not seen on CT head, but there was no mass, no apoplexy on the scan. So what does it make us think about? It all turned out to be Addisonian crisis from primary adrenal insufficiency. She had very small atrophic adrenal glands on the CT subsequently, and a few days later, the adrenal antibodies came back strongly positive. And the viral CSF PCR was eventually negative, so there was no sign of CNS infection, was a bit of a red herring. So this case just illustrates the kind of convoluted path to the diagnosis in this patient, and it all in the end turned out to be Addisonian crisis. And the symptoms can be very non-specific and vague sometimes. And if you look at the list of how the patients can present, you probably will have people telling you similar symptoms every day during your consultation, and they may have something completely else going on with them. So it's just important to keep at the back of your mind that those adrenal failure patients are there, and you have to have a high index of suspicion when things just don't quite add up. Acute adrenal insufficiency gives you quite specific lab findings as well that can prompt you to what's going on. People have hyponatremia, hyperkalemia, they can have AKI, pneumochromic anemia, and hypoglycemia. And when you investigate them, once you kind of establish your diagnosis, you want to keep eye on her blood pressure, do a strict fluid balance, take a detailed drug history, because it might be actually that these patients were taking steroids for some other reason, like they may have been on steroid creams, steroid inhalers, steroid injections in the joints, and they were rapidly stopped. And that's why they present with iatrogenic adrenal. And we don't often think about these causes, and you probably know it yourselves, steroids are given for lots of indications these days, and this applies to many patients that you will be seeing. You obviously want to see what the user needs are doing. The thyroid profile, you want to have the paired serum cortisol plasma ACTH, though ACTH might be a bit tricky to measure because it's not very stable. So it's important this sample is sent on ice to the lab immediately. Otherwise, you get artificially low result and it won't tell you much really. You do the short synactin test once those patients are stable. So how do we manage these patients? Obviously, if we've got adrenal crisis, we want to give hydrocortisone either IV or IM. You give your bolus, and then you follow it up with an infusion, 200 milligrams over 24 hours, or you can give 50 or 100 milligrams boluses. Rehydration is very important with 0.9% saline. You want to give between 4 to 6 liters in 24 hours, obviously depending on the other comorbidities, if it's safe to do. You want to speak to your endocrinology colleagues, let them know you've got such patients. And once the patient is stable, you'll want to taper down the hydrocortisone, then eventually switch it to oral. And the long-term maintenance hydrocortisone dose, it's usually 15 to 25 milligrams per 24 hours. It's split doses, for example, 15 in the morning, 10 in the afternoon, or 15, 5 and 5, or 10, 5 and 5, depending on how the patient feels. You go by the symptoms. If they're feeling a bit more energetic, the lethargy is under control, they're feeling less dizzy, then you know that you're on the right replacement dose. Otherwise, you may have to increase it a little bit. As I said, precipitating factors often are rapid cessation of therapy, whether it's taking steroids for some other indication, or people may not be compliant as well with taking this steroids replacement. Also, sometimes patients ignore or are not aware enough of the sick day rules. Sick day rule number 1, you should double up the steroids when you're unwell with fever, antibiotics, etc. And sick day number 2, there are certain conditions when you need to administer the hydrocortisone IM or IV. For example, when people have diarrhea or vomiting, or when they undergo procedures like colonoscopy, surgery, etc. And sometimes it's the healthcare professionals who kind of do not administer the hydrocortisone IV. So it's important to raise awareness for these scenarios as well. But management, otherwise, in people with adrenal insufficiency, so not the pituitary patients, you also want to add fludrocortisone, usually 50 to 100 micrograms per day, and then you up titrate or down titrate as needed. You go by the drops in postural blood pressure. Once they settle and the potassium is normal as well, you know that the patient is on the right dose of fludrocortisone. You don't need to give fludrocortisone if the total daily hydrocortisone is more than 50 milligrams per 24 hours. Some patients may require adrenal androgen replacement like DHEA, usually for low libido or low mood. There's a little bit off-label, but you will come across some patients that benefit from that. We don't often use prednisone and dexamethasone. You could. They have longer half-life, so they may affect bone density and insulin sensitivity in long term. And you have to be aware that in certain scenarios, you may have to increase the daily steroids dose. This applies to in the third trimester of pregnancy, patients on certain drugs that affect the CYP3A4. Very hyperthyroid patients, for example, may require the increase in the dose as well. And depending where you work, obviously you have different steroids preparations that you will be using. So in UK, we mostly use hydrocortisone, but you may have cortisone or prednisone. So this is like a conversion list, but these calculators are available online, so you can easily convert as you need. How do we prevent adrenal crisis? Education is the key of the patient and of the healthcare professionals as well. So for the patients, we ask them maybe they can have a necklace or a bracelet or a steroid card to make people aware in case of emergency. People should be aware about doubling up the steroids during intercurrent illness, when to use parenteral steroids. And our patients in the UK, they get hydrocortisone emergency kit. So they've got box with 5 vials of hydrocortisone sodium phosphate. They've got syringes and needles. Them and their next of kin are trained how to do it in case of emergency. The website from the Society of Endocrinology is very useful as well. They talk, looks like, and this is something that you could, there's also a QR code to take patients the relevant information. So this is something that you might find useful or might want to implement locally as well. Okay, so let's move on to case number 2. There was a man in his 60s who came with worsening back pain, but no history of trauma, decreased appetite, generalized aches and pains and fatigue, some reports of hematuria and dysuria on a few occasions. Background of high blood pressure, COPD, dyslipidemia. He was a smoker and drank quite a bit. Dad had lung cancer. When he was first assessed, he was tachycardic, his temperature was a little bit borderline, and he looked clinically dehydrated and he seemed a bit confused. But the cardiovascular examination and respiratory assessment and neurological examination were actually fine. There was not much to pinpoint at that point. Chest X-ray was fine, but it was found he had short QT interval on his ECG. And when his bloods came back, you can see that he had anemia, normocytic anemia. He had low sodium, high potassium, AKI, but what is and high inflammatory markers, but what is most striking is his calcium of 4 millimoles per liter. And he had blood and protein in his urine dip. So what is your immediate management plan based on that? And what do you need to do next? Obviously, this calcium is a medical emergency. You want to give IV fluids, preferably 0.9% saline. You want to hold the nephrotoxic drugs. You want to do strict urine input and output, fluids input and output charts because of his AKR and the fluid resuscitation. And further investigations revealed that he had normal kidneys on the ultrasound, but the prostate was quite enlarged and the PSA was high with suppressed PTH, which was only 1. So when you have hypercalcemia with suppressed PTH, that should always make you think about malignancy. And there are 3 main mechanisms of cancer-induced hypercalcemia. This is secretion of PTH-related protein, PTH-RP, usually by solid tumors such as breast or cancer or SCC. We don't measure the PTH-RP routinely because it's very difficult to obtain such measurements in UK. Only few labs do it, so it's the kind of you make this diagnosis based on the presentation and what the underlying tumor is. Often osteolytic metastases can give high calcium as well. That happens with lymphoma and multiple myeloma. And in certain patients such as patients with Hodgkin or non-Hodgkin lymphoma, or those with TB and sarcoidosis, there is increased production of calcitriol, and that gives you high calcium. Obviously, we have other causes of hypercalcemia as well, which are not malignant, like PHPT, drugs such as thiazides. We have to remember about that because they're commonly prescribed. Vitamin D intoxication, which can happen these days because some patients like taking industrial amounts of various vitamins and supplements. Rhabdomyolysis, high bone turnover in thyrotoxic patients, or can sometimes happen in ITU in patients who are immobilized for quite a while. Symptoms, again, can be non-specific at times, as you can see. Traditionally, they were described as stones, bones, abdominal moans, and psychic groans. And it could be anything. It can be just a bit of lethargy, could be a bit of confusion, could be a bit of constipation, abdominal pain, but in very extreme cases, arrhythmias and syncope, as we can see in our patients, renal failure as well. So what do you do with acute hypercalcemia? When we think about classification, you want to think, how severe is it? Below 3 millimoles, often people are asymptomatic, and it does not usually need urgent correction. Anything more than 3.5 requires urgent correction, is a medical emergency. People can have dysrhythmias and coma. 3 to 3.5 is kind of in the middle zone. If it has risen slowly, it might be well tolerated, but people they do require treatment as well, and they may be quite symptomatic even at those levels. Depending on the context, you obviously want to know what caused the high calcium, so you may need to do further investigation, serum electrophoresis, serum light chains, urine Bence-Jones protein, and please be aware that the Bence-Jones protein does not get picked up by the routine urine dipsticks. You may have that clear for protein, but you still want to send the separate sample for BJP. And in certain circumstances, you may proceed to skeletal surveys if there's indication that your patient might have lytic bone lesions. Myeloma can cause nephropathy by various mechanisms as well. There can be light chain cause nephropathy, renal vein thrombosis, amyloidosis. Often you may end up doing a CT tap to just search for malignant lesion if the cause is not clear. In the case of our patient, unfortunately, he had a prostate cancer with vertebral metastases confirmed. So in the acute settings, when you've got severe hypercalcemia, what you want to do is to start with fluid resuscitation, 0.9% saline, 3 to 6 liters over 24 hours. Obviously, you may need to be more careful with people with fluid renal impairment or elderly fluid overload. Once your patients are rehydrated, you give IV bisphosphonate, whichever one you've got available in your hospital, whether it's zoledronic acid, pamidronate, or ibadronate. And then you monitor your serum calcium response. It might take about a couple of days to improve. People with renal impairment should have the reduced dose of biphosphonates given, and those that had undiagnosed vitamin deficiency before such presentation, they may develop hypocalcemia later on. So be aware of that. Loop diuretics are not really used these days. They're not really effective in lowering the calcium, but you might want to use them if your patient develops fluid overload. In refractory cases, dialysis might be required. Sometimes, especially in context of oncological patients, we also use denosumab. Secondary management options, depending on the cause, people with lymphoma or granulomatous disease might benefit from steroids, and just good old prednisone 40 milligrams once daily does lower the calcium in about 2 to 4 days. So think about that. We use cinacalcet, calcium mimetics, mainly in context of people with parathyroid cancer, renal failure, those with primary hyperparathyroidism, whom we cannot operate for various reasons. Calcitonin, or as I mentioned, parathyroidectomy might be the solution sometimes. All depends on the context. As we're talking about hypercalcemia, let's talk briefly about hypocalcemia. Symptoms usually develop when patients have got calcium levels below 1.9, but again, it varies. Every patient is different, it's very individualized. And as you know, people can have periorbital digital paresthesia, positive Hostek and Trousseau signs, laryngospasm, ECG changes, or even seizures as well in extreme cases. Easy way to remember is that, low calcium, prolonged QT, high calcium, short QT. So look at the ECGs when you suspect the electrolyte disturbances. Why do people develop hypocalcemia? So for us medics, it's mainly the surgeons who cause it, because they either take the parathyroid glands when they do the thyroidectomies, or following the selective parathyroidectomy may take some time for the other parathyroid glands to pick up after the surgery. Often very severe vitamin deficiencies are present as well. And something we cannot forget is hypomagnesemia that is coinciding, and often lots of people can take very big amounts of PPIs, and it's very commonly prescribed drug, and people just sometimes overuse it without thinking about the consequences as well. So look at the drug list as your potential culprits as well. Test that you want to do in such scenario is obviously serum calcium adjusted for albumin, phosphate, PTH, vitamin D, magnesium, and using. And if the hypocalcemia is mild and asymptomatic, you can often, as I mentioned, post-thyroidectomy patients will need some supplementation if the calcium starts picking up. After 24 hours, they can be discharged and then monitored in the outpatient clinic, but sometimes you may need to add alpha-calcidiol as well if the hypocalcemia persists. Obviously, always replace vitamin D if that's the cause of the deficiency. If the magnesium is low, stop the drug that lowers the magnesium and replace the magnesium IV, and the online calculators to tell you, because it has to be quite precise replacement, and oral magnesium usually doesn't do the job. With severe hypocalcemia patients, we need to treat this as emergency. Again, guidelines are available on the Society for Endocrinology website. If your calcium is less than 0.9 and patient has symptoms, or even without the symptoms, you want to give IV calcium gluconate. You start with 10 to 20 ml of 10% calcium gluconate over 10 minutes. You may need to repeat it until the patient is asymptomatic, and then you do an infusion. So you need to put 10 vials of that calcium gluconate into 1 liter of fluid, and you infuse it over as 50 to 100 ml per hour. Obviously, be careful in patients that are at risk of fluid overload with end-stage renal failure. And you want to titrate the infusion to achieve normal calcemia, and again, treat the underlying cause of what was the reason for low calcium. As we are talking about calcium, I will briefly go through hyponatremia. This could be a subject for a whole separate lecture itself, but just a few points as a take-home messages. It can have a very broad spectrum of symptoms and signs, but it can be life-threatening if it's severe and if it's not treated appropriately. Biochemically, we're divided into mild between 130, 135, moderate 125 to 129, and severe if it's less than 1 to 5. But every patient is different, and the symptoms may vary aside from those arbitrarily decided classifications. So the symptoms can be presenting symptoms can be low GCS, seizures, cardiorespiratory arrests, severe vomiting, confusion, headache, and depending on how quickly the hyponatremia developed and how much time the patient's CNS had to adapt to changes in osmolality, the patients can present differently, and also depending on the age and the range of comorbidities and the drugs they're taking as well. If people have sodium more than 130, it's unlikely they will have symptoms, but obviously every management decision is individualized. Those with severe symptoms, severe hypernatremia, require immediate treatment with hypertonic saline, irrespective of the cause of hypernatremia. You treat first, then you start digging for the cause. And the Society for Endocrinology recommends that within the first hour, you give 150 ml of 3% hypertonic saline or equivalent. Over 20 minutes, you monitor closely, you send off the blood quick, or do it on the gas machine for repeat sodium, then immediately put up a second infusion in that time. You can repeat it twice or until the sodium has increased by 5 millimoles per liter. Then you stop and keep the line open with the normal saline infusion and start thinking what caused it and where do we go from there. Please remember that you don't want to increase the sodium by more than 10 ml in the first 24 hours, even if you have something like ridiculously low, because the patient will go into trouble. And you limit the increase to 8 millimoles every 24 hours thereafter. You want to check your sodium very carefully, so at least every 6 hours initially, then 12 hours, then daily once they stable. And why am I talking about overcorrection? Overcorrection is dangerous because, so if you will exceed the limit of the 10 ml in 24 hours, you obviously have to stop the hypertonic saline, but you might want to speak to your endocrine colleagues or experienced clinicians whether we should introduce a hypotonic fluid or give, for example, some desmopressin to correct the overcorrection. And obviously, as I said, keep looking for the cause of the hypernatremia and treat the cause, because otherwise you'll be back to square one and your sodium will drop again. This is a graph that might be worth taking note of about how useful doing the urine osmolality, urine sodium can be in helping you to decide what is the cause, what is the most likely cause of the hyponatremia. So please take a note of that. And this is a very useful graph. Again, we don't have enough time to talk to it, but if you want to familiarize yourself with it later, it tells you how important is the assessment of the fluid status of the patient, whether it's hypovolemia, euvolemia, and how you can use the urine sodium, urine osmolality to help you decide about the fact, for example, whether the patient needs fluid restriction and what sort of fluid restriction, how strict you should be with that. And it's a very useful thing called first formula here, urine sodium plus potassium divided by serum sodium, that gives you very good indications what you should be doing or when fluid restriction will not work. So maybe take a picture of the slide as well and read it peacefully after the talks. Refractory SADH is something that we often struggle with, and historically we use the macrocycline, sometimes lithium, very rarely, but the results are not that great. A few years ago, you probably were aware that the drug called tolvaptan had a bit of like a moment of fame, was used quite a lot, but it is quite unpredictable in how quickly it raises the sodium back up, and people might go into overcorrection. So we use it very with caution. And as I said, cornerstone of management of severe hyponatremia these days is the hypertonic saline, and you look for the cause and treat the cause. So let's move to the final cases. This was a lady who was in her 50s, presented with confusion, agitation, fever, quite dyspneic. She had palpitations and was vomiting, and she was unwell for the last few days with symptoms suggesting UTI. Generally, over the last few months, she was not right. She was losing weight. She had changes in bowel habits. She could not sleep. She was sweating and reporting palpitations. Her family commented on that as well. No regular medications as such. Mother had hypothyroidism. The lady was a smoker but didn't drink alcohol. And when she was assessed, her GCS was a bit decreased. She was disorientated, agitated, had high temperature, high respiratory rate, and she was tachycardic. And when she was examined, she was found to be clinically in an AF. She had some few crackers at the bases of her lungs, and she had quite an obvious goiter, and the tremors were noted. Bloods revealed that she had high inflammatory markers. Her calcium was a little bit on the high side. Urine dipsticks pointed towards infection. There was cardiomegaly on the X-ray. ECG showed fast AF, and TFTs were pending, but at that point it was pretty clear that they would likely come back, as they did eventually, with completely suppressed TSH, FT3 quite high, very high, and FT4 in the 70s. So before the bloods were back, other differential were considered, but this is a thyroid storm that was precipitated by urosepsis. So how do you manage a thyroid storm? Obviously, supportive measures are important at your ABCD, as you always do with managing unstable patients. You give oxygen supplementary or ventilatory support if required. You stabilize them with IV fluids, obviously, if no risk of overall. You want to control the hyperthermia. Then you want to give your beta blockers to stabilize the heart rate and the tremors, and also that benefit is that they inhibit the peripheral conversion of T4 to T3. You can use propranolol, PO or NG, or IV, or you can give atenolol, bisoprolol, metoprolol, whatever you have available in your local hospital. If the patient cannot have beta blockers, for example, because they have severe asthma, you can use a calcium channel blocker such as verapamil. And what do we do? What is the most important thing? We obviously have to stop the overproduction of the thyroid hormones. So we go with propyltiuracil first, usually 200 milligrams every 4 hours. You can give orally or via NG tube. And we prefer it over carbimazole because it's got quicker onset of action and also inhibits peripheral T4 to T3 conversion. Then when the patient is feeling better and is responding, then we can convert them later to carbimazole. Obviously, you have to consult the patient about the risk of neutropenia, about the need to monitor the LFTs. In certain scenarios, you may also want to use the Lugol's iodine because they block the release of thyroid hormones, that they come in the drops, so again, orally or via NG. Steroids are quite important as well, the favorite endocrine drug, because again, they decrease the peripheral conversion of T4 to T3, and they also prevent relative adrenal insufficiency that maybe those patients have that we don't know of yet. Bile acid sequestrants might be useful as well as something called cholestyramine. You can give it via NG tube, and that orally, and it reduces the thyroid hormone reabsorption from the gut. In extreme cases, obviously, you may have to use plasmapheresis, and people might end up in ITU or HDU. And as in this case, you want to treat the underlying condition that precipitated thyroid storm, often something else happening that pushed them into that. And the final case, this is a man in his late 80s that was brought in by the paramedics, was found on the floor by the relative. He must have been on the floor from the night before. He wasn't able to stand up and leaned against, developed skin burns on his back. And generally, he's been increasingly confused over the last days and weeks, and presented with symptoms that suggested that he may also have concomitant respiratory infection. Pretty standard pathologic history for a man of his age. When he was assessed, his GCS was low, his temperature was only 33, he was bradycardic and hypotensive, and his oxygen saturations were low. And he was found to have dry skin, periorbital and pedal swelling, and there were crackles at the bottom of the right lung up to his midzone. Blood showed that the CRP was high, the sodium was low, borderline calcium, glucose was low, and then he was bradycardic with prolonged QT, low amplitude QRS, ECG. X-ray confirmed that he had a pneumonia, and subsequently his TFTs came back showing that he's got severe hypothyroidism. It was a case of myxedema. And his airway were managed with supplementary oxygen. It is very important to know that these patients might often require ventilatory support as well. So ask your ITU colleagues to review as well, so that the respiratory support is offered on time if required. First thing that you want to do is replace the thyroid hormones. You have to go do it IV because there's reduced GI absorption. So you give loading doses of levothyroxine between 300 to 600 micrograms, and then you follow it by the daily doses. Obviously, in patients with cardiac history or elderly patients, you want to go lower because precipitate the cardiac ischemia. And if it's available at T3 as well, between 5 to 20 micrograms IV boluses, initially followed by 2.5 to 10 micrograms TDS. The patients will be switched to oral levothyroxine once they're stable, TFT is improved, and they're able to take the oral meds. Obviously, you need to monitor the cardiac function, the pulmonary function, and the GCS to assess the clinical response. It takes good few days for TFTs to normalize, and you would want to do TFTs daily or these alternate days just to see what's going on biochemically. Steroids are quite important in management of these patients too, because again, they may have occult adrenal insufficiency or the T4 therapy can precipitate the adrenal crisis. So you cover them with steroids. And then once they stable, you check the morning cortisol, random cortisol, and the short synactin test. Supportive measures are very important as well, correcting hypothermia, treating the underlying infection, treating the hypoglycemia with dextrose, and correcting hyponatremia often will correct itself once you treat the underlying cause, and supportive measures in terms of feeding, such as NGOTP and feed might be required as well. And in many cases, these patients end up in ITU till they stable. Just as the final slide, I would like to mention the endocrine complications of checkpoint inhibitor therapy. And this treatment has revolutionized the management of people with oncological problems, but we know that they cause various endocrinopathies. Could be hypophysitis, adrenalitis, thyroiditis, and it can happen early on to treatment or even years after. So if you have your patients who had cancer managed with ipilimumab, pembrolizumab, or nivolumab, for example, and they present with you with those vague symptoms that we discussed that may suggest adrenal failure, may suggest some issues with thyroid, please start investigating accordingly. Keep it somewhere at the back of your mind that this is important to know. And please remember that the SFE guidelines are also available, what to do in such scenario, how to investigate further. To have low threshold for checking, it's better to check and everything is fine than miss something like that, because as you can see, when these endocrine emergencies happen, people can be quite sick and things can go down very rapidly, and they may end up in ITU. So always remember that if you suspect adrenal insufficiency, for example, there's never any harm of giving a status hydrocortisone while you're figuring what to do. Okay, you can do the confirmative investigations later, but it can save lives in certain scenarios. Thank you very much for listening. I hope that you feel a bit more prepared for your future oncology when the endocrine emergencies may occur. Remember that the guidelines are available there, and the effective and safe treatment early on is very important. So use the society guidelines website, or keep them somewhere on your phone so you can access it easily. Thank you very much.
Thank you. So we have our next speaker, that is Professor Dr. Atul Khalhan, consultant endocrinologist, Royal Glamorgan Hospital Course Director, Postgraduate Diploma, MSc Endocrinology, University of South Wales. Sir, Atul Khalhan will be speaking on interpretation of thyroid function test results, clinical scenarios from real life.
Good morning. I'm Professor Atul Khalhan. I'm a consultant endocrinologist based at Royal Glamorgan Hospital, South Wales. I'm thankful for Merck Foundation to give me opportunity to interact with you. Today, I'll be talking about interpretation of thyroid function test results. I'll be sharing some clinical scenarios from real life with you. Let me share the first clinical scenario with you. A 35-year-old housewife presents to your clinic complaining of fatigue and malaise, which has been ongoing for a few months. She feels extremely frustrated about her inability to lose weight. Her appetite is normal and she's exercising regularly. Her menstrual cycle is regular. There is no history of cold intolerance. She has no past medical history of any medical disorder. She's currently not on any medication. On examination, her body mass index is 32 kg per meter square. General physical and systemic examination is unremarkable. You do the baseline investigations for her. Full blood count, kidney and liver function tests are within normal range. Her thyroid function tests show free T4 of 12.5 picomole per liter. I've provided you with a normal range, which is 9 to 19.5. TSH is mildly elevated at 6.5 m unit per liter. So the management options for this woman you're going to give a thyroxine and T3, only thyroxine, only T3, or give a placebo treatment, or do nothing and repeat the thyroid function in 6 to 8 weeks. So I'll recap the clinical scenario. A young woman presenting to you with biochemical picture of subclinical hypothyroidism, whose symptomatic symptoms are non-specific. Which out of these management options you are going to go for? Before we discuss this clinical scenario in detail, I'll share with you the attribution theory. If you give a person a label of a pathology, their view of themselves as a self-directing individual and their sense of well-being deteriorates. Subclinical hypothyroidism, the clinical scenario I shared with you, has a prevalence up to about 10% of adult population. The key thing you have to remember that a twofold change in free T4 level is associated with a 100-fold change in TSH values. The individual range for free T4 and free T3 are narrower than the population reference range. And it's important to remember that TSH levels increase with age. So a TSH of 6 to 7 m international unit per liter at age of 80 may be deemed as normal. It's important to be aware of impact of gender, ethnicity, and body mass index on the TSH levels. Things we have to remain mindful about when we are dealing with a patient with subclinical hypothyroidism. Could it be a recovery from non-thyroidal illness? And the best way to do it is to repeat the TFT in 6 to 8 weeks. Could these results be because of a assay variability or interference, presence of heterophile antibodies? Now, T3 therapy, none of the guidelines support its use. It's being used as part of research. Another thing which we have to be mindful of is subclinical hypothyroidism, its impact on cardiovascular health. There is data, mostly based on observational studies, which suggest that subclinical hypothyroidism has an impact on endothelial function, and treatment of it helps in lowering insulin resistance, but it's not level 1 evidence. So let's appraise the quality of evidence for treating subclinical hypothyroidism. That is the group with free T4 levels, which are within normal range, although the TSH varies between 4 to 10 m international unit per liter. If we look at progression to overt hypothyroidism, especially if anti-TPO antibodies are positive, the strength of evidence is good. Increase CVD risk, insufficient evidence in treating subclinical hypothyroidism. Similarly, for dyslipidemia and cardiac dysfunction, quality of evidence for treating this cohort remains insufficient. Similarly, treating patients with subclinical hypothyroidism related symptoms and psychiatric symptoms, the strength of evidence and benefit of treatment remains limited. So the question arises, when should we treat people with subclinical hypothyroidism? When should we give them a therapeutic trial with thyroxine? Unequivocal evidence is there for treating people if the TSH level is more than 10 m international unit per liter on 2 separate occasions, which are 3 months apart. If anti-TPO antibodies are positive, then chances of these individuals to go on to develop overt hypothyroidism remains relatively higher, which has been quoted to be around 4.3% annually. You have to at least monitor the thyroid function in this group. In other group with TSH of 4.5 to 10, you tend to treat with thyroxine if there is history of infertility and miscarriages, if these are younger individuals who are at high risk of CVD with associated risk factors, symptomatic patients, you can consider giving a therapeutic trial, or in presence of goiter, you can consider treatment. I'll finish the first clinical scenario by quoting Groucho Marx. The problem with doing nothing is that you never know when you're finished. So in a patient with subclinical hypothyroidism, I would not treat unless until there is a clear indication for it. And I'll reinforce the indication: recurrent miscarriages, presence of goiter, or high CVD risk in younger individuals. Let's move on to the second clinical scenario. A 68-year-old retired teacher presents to your clinic. He has background history of type 2 diabetes and osteoarthritis. He's otherwise well, and he had undergone some routine blood tests which showed raised free T4 of 15.5 picomole per liter. I've given the normal range, which 9 to 19.5, and TSH is suppressed at 0.15 mUnit per liter. And let me reinforce, this gentleman is asymptomatic and examination is all normal. There are no signs of hyperthyroidism. Eye examination is normal. There is no visible or palpable goiter. So my question to you, what are you going to do for this 68-year-old asymptomatic man presenting with suppressed TSH levels but free T4 within normal range? Are you going to treat him with carbimazole, or will you discuss elective thyroidectomy with him, or you'll go for propylthiouracil, observe, or radioiodine ablation? Which out of these options are you going to go for? The second clinical scenario I had shared with you was related to subclinical hyperthyroidism. T4 was within normal range and TSH was suppressed. The management approach which I follow in clinical practice includes confirming the diagnosis, evaluating the severity of hyperthyroidism, trying to investigate and finding out the underlying etiology for this overactive thyroid gland, assessing for complication, and then deciding what is the most appropriate treatment option. So the first step in any individual with subclinical hyperthyroidism includes to confirm the diagnosis. Now, our scenario had an asymptomatic man with no risk factor for CVD, for example, no background of atrial fibrillation, diabetes, hypertension, or known to have cardiovascular disease. The best thing to do is to repeat the thyroid function in 1 to 3 months and see if the same pattern exists. The scenario would have been different if it was a symptomatic man who had associated risk factor. You couldn't have waited for TFT to be repeated, for example, in 3 months. You needed to act in a bit more urgent way. In such a scenario, it's important to get the thyroid function test repeated in 2 weeks' time. Step 2, assess the severity of hyperthyroidism. And there are 2 simple grades here. Is the TSH suppressed to under 0.1, or it is measurable at between 0.1 to 0.4? And I'm talking in context of normal free T4. Age more than 65, you qualify to be having higher CVD risk. Presence of comorbidities, for example, arrhythmias, heart disease, osteoporosis, put you at a higher risk. And presence of symptoms, for example, angina, shortness of breath, are associated with increased severity. The third step is to establish the underlying etiology for this subclinical hyperthyroid state. Could it be a transient viral thyroiditis in which a subclinical hyperthyroid state is followed by euthyroid or hypothyroid state, which 1 in 3 patients may have it on a long-term basis? If it's a persistent subclinical hyperthyroidism, could it be a toxic adenoma or something autoimmune like Graves' disease? In the right context, could these tests be secondary to a pregnancy in a younger woman? Or there can be some iatrogenic factors which are contributing to this subclinical hyperthyroid state. And it's important to be aware of medications, for example, interferons and new anti-cancer therapies, which can induce this kind of state. I'll just recap with you some practice essential related with overactive thyroid gland. As I mentioned, the differential diagnosis for hyperthyroidism include autoimmune Graves' disease, toxic nodular goiter, viral thyroiditis, iatrogenic factors. One can consider uptake scans. Again, it depends on availability. Toxic nodular goiter may show an increased uptake versus viral thyroiditis, which may have reduced uptake. In our practice, we are relying more on thyroid stimulating immunoglobulins, but one has to be aware of the implication, the cost of this test also. Presence of thyroid stimulating immunoglobulins confirms the diagnosis of Graves' thyrotoxicosis. Absence goes in favor of some alternative underlying etiology for hyperthyroidism. Thyroid FNAC has no role in diagnosis of subclinical hyperthyroidism or hyperthyroidism. Sharing with you increased uptake on radioiodine uptake scan, which is hallmark of a toxic nodular goiter, and reduced uptake at times is associated with viral thyroiditis. Another radioiodine uptake scan with no uptake in the thyroid. So coming back to the clinical scenario related with subclinical hyperthyroidism, we discussed about confirming the diagnosis, assessing the severity of hypothyroidism, and underlying etiology. Fourth and most important step, assess for possible complication. Is this associated with increased risk of atrial fibrillation? What is the CVD burden on this individual with ongoing subclinical hyperthyroid state? You can consider arranging a bone density scan to assess for osteoporosis, because untreated subclinical hyperthyroidism increases risk of osteoporosis more for the cortical bones as compared to the trabecular bones. There is no evidence for subclinical hyperthyroidism affecting cognitive function. There is no conclusive evidence for it. What is the right treatment in such scenarios? Obviously, it depends on underlying etiology. Treatment definitely is indicated in high-risk individuals, for example, people who are aged 65 and above, who've got background of ischemic heart disease or atrial fibrillation. If persistent endogenous and grade 2 subclinical hypothyroidism is there, that means there is a persistent suppression of TSH. And most of the time in our clinical practice, we see this kind of clinical and biochemical presentation linked with a toxic multinodular goiter, which may not be palpable on clinical examination. In such scenarios, treatment options are going for radioiodine ablation if it's available, or low-dose carbimazole, which is safe and efficacious way to deal with it. I'm sharing some evidence related to use of low-dose carbimazole versus radioiodine ablation in patients with relapse of Graves' disease. They divided the groups into the ones who received radioiodine followed by thyroxine versus low dose of methimazole. Median duration of follow-up of both groups were quite similar at around 81 months versus 71 months. Interestingly, euthyroidism was more common in methimazole group. Thyroid dysfunction and deterioration of ophthalmometry were more common in radioiodine ablation group, although assessment of quality of life indexes were same in both groups. This study was published in Thyroid in 2015. I'm sharing another older study for long-term use of low-dose carbimazole in individuals with severe Graves' ophthalmopathy and hyperthyroidism. There were around 108 patients who received low dose of carbimazole. Median duration of follow-up was around 80 months, and 90% of such patients remained euthyroid throughout the treatment period. As I said, it's a relatively older study which was published in Thyroid in 2011. I'll close the second clinical scenario by sharing a quote from William Osler. The person who takes medicine must recover twice, once from the disease and once from the medicine. It's a very deep quote. Do spend some time reflecting on it. So far we have covered two clinical scenarios, one covering subclinical hypothyroidism, which is relatively common in clinical practice, and the second one related to subclinical hyperthyroidism. Let me talk you through a third clinical scenario. This is an individual who was 43-year-old when he presented to our endocrine clinic. There was history of feeling unwell for over 6 months, very non-specific kind of symptoms. He was complaining of feeling lethargic, cramps in hand, headaches. His general physical and systemic examination was normal. His initial set of investigation showed raised phosphate, low PTH, although the repeat parathyroid hormone levels were within normal range. I want you to focus on abnormal thyroid function test results. His free T3 levels were within normal range, although free T4 levels were 9.1 picomole per liter. The normal range used in our lab is 9.2 to 21. TSH was low at less than 0.02 m unit per liter. So just focus on the free T4 and TSH levels. Free T4 low and TSH less than 0.02 m unit per liter. As this gentleman had low free T4 and TSH levels, we carried out rest of the anterior pit hormone biochemical screen for him. His MRI was arranged, and not surprisingly, he had a pituitary macroadenoma. I'll try to point it to you using the arrow. There is a large macroadenoma which is compressing optic chiasm. So here is a gentleman who presented with non-specific signs and symptoms. He had secondary hypothyroidism biochemical picture in which free T4 was low and TSH suppressed. Subsequent imaging picked up macroadenoma. I'm sharing the radiology report for this gentleman. It was reported to be a 19 into 20.7 into 20.6 millimeter macroadenoma with evidence of hemorrhage. The only test result which I didn't share with you was his prolactin level was 100 times the normal. To cut the long story short, he had a prolactinoma with anterior pituitary dysfunction. We treated him with cabergoline therapy, which led to shrinkage of the tumor and normalization of his TFT also. Last seen, he was on cabergoline 500 microgram twice a week. The macroadenoma had shrunk and TFT results had normalized. So the only purpose of sharing this particular clinical scenario is to make you aware about possibility of a prolactinoma or a macroadenoma or a cellular structural lesion related to pituitary if you encounter secondary hypothyroidism biochemical picture. I'll briefly go through the clinical scenario, the last one. A 58-year-old man complaining of ongoing tiredness has been referred to you in endocrine clinic. He has background history of depression, low back pain and fibromyalgia. He remains on multiple medication, which includes citalopram and paracetamol. Clinical examination is more or less unremarkable. His blood tests show a similar picture to the third clinical scenario I shared with you a few minutes ago. Free T4 was low, although the TSH was measurable. Interestingly, in contrast to the third clinical scenario, the prolactin levels, IGF-1 level, 9 AM cortisol levels were within normal range. So I'm sharing biochemical picture of secondary hypothyroidism with no other clinical or biochemical parameters suggestive of anterior pituitary dysfunction. And over the last few years in our center, we were observing more or less, one or two referrals every few months with central hypothyroidism biochemical picture. And we were doing MRI scans and radiological imaging for such individuals. MRI was not picking up any obvious adenoma or pituitary abnormality. The only common theme or link we saw in this cohort was they were on medication which were affecting serotonin dopamine pathway. And these medication included citalopram, sertraline, fluoxetine. And our working diagnosis was that this central hypothyroidism is likely linked with the medication they are on. As a result, we published our finding in Clinical Endocrinology last year, and prior to it, we published a smaller study in Thyroid Journal back in European Journal of Thyroid back in 2022. So based on our own data, we do think that individuals who are on medication which affect serotonin dopamine pathway, it can induce central hypothyroidism biochemical picture. It's very important that you still carry on clinical and biochemical assessment for the rest of pituitary function in this cohort. So I just wanted to share this last clinical scenario with you about something which we have recently reported. This is my last slide, which sums up how to interpret thyroid function test. Obviously, when free T4 is high and TSH is suppressed, diagnosis is very clear. It's hyperthyroidism. Same is the case if free T4 is low and TSH is high, it's hypothyroidism. Subclinical hypothyroidism and hyperthyroidism are relatively common in clinical practice. We covered both of these entities in clinical scenario 1 and 2. For an endocrinologist, the most important thing, or what interests us, is if free T4 are low and TSH is normal, suggestive of a central hypothyroidism picture. So I shared with you a pituitary adenoma, which was prolactin secreting, and then shared with you iatrogenic causes of central hypothyroidism. Similarly, if free T4 is high and TSH is normal, think about TSH resistance or TSH secreting pituitary adenoma. I'll finish my talk by quoting Voltaire, who said, "Art of medicine consists of amusing the patient while nature cures disease." Similarly, William Osler said, "It is astonishing with how little reading a doctor can practice medicine, but it's not astonishing how bad he may do it."
Yeah, thank you, Professor, for the wonderful presentation. So, dear doctors, in case if there is any queries related to the presentation of all the online speakers, you can write to us so that we can send these queries to our online speakers and get them answered. Okay. So now we will move on to the fourth online presenter, that is Dr. Roberta Lamte. So the Dr. Roberta Lamte is consultant family physician and diabetologist, family medicine department, Korlebu Teaching Hospital, Ghana. She'll speak on it's time to update the diagnostic criteria for diabetes, a closer look at the utility for 1 hour post-load glucose. So this presentation is a pre-recorded presentation since we are having a technical glitch, but Dr. Roberta will join us lately to answer the questions. Okay?
My name is Dr. Roberta Lamte, and I come from Korlebu Teaching Hospital in Ghana, Accra, Ghana. I'm thankful to Merck for inviting me to deliver this talk. And today I'm going to talk about the utility of the 1 hour post-load glucose. So let's get right into it. I thought I'll start off with a question about self-care. When you think about your own self, your own practices, your own habits, what is the one challenge that you face when it comes to self-management, when it comes to portion control, doing your exercises, getting enough sleep, basically managing your own self? What one word will you use to describe your biggest challenge? Please put your answers in the chat box so that we can have a very interactive session. So this is the agenda I'm going to follow through today. We're going to talk about the diagnostic criteria for diabetes. Then we'll look at the sub-Saharan African context and the epidemiology of diabetes in sub-Saharan Africa. I'll then look at the utility of the 1 hour post-load glucose in predicting outcomes of diabetes. And we'll look at why the 1 hour post-load glucose matters, and I'll end with a call to action. So let's start with diagnosis of diabetes. Diagnosis of diabetes can be made with a fasting plasma glucose, a random plasma glucose, and HbA1c. So a fasting plasma glucose of 7 millimole per liter or more meets diagnostic criteria for diabetes if the person is a repeat testing or the person has classic symptoms. If it is in somebody who is asymptomatic, please remember to repeat the test. However, if the person presents with classic symptoms such as diabetes, DKA, wasting, cachexia, then a random plasma glucose, a single value is enough to make diagnostic criteria. And that value is 11.1 millimole per liter or more. We can also use HbA1c to make a diagnosis of diabetes. So an HbA1c of 6.5% or more meets diagnostic criteria for diabetes. Why am I talking about that? I'm talking about that because I want to draw your attention to the fact that although those are very strict cutoff points and it's like a sharp line, really those lines represent where the increased odds for developing retinopathy is sharply elevated. However, the risk for hyperglycemia is on a continuum, just like the rainbow I'm showing you there. And I'd like you to keep that rainbow in mind as we go through the rest of the presentation. So yes, the risk is a continuum, the risk associated with hyperglycemia is a continuum. And actually, complications associated with hyperglycemia start way before somebody may even meet diagnostic criteria for diabetes. They start from the pre-diabetes stage. So risk complications such as nephropathy, neuropathy, all can happen way before people meet diagnostic criteria for diabetes. So let's look at the sub-Saharan African context. What is the epidemiology of diabetes in sub-Saharan Africa? As of 2021, there were 24 million people on the African continent, in the sub-Saharan African region living with diabetes. And this is data gathered in people, in adults aged between 20 to 79-year-olds. And that 24 million translates into a prevalence of about 4.5%, meaning that for every 100 people, you will get about 4.5 people, less than 5 people who actually had diabetes as of 2021. Now, this is where it gets alarming. The projection is that if the current trends persist within the next 20 years, by 2024, there will be more than 100% increase in this prevalence data, actually more than 130%. So that means that you will now, when you take 100 people, have more than 10 having diabetes. So for every 10 people that you see, one of them will have diabetes. And that is what we are facing in sub-Saharan Africa. But it's not just the non-communicable diseases that is on a relentless drive. It's not just diabetes. In sub-Saharan Africa, we know that we are also battling communicable diseases. The regional prevalence of tuberculosis is about 9%. This is data from meta-analysis. So therefore, there's a range. And if you take individual countries in sub-Saharan Africa, the prevalence is much higher. If you take a country like Nigeria, for example, the prevalence is about 15%, which is pretty high. I am very intrigued by this study. So what they did was to take post-mortem and find out the prevalence of missed tuberculosis. So people who died and actually had tuberculosis, but it was missed. So in the general population, they found a prevalence of 27%. Now let's look at people who were living with HIV. They found a prevalence of as much as 67%. So in the sub-Saharan African region, we are facing both a disproportionate burden of diabetes, projected rise of more than 130%, and then a current burden of tuberculosis. Now, I want you to realize that diabetes and tuberculosis are linked. There's a bi-directional relationship between the two. So the prevalence of diabetes among people living with tuberculosis in sub-Saharan Africa is 9%. And people who develop diabetes have an increased risk for developing tuberculosis. And people who have tuberculosis are at increased risk for developing diabetes. So think about the projections and think about what that means when you think about the bi-directional relationship between tuberculosis and diabetes, and what will happen in 2045 when that predicted rise in diabetes prevalence does occur, if nothing changes. What would happen to tuberculosis, knowing the bi-directional relationship I've already shown you? So I'm sure you will agree with me that what is facing the sub-Saharan African context requires an aggressive and a bold approach. So that brings me to the utility of the 1-hour post-load glucose in predicting diabetes outcomes. To tackle that, I want to share with you the IDF position statement on the 1-hour post-load glucose. And this statement was released in 2024, and I highly encourage you to pull up the full paper and to read it. But the IDF position statement is that the 1 hour post-load glucose actually, when it meets a cutoff of 11.6 or more, is actually diagnostic of diabetes. And this threshold, the interesting thing is, develops earlier than the threshold of 2 hour PPG of 11.1 or more. So what am I saying? I'm saying that if you use or you look at the 1 hour post-load glucose, you do an OGTT, and at 1 hour, you see a value of 11.6, it means that that person meets diagnostic criteria for diabetes. And what about pre-diabetes? What about intermediate hyperglycemia? This position statement tells us that if the 1 hour post-load glucose is 8.6 or more millimole per liter or more, you should worry. You should think about pre-diabetes, and you should initiate lifestyle recommendations. So the 1 hour post-load glucose is important because it allows us to spot the difference. And as I've already said, sometimes spotting the difference can be easy as picking out that red egg, or it may be as difficult as spotting the difference between those eggs I'm showing you. So the 1 hour post-load glucose is a gem because it allows us to identify earlier. It allows us to be able to pick out those people who have normal glucose tolerance when you look at the fasting sugar and when you look at the 2 hour post-load glucose. They don't meet diagnostic criteria, but yet, if you look at the 1 hour load glucose, you will be able to identify them. And early identification helps you to be able to offer therapy, to offer non-pharmacological therapy, to offer pharmacological therapy. And why is this important? Because without treatment, without identification, there can be no treatment. And without treatment, there can be no control. And we know that diabetes, which is not controlled, is associated with increased risk for very serious complications. Now, in Africa, in Sub-Saharan Africa, more than the number of people who have diabetes and know that they have diabetes is actually fewer than the number of people who have diabetes and don't know that they have diabetes. What am I saying? Sub-Saharan Africa, the prevalence of undiagnosed diabetes is more than 50%. And we know that without a diagnosis, there can be no opportunity for treatment, no opportunity for achieving control. But not just that. Now, the evidence that diabetes can be driven into remission abounds. The literature is littered with scores and scores and scores of evidence that it is possible to drive diabetes into remission. Unfortunately, none of those diabetes remission studies were conducted in Africa. And I hope that somebody here will take up the challenge. I will quote this paper from the UK. They used UK data. But what they found is that if you are able to initiate interventions, lifestyle-only interventions in people who are diagnosed within the first year of diagnosis, the odds of being actually able to drive them into remission is 3 times higher than if you wait and initiate lifestyle-only interventions 3 to 5 years after diagnosis. Why am I interested in lifestyle-only interventions? Not that those are the only interventions which can be used to drive diabetes into remission. We know that bariatric can drive diabetes into remission. We know there's pharmacotherapy that can drive diabetes into remission, but often lifestyle modifications are a low-hanging fruit. And in a setting like Sub-Saharan Africa, where we are resource constrained, resource challenged, lifestyle options, lifestyle-only interventions, which can achieve diabetes remission, are an attractive option. I'm sure you will agree with me. So does diabetes remission translate into reduced complications? What data do we have? This is from the Look Ahead study. and post-hoc analysis show that cardiovascular events such as MACE were actually reduced by 40%, as much as 40% in the people who achieved remission. What about the direct trial? The direct trial was one of the very first studies to be conducted to show that you can drive type 2 diabetes into remission. Of course, it's not all kinds of diabetes which can go into remission, but 5-year follow-up of the direct trial has shown that those who were able to achieve remission actually also had fewer clinical events and better metabolic profiles than those who were not able to achieve remission. So I'll be bringing my talk to an end, and I will end with a call to action. My call to action is simple. When I asked you to put in your self-care challenges, these are some of the things that came up. You have to be consistent. Being consistent is difficult. If you are irregular, it doesn't work. It is time consuming. It requires consistency, persistence. It can be challenging. So self-care is not easy. But we know that lifestyle modifications, if we are able to have people, we are able to drive diabetes into remission with lifestyle-only interventions. And we know that it is most effective when you initiate these interventions within the first year of diagnosis. And the 1-hour post-load glucose allows you to be able to identify, to pick up people who could potentially develop diabetes, pick them up way earlier than waiting for the 2-hour post-load glucose. I trust that this has been a good use of your time, and I hope that I have convinced you to start looking at the 1-hour post-load glucose. I will end here, and I'm happy to take any questions that you may have. Merci pour votre attention. Goodbye. Thank you so much.
Yeah, thank you very much, Dr. Roberta.
Yeah, welcome.
Okay. So after highly informative lectures, now time to move to the panel discussion. So the topic for the panel discussion is gut microbiome and diabetes. So we have with us our panel today, that is Merck Foundation alumni who have completed their online program through Merck Foundation Scholarship. Dr. Lucy E. Marma, she is Research Program Department, National Institute for Medical Research, Tanzania. Dr. Sarah Firdousa, she is internist, Banda Ek Merck Foundation alumni, Indonesia. Dr. John Katema, Medical Officer, Head of Department of Diabetes, Mahatma Gandhi Clinic, Merck Foundation alumni, Zambia. Dr. Kibanga Isaac Staron, Deputy Medical Superintendent, Kishoro Hospital, Merck Foundation alumni, Uganda. And finally, Dr. Bizudar Avinash, he is Consultant in Internal Medicine, Department of Internal Medicine, Jawaharlal Nehru Hospital, Ministry of Health and Wellness, Merck Foundation alumni, Mauritius. Yeah, so you can come up. Dr. Carlson will be moderating this session. Over to you, doctor.
Okay, thank you so much. Good evening, everyone. So we found out today that the gut microbiome is one of the factors associated with the treatment of diabetes and other metabolic disorders. So we have this wonderful panel of experts here that will answer a few questions on the gut microbiome. We'll start with Dr. Lucy Rema. Yes, so we'll delve directly into it because of time constraints. What are the current gaps in research regarding the gut microbiome and diabetes, and what areas should be prioritized for future studies?
Yeah, so I'll try to be brief. It's a huge topic. So I see 4 areas that really need some careful research. One is that most of the studies that we look forward, that we read, are really cross-sectional. We don't have longitudinal studies that show causality. For instance, when you begin with a population that is healthy and then you follow them up until they have diabetes and then complications, then you can extrapolate a lot of things. So studies that are more longitudinal really are lacking in this context. So I think it's our call for more research. Another important area is the issue of ethnicity. As we know that most of the studies that do with the gut microbiome and diabetes come from the North or the Western countries. So if we have, if the prevalence of sub-Saharan Africa is expected to increase better than any other part of the world, we expect a lot of studies to really represent this population. So if you look in the African context, there are few or none studies that have really looked into the gut microbiome and diabetes, to be precise. Another area that I think is of importance is, especially when it comes to translation in clinical practice, a lot of biology is exciting, as Professor said, but how do we translate it later into clinical practice? I think that is an area that we as biologists need to really think, because we do all these nice science, but then how do they translate to clinical practice is another issue. And lastly, I think the gut microbiome has been linked to a lot of complications, especially when you speak about diabetic kidney disease. Prof has spoken about uremic metabolites causing a lot. So I think that is really an area that we should further expand to see how we can personalize medicine to see those that are at risk really get the treatment according to the gut microbiome, and maybe employ some of the omics techniques that can really put the clinical part together with the biomarkers that we study from the gut microbiome. So in brief, that is really what I can say about the research gaps we have. Thank you.
Thank you, Dr. Mrema. We can see that there are really some research gaps and more evidence needs to be produced, especially context-specific evidence, if our clinical practice is supposed to be tailored to meet the needs of our population. We'll move over to Dr. Sarah Fidosa. Doctor, please tell us, how does the gut microbiome contribute to low-grade systemic inflammation observed in diabetic patients?
Okay, thank you for the opportunity. So I will start with the gut microbiome. Gut microbiome is the complex community of the microorganisms that reside in our gastrointestinal tract. And it contains of millions of bacteria, virus, bacteria, and others. And they live in peace and harmony and in balanced composition. But in some extent, it can be imbalanced, and then the conditions that we call dysbiosis happen. And when the dysbiosis happen, the good bacteria will while the bad bacteria will increase. And this condition and then will lead to increased gut permeability. When the gut permeability happen, and then the bacteria, the component of bacteria such as the LPS, lipopolysaccharide, can enter the circulation to the bloodstream, and then at that time, and then we call leaky gut. I mean, the gut can translocate the bacteria from the gastrointestinal tract and then go to circulation. What happens when the LP come to the circulation? It will trigger inflammatory response, which then increase the and interleukin-6 and others, and this condition will lead to low-grade inflammatory status that at the chronic time, at the prolonged time, will make a bad condition on, especially in diabetes. Another pathway that can make gut microbiome dysbiosis can lead to systemic inflammation in diabetes is short-chain fatty acids. These short-chain fatty acids, such as butyrates, is something that produced by the fermentation of our gut bacteria. But in the dysbiosis, this short-chain fatty acid can be reduced, and this will lead to inflammatory response also. And the others is gut microbial metabolites that can also disrupt the harmony of the community of this gut bacteria. So when the dysbiosis happen, and then the good bacteria is decreased and the bad bacteria increase, and then the leaky gut happen, the LPS enter to the circulation, this will triggers the inflammatory response so that the low-grade inflammatory status happen in diabetic patient. I think that's all that I can say. Thank you.
Thank you so much, Doctor, for that elaborate exploration of the mechanisms involved. We'll move over to Dr. Juan Mwamba Katema. Please explain to us, how does dysbiosis of gut microbiota disrupt insulin sensitivity, glucose metabolism, and immune homeostasis?
Okay. Thank you very much, and good evening, everybody. I'd like to think of it in three ways, three processes. Thank you to the previous speaker. I think she's alluded to most of the things that I had wanted to talk about. But the first mechanism that I'll refer to is that of the bile acid metabolism. So in the normal gut, primary bile acids are converted into secondary bile acids, and that's in the presence of normal gut microbiome, okay? So when that happens, the secondary bile acids, they promote an increase in the energy expenditure of skeletal muscle, and they also increase on GLP-1 secretion. So what happens in dysbiosis is the reverse of that. You find that the energy expenditure of the skeletal muscle is lessened, and so is the secretion of GLP-1 in the intestines. So in effect, we find that the stimulation of insulin is reduced, and so the effect of insulin is lessened. Another mechanism is that of the LPS, which was mentioned, LPS being the lipopolysaccharides, which are found in the cell wall, mainly of the gram-negative bacteria that are in the gut. So in the presence of a fatty diet, and also in the presence of dysbiosis, you find that the lysis of the cells of the bacteria will release the LPS, which will persist, as opposed to the normal state of the gut where the host is able to clear the LPS. They persist and they lead to other things which I'll allude to later on. So the third mechanism is that of the gut bacterial metabolites. Short chain fatty acids are produced when dietary fiber is fermented. So the ones that are produced mainly are the butyrate, acetate, and propionate, and which I'll refer to as being friendly is the butyrate, and the one which persists or is more predominant in persons with prediabetes or type 2 diabetes is the propionate. So in the normal state, the butyrate works in three ways. At the hepatic stage, it promotes the synthesis of glycogen, it promotes lipogenesis, and also reduces gluconeogenesis. Then in addition, there's GLP-1 secretion increase, and also the peptide YY, which reduces appetite in persons. Then finally, another effect of butyrate is that of the epithelial cells of the colon. It creates a mucin layer, which is protective, and it protects the gut from harmful microbes. And also it is an energy source for the colonocytes, and hence it reinforces the barrier, including tight junctions, making the colon semi-permeable. So then what happens in dysbiosis is that the mucin layer that we were talking about is compromised, and there's also a dysfunction of the tight junction, meaning the L, which would otherwise be cleared, will penetrate through the gut and would finally find their way to the producing chemicals, which are the cytokines, which in turn will attack the receptors, the insulin receptors, and hence cause insulin resistance. I hope I was brief.
Thank you, Doctor. That was brief but eloquent and elaborate. We'll move on to our next panelist, Dr. Kibunga Isaac Staron. Please, Doctor, tell us, what role does the microbiome play, the intestinal microbiome, what role does it play in the effectiveness of anti-diabetic medication?
Good evening, everyone. I want to thank you for the question. And then also I want to thank the previous speakers. It's just a summary of what they've talked about, but I broke it down in two phases. One is the modulation of glucose metabolism, which as earlier highlighted through the production of the short chain fatty acids, the mention of the butyrate, which is commonly, which has been studied. Unfortunately, a lot of these studies have been in animal models. There is a common one which has been well studied about metformin, which is our first line DM drug for the type 2. It was seen in the germ-free mice when the fecal microbiota of individuals who are receiving insulin was transferred into these germ-free mice. There was an observed increase in the insulin sensitivity of these mice as compared to the fecal microbiota transplantation that was done from individuals pre-metformin. There was also an observation of bile acid alteration. They affected mainly the farnesoid X receptor, which is a nuclear protein receptor, as well as the TGR5 receptor. And this resultantly reduced in the endogenous glucose production. As my colleague also earlier highlighted about the production of certain metabolites, the lipopolysaccharides from the negative cell walls that disorganize the gap junctions of the cell ultimately leading to the chronic low-grade inflammation that she earlier cited. We saw a number of inflammatory mediators, the interleukin-1, interleukin-6, the tumor necrotic factor. And we basically know the influence of these inflammatory mediators on insulin. They cause insulin resistance. Furthermore, we see that these microbiota, there is a bidirectional effect. As they affect the different DM drugs, also the drugs affect their composition and the load within our gut lumen. We see that there are different effects that each drug does bring. Still, metformin has been well studied, and it was observed that these microbiota will lead to an increased insulin tolerance and efficacy. It was also observed that the bioactivity of these drugs will be highly affected by the different microbiota that is available in our gut, as well as the bioavailability, the toxicity, and the efficacy of different medication. They highlighted, I'll share with you some literature. They highlighted about the sulfonylurea. There's a decrease in the absorption of this drug as a result of this dysbiosis that we see. Also, currently, there are a number of randomized clinical trials that are ongoing, which are thinking that the prebiotics or the probiotics, the prebiotics are the food supplements which are used by these microbiota in our organisms to produce these short chain fatty acids that we saw, and the probiotics are these microorganisms. They are commonly they are found in animal products, the dairy products. We commonly see them in yogurt. We think they will play a role in the personalized DM management, as well as the fecal microbiota transplantation, which is currently ongoing. They are getting the good bacteria through the gastroduodenal tubes. They are introduced into the lumen of individuals, especially obese individuals, and they've seen remarkable changes, them losing weight. There are a number of ongoing studies. Unfortunately, the weakness of this is majority of them are still in animal models. We are yet to find out what exactly happens in us humans. Thank you so much.
Thank you, Doctor, for that insightful expose. Finally, we'll move to our last panelist, Dr. Bizadu Avinash. Please, Doctor, tell us what dietary patterns have been shown to positively or negatively impact the gut microbiome in diabetic patients?
Yeah, thank you for the question. Actually, the diet is one of the most powerful modulators of the gut microbiota functions and composition. This complex interplay involves the immune system and the intestinal barrier, highlighting the central role of diet in the pathogenesis and treatment of diabetes. Experiments have shown that dietary changes can induce temporary shifts in a large number of microorganisms as rapidly as within 24 hours. Shift in microbial equilibrium caused by dietary changes leads to dysbiosis, which is related to many disorders such as diabetes, dyslipidemia, and cardiovascular disease. Macronutrients such as fiber, protein, fatty acids, and micronutrients including minerals and vitamins significantly impact on gut microbiota diversity and composition. We have dietary fiber, which my friends have spoken. Dietary intake with lots of fibers promotes fermentation and intestinal microbes. And this appears to cause increase in short-chain fatty acids, which participate in the regulation mechanism of glucose homeostasis. Among the dietary patterns which positively affect the gut microbiome, we have the Mediterranean diet and the plant-based diet, the vegetarian and vegan diet. We have the low protein and low carbohydrate diet and the high fiber diet. And the Mediterranean diet is based regularly on fiber intake, many whole grains, vegetables, legumes, fruits, olive oil, polyunsaturated fats, moderate meat consumption, and moderate alcohol consumption. This food pattern is associated with reduced plasma glucose levels, improved HbA1c, and LDL cholesterol. The Mediterranean diet produces more short-chain fatty acids, contributing in the prevention of diseases, development, and promoting host metabolic health. This pattern could restore some microbiota species and consequently the microbial dysbiosis in adults with diabetes. Another dietary pattern, which I told you earlier, is the plant-based diet, which is beneficial for the gut microbiota. This diet primarily consists of fruits, vegetables, seeds, nuts, legumes, whole grains, and herbs. And this diet positively affects the gut microbiome, and studies have shown that improvements were observed in patients with metabolic disorders with optimized lipid profiles and blood pressure levels. The positive outcomes may be attributed to metabolic products like short-chain fatty acids. And we have the Western diet type. This diet pattern consists of high animal fat, protein, low plant fiber. And these factors are important in the onset of metabolic diseases such as type 2 diabetes. The Western pattern is characterized, as I said, high fat and low fiber intake, which is associated with low microbial diversity and richness. The health consequences of Western diet are extensive, such as dyslipidemia, insulin resistance, systemic inflammation, and alteration in the gut microbiota. A major effect of the Western diet on the gut microbiota stems from the high consumption of processed and ultra-processed foods. Research has shown that high consumption of these types of food leads to dysbiosis. And we have lots of sweeteners, artificial emulsifiers, and the use of antibiotics in farm-produced meat. And this leads to dysbiosis. And I hope I've been quite brief and rapid.
Thank you so much, Doctor. You have been very brief and precise. Okay, we may give the opportunity to some people to ask 1 or 2 questions to our expert panelists.
Thank you very much. I actually thought Prof wanted to take the first bite. Thank you for the wonderful presentation on the gut microbiome. My question, but prior to my question, it's the fact that I think the Black race or African population actually has diversity with regards even to heterogeneity of our genome and of our microbiome. I think basically the microbiome, it's influenced by diets. And as you can pass through the rest of Africa, you realize that even our diets are, there are varieties, separate and all that. So my challenge is the fact that, we haven't developed, research, just like she made mention in our African, population, just to find out. Because mind you, it's possible that, we have westernized our, dietary habits. And so we are losing that form of gut microbiome and going into dysbiosis. And that may just be the emphasis on our rising rates of, diseases, especially diabetes, as we are alluding to. Picking up those essential microorganisms may be essential. It was even said in the past that our great-grandfathers and grandmothers used to live a bit longer because, they could cook their foods on the farms, roast them and eat. But now, because of the high intake of the processed foods, the long-chain fatty acids and low-fiber diets, we tend to have a shorter, lifespan as it may stand. So I don't know how can we implement research, especially in our population, with regards to just even this gut microbiome, to improve our chances and prevent dysbiosis and the eventual inflammation that leads to diabetes. Thank you.
Thank you very much. It's a really nice question. I will answer it not in the context of diabetes. I'm aware of some studies that are done in Tanzania, in particular Kilimanjaro. There's an ongoing clinical trial whereby they actually modify people's diet. They take a Western diet and a traditional local diet. The Chaga tribe is from Kilimanjaro. So they prepare alcohol that is local brew. Many Africans know local brew. And then the Western diets are given the industrialized beer together with burgers and all that. And then later on, they collected urine, they collected stool to study the gut microbiome. They also collected blood to study the inflammatory status. And this paper is published in Nature already. I think if you Google it, it's Temba et al. About the inflammatory status of Tanzanians. And it says actually when you switch diets, even for 2 weeks or 1 week, the impact is already seen in your inflammatory status, meaning those that have switched from the traditional diet to the Western diet appear to be more inflamed in comparison to those that were living in the rural areas. So regardless, you might be born in the rural area eating the traditional diet from childhood, but the moment you switch, you already see the difference even in your blood. So you can imagine the long-term exposure to that type of diet would already have an implication. Now that we are speaking about the local tradition, I think you have heard of the Hadzabe tribe. That's a really interesting population to study because they're entirely hunters. They feed on honey that comes naturally from the hive. So you can already imagine if we had samples from this population, what insights could we have, for instance? Or the Maasai tribe that is entirely pastoral. They move from one area to another. They don't settle. They eat a lot of meat. So there are some populations that are quite interesting to study in this context. And yeah, it just raises a lot of questions, really. I don't have answers to all, but as you mentioned, Africa is highly heterogeneous. And there's even heterogeneity between me and someone seated next to me. So you can imagine how difficult it is to really study this when it comes to the gut microbiota.
Thank you. I wanted to add on in Uganda, specifically in Mbarara. We are running an RCT of the different microbiota that are available among the town dwellers and the villagers, so-called villagers. We are still collecting data. I think by the end of this year or early next year, we shall have gotten results. So Africa, we are moving towards having our local data available. Thank you.
Thank you very much. You've summarized many good things, and you have brought in concepts of diet and urbanization. What you have not included is poverty. Poverty is like a curse because when people are urbanized or peri-urban or even at home, the kind of diet they have access to is cheap carbohydrate and cheap fat. So then that alters their choices significantly. So then worse if they're urbanized and you realize that then the risk of diabetes and related metabolic illnesses now seem to tilt the pendulum towards the poor. I know one Liverpool study published a long time ago about the curvilinear nature of how poverty down a certain level, you get more diabetes in the poor and poor neighborhood. And as you get into the affluent where you don't do a lot of exercise, the drivers are different, but the consequence is the same. And the drivers here are now the gut microbiome is becoming much more prominent. Maybe in further reading, further discussion, you link the taste physiology and gut microbiome. What is unique about taste physiology is there are about three also genetically predetermined tastes. The ladies here who feed babies, who feed us when we are babies, will tell us the breast milk has very little sugar, extremely, tending towards the salty type. So babies brought up exclusively on breast milk seem to be protected both immunologically and metabolically. But as time now moves, when you go back to work and leave this baby and the maid, who think that when you give it a lot of sugar, then they love it. That changes their taste physiology because sugar taste is acquired. It is not genetic, as it were. So then sugar begets sugar. You take a lot of sugar, a lot of it reaches the pancreas. But that is one point. I've linked poverty, now bring a bit of taste physiology. People who have a lot of sugar taste don't take fibers generally. They take more of the drinks. That's why when you advise your diabetics to take fruit and drink the water, the fruit has fiber. So there's so much that you should organize a symposium for us, how pre-diabetics, how do we evolve into the risk of diabetes? And then within diabetes, there's a spectrum of new, experienced, complicated. How do the diet worsen our states of gut dysbiosis and all that? But you've come out very well, so that the key news here is when you advise your patients to watch their diet, fatty food are bad for everybody, for gut dysbiosis, for obesity, and just the difficulty in digesting fat through the bile salts or the bile acids that you have elaborately talked about. So and you forgot to tell them about whether the firmicutes or which group, but gut microbiome, it is thought to have more cells than the body, our own body cells. So that is how sophisticated it is. And diet is a major determinant. So when you advise your patients about diet and their diabetics, You actually are advising them diet that limits inflammation, that limits fat intake and therefore weight loss, and many good things that must happen to the gut, alter microbiome to give them health. Thank you.
Thank you very much, doctors, for taking part in panel discussion. And thank you very much, Dr. Carlson, for moderating the session. So now we enter into the second panel discussion, and that will be moderated by Dr. Lucy.
Okay, so we are up to the last session. I'll try to be very quick and brief. I acknowledge that we're tired. So this session is all about sharing. It's all about sharing the impact of Merck Foundation for some of us who are the Merck alumni, beneficiaries of the Blue Points program. And I would like to call upon Dr. Ruben. Dr. Ruben, are you in? Yes, Dr. Ruben is an executive board member and chairperson of the Namibia Medical Society, also Merck alumni. Dr. Kevin Ndende, are you in? Yes, yes. Dr. Kevin is a consultant physician from Isiolo County Teaching and Referral Hospital, Kenya. I would also like to call Dr. Ndikumana Sudi. Yes, you're welcome. Dr. Ndikumana is the CEO and founder of Shifa Medical Center from Burundi. Dr. Amanda Sarah, are you in? Dr. Amanda, yes, Dr. Amanda, warmly welcome. She's public health officer, malaria elimination, Ministry of Health and Child Care, Merck alumni from Zimbabwe. Dr. Sunil Hungel, yes, thank you. He's in the Department of Internal Medicine, National Trauma Center, Merck alumni from Nepal. Yes, so let's quickly begin with Dr. Ruben. Do you have a mic? Yes. Dr. Ruben, please tell us what is the most significant challenge, opportunity in the field of preventive cardiovascular medicine today?
Okay.
And how did Merck Foundation Fellowship training shape your approach towards clinical practice in preventative cardiovascular medicine? You have 5 minutes.
No, thank you very much. Let me start with the challenge. We know, as it goes by the says, prevention is better than cure. That basically imply that prevention is actually cheaper than a curative approach of diseases. If you listen to most of us when you are talking from Africa, we highlight mainly the question of health financing. And I think that's one of the challenge that exists within preventative. And in most of our country, preventative is a function that lies with the primary healthcare. So, and most of our systems were developed based on the Alma Ata Declaration of 1978 of the UN. And you find that most of our primary healthcare, they are not as strong as they should be. And mainly they are constrained by different resource challenges. Human resource being one, the skills that are required to effectively manage some of the conditions, and then the infrastructure and the equipment. So there is definitely an opportunity for us to develop, especially this time when you are talking of universal health coverage. Universal health coverage in Africa and elsewhere, I don't think will be possible without strengthening the primary health care. So there's an opportunity for us to train most human capital for healthy. There's an opportunity for us to strengthen our healthcare systems, whether in terms of infrastructure or in terms of equipment. So, and this is exactly ties in well with the purpose of the program that are being offered by Merck Foundation, because they're on the basis of prevention and promotion of healthcare. So Merck Foundation is specifically for my content, for myself as a alumni member,
makes an impact where we have a shortage of human resource for health, especially in the remote areas of our countries, the rural areas. When I took up the course, I was a medical officer at a health center. And the challenge I faced there was to manage most of my patients with cardiovascular condition. Most of them actually, in the beginning, I was referring them to the next referral hospital. But after enrolling for Merck Foundation program, I think 6 months into the program, I was able actually to start carrying out appropriate investigation for this patient. I was able to manage them. I was able to change some of the management that were not optimal for certain patients. And I was also able to impact knowledge to my nurses because I was the only doctor there with nurses. So that it can also help me in screening and managing some of these conditions. So, and I think that one can go a long way in strengthening our healthcare system. If this is now the alumni members, if they can be supported by our different Ministry of Health within our countries, so that they have resources required and be deployed also within the primary healthcare to make sure that they are excellent gatekeepers of the healthcare. Thank you.
Thank you very much, Ruben. Thank you. A round of applause. Dr. Kevin, up to you. How did preventative cardiovascular medicine clinic at the public hospital you work influence the lives of patients and the surrounding community? And secondly, how did the training provided by Merck Foundation benefit your clinical practice when you're in the hospital?
All right, thank you very much. Merck Foundation alumni for preventive cardiovascular medicine. I completed the course in 2022, both the diploma and the MSc. So at the public hospital that I'm affiliated with, I must admit that we do not run a dedicated preventative cardiovascular medicine clinic, but we have integrated it within the hypertension and the diabetes clinics. So it runs in tandem with those because typically those are the patients that generally would require that expertise. However, during those clinics, how my training has impacted on the lives of our patients and the community at large is through a variety of ways, one of which is we have improved patient education through giving them practical cardiovascular disease preventative measures, chiefly through awareness and also through improved screening for risk factors of cardiovascular disease. The second one is that there's now quicker access, as my colleague has said. In most of the rural setups where we work, the expertise is not there for people to look at this particular non-communicable disease and particularly cardiovascular disease. So it means now those places are able to get international quality standard of care, courtesy of this training. Then the next advantage is patients are able to get earlier detection of their disease for intervention because one, you're actively looking for these risk factors. Then the other aspect is appropriate referrals because we get cases where we cannot manage. So detecting them early also means you're able to risk stratify and know who you can manage and who you are able to refer to other centers. And then lastly, it has also helped me to capacity build the healthcare workforce within the facility where I work and in the other facilities that are affiliated. Then on the second aspect of the question, the benefits that I've accrued by training through the Merck Foundation are also multiple. So one, I have improved my skills and knowledge to manage a variety of conditions, especially because the course was on an evidence-based practice. So I have practiced that and I have seen a significant improvement in my output. The second benefit is that there's a higher number of patients that are referred to me from colleagues who now understand that the service is available. Then the third aspect is what I alluded to in my last point, skills transfer to other cadres of healthcare workers. Of course, there's improved patient outcomes, which is something that is beneficial and fulfilling for the practitioner as well when you see people get better. Then on a personal level, it has enhanced my eligibility for further training, especially in the field of cardiology. I mean, when you apply for some of these opportunities and you have the international MSc from a university like South Wales, then it improves your profile when you apply for this. And also it has enhanced my career progression. And one of the highlights that I would want to mention, courtesy of this training, is I have recently been offered a tutor position on the same program that I learned from. So that is something good for my career as well. Thank you very much.
Thank you very much, Dr. Kevin. Wonderful news. Okay, up to you, Dr. Ndikumana. As an active clinician, how do you think Merck Foundation training has assisted in managing chronic conditions such as diabetes? And how does your medical center and the services you provide impact the lives of your patient and the community at large?
Thank you so much, Lucy. What I can say, the journey began when we were studying this program. Normally, it was like thinking to study and then to get your degree, and then after you be like going somewhere in a hospital, working. But when I was studying, it was a time, I think there has been a study in our country done at the University of Burundi, 2017, stating about the prevalence of diabetes in a different district of the country. So the district which has been like in a higher prevalence was the one I was born. So it was like an interpellation saying that you have to do something to your people or to your community. So when I graduated, so I thought out of the box, saying that not only to go to one hospital, work as a clinician, but also to try to think for the majority of the people, according to the reality they are living, they are facing. I saw it's like what Dr. Omari was telling us. So I saw that there is a big need, according to how we can prevent their lifestyle and how we can educate them, even if from their home. Because the experience I had, it's like every day when I went to hospitals, even if in a referral hospital, I saw people coming in big numbers at hospital. But I thought on myself that how come people still coming to the hospital? And then we have big doctors, we have big hospitals, we have equipments. So how come we can't empower them from their home? That's why I started with the vision of Shifa Medical Center. So this center, for me, it was like to implement my vision. I was thinking about how to reach out the healthcare services for all without any financial disturbance or any financial hardship. That's the universal health coverage definition. So I decided it's like it's a memorable, but it was hard for me. It was a decision that I start a clinic, but where consultation will be free for diabetic patients. It was so hard for me, even for my colleagues, even for everybody. But I said, no, all diabetic patients will be consulting my cabinet for free. And secondly, for those who will be like admitted in hospital, so they will be charged after recovery. So I don't want to talk about money before seeing them being well recovered. And then I have good numbers of evolutions, because as I think it's Dr. Omari or other professor also who shows us the quote from Voltaire, As a medical doctor, it was like to calm them, but the nature will be healing their diseases. So that's why we began that center. And then years, now it's the 5th year. Even if we have other centers, we have other hospitals with other doctors, our center has been like more significant according to what we have decided towards the diabetic patients. Another good news is like after that, we got another category of patients who said that this clinic is not for everybody. So it's like a community-based clinic, but there are some VIP patients who need also my services. That's why I was trying to put up another Shifa clinic, but for VIP. This is a new I can say a new result for what we have got from Merck Foundation program, a diabetic program. So I'm so grateful according to this scholarship opportunity, because it taught me to think out of the box and then to see how we can be more benefit, not only to 1% or 2%, but to see globally or nationwide to the majority of the population.
Thank you very much. You don't pay.
That's normal.
Thank you very much, Dr. Sudi. Up to you, Dr. Amanda. Is it possible that exposure to malaria can predispose individuals to hypertension and other cardiovascular diseases? And second, the impact of Merck Foundation training to address the challenges in your community. If there are any, please mention them. Thank you.
Thanks, Dr. Lucy. I think firstly, I'd like to just clarify, I'm no longer with Ministry of Health. I still work closely with Ministry of Health, but my affiliation has changed. I'm currently working as a senior technical advisor with JAPIGO, still supporting malaria program. So yeah, I completed my preventative cardiovascular medicine in 2022. And I think it really has been eye-opening, like the previous speakers have said, there's so much that you can do. And particularly as a public health specialist, one of the things is trying to reach the community where they are, regardless of their situation, where they come from, whether they have money to pay or not. So in my current role, part of the work I do is to improve quality service delivery to the clinics in the rural areas and also improve community case management with a focus on malaria, of course. But one of the enlightening things about interacting with the communities is that people are at risk of all these diseases. And one of the things that I have been pushing in my work is to say, when we interact with a client or a patient, we need to not only look at them as a malaria case, HIV case, or whatever business we are walking about on the day, but as a whole patient, because one of the things is infectious diseases are much prevalent in Africa, but also now we are seeing a lot of these non-communicable diseases, a lot of cardiovascular diseases, hypertension, diabetes. So part of the work I do is to really work closely with health workers to try and improve that. So I think to answer your question as to the second question really as to the benefit of this is that I work closely in the public sector really to reach people, to improve their health. But also as a clinician, part of the work I've been doing is also to, like the previous speaker was talking about, to say there's a different clientele, there's the VIPs, or at least a different set of communities that we also interact with. So one of the things I've done is I have partnered with health insurance companies, 2 main health insurance companies in Zimbabwe, to set up wellness clinics. So we do wellness clinics for companies, for corporate organizations, because we know most of the people in the corporate world live really sedentary lifestyles. Their risk of cardiovascular diseases is higher. So I have partnered with 2 companies, and what we do is we conduct wellness clinics to just try and encourage wellness, fitness, primary prevention, like the first speaker said, to identify them before they actually get sick. So that's one of the work I do as a clinician outside promoting public health. And then to answer the first question on if malaria could be responsible for hypertension and other cardiovascular diseases. I think there hasn't been much studies, but there are suggestions really that malaria is a pro-inflammatory condition. And in Africa, in India, and some parts of Asia, it's really prevalent throughout the year, which means these people are continuously getting infected with malaria. So what we know is that these pro-inflammatory cytokines could hurt cardiovascular health and cause cardiovascular diseases. So indeed, it's something that we need to consider, especially with most of us that I see here. We are coming from these countries where really malaria is a big problem. So a message is when you go back, when you interact with the patients, these people are also at risk because of this infectious disease. It causes chronic anemia, which also has an implication on cardiovascular health as well. So just a point to note. And I think lastly is these infectious diseases. I think someone early today said there is no money in cardiovascular diseases. There is no money in NCDs. That's true. There isn't any money. There is no funding. Someone said there is no governments are not funding these things. That's true. There is no specific funding that will come and say we are funding medicines or we are funding guideline development for diabetes, but there is room to explore what can be done. I think the HIV unit has done a lot to appreciate that, of course, HIV, we need to control HIV, but after we have controlled, we're getting a lot of these non-communicable diseases, hypertension, diabetes coming up because of the medicines that we're using and because these people are living longer. So one of the things that I have also been working on is really to be an advocate with these funders, these big funders, the USA, the Global Fund, the Bill and Melinda Gates, to really promote funding towards diabetes, non-communicable diseases, cardiovascular diseases. One thing is no one will come and say there is money for NCDs really, but you can use that channel of infectious diseases to really advocate for funding for the conditions that are prevalent in your area. So that's one of the things that I'm working on. Thanks.
Thank you very much, Dr. Amanda, for that last message. It was really nice. Dr. Sunil, you finished this round. I have also 2 questions for you, 5 minutes to answer. What are the challenges related to your field that you face today, and how do you plan to tackle them in your community with support from the Merck Foundation training? And secondly, how did the Merck Foundation training help you in your clinical practice?
Thank you for the question. As I live in Nepal, it's Asia, and we know that the diabetes, about almost 2/3 of the diabetes is in Asian population. That's India, Nepal, Southeast Asia. So the global burden seems to be increasing, and in Nepal also we have seen rapidly rise of diabetes. About 10 years back, it was about 4%, but now the prevalence is estimated to be, a recent study shows 9%. So one of the main reason I'm working as an internal medicine doctor in a public hospital, and I have used as a single internal medicine doctor in a public hospital. I have to deal with every kind of patients, and almost 10 to 15% of the patients that come to my OPD are suffering from diabetes, and the major cause of the diabetes are rapid urbanization in our part of the world. And also the changes in dietary habit, that people are more shifted to town sites, are taking ultra-processed foods, they are avoiding their dietary fibers, and also sedentary lifestyle. And one of the other aspects, what we used to see in our part of the world is that patients are not aware that they are not so much informed about their status. We usually diagnose diabetes when they come to visit for other illness.
Like someone comes with a fever, someone came with other parts, and then we do random blood sugar, and then they have a high blood sugar. And when we inform them that they have got diabetes, then first of all, they deny it. And some of them will get lost. I don't know where will they will go. And then this lack of awareness is also playing a key problem. So after I have done postgraduate diploma in diabetes just this year, and now I'm doing ongoing, and my MSc is ongoing, MSc in diabetes. So after this course, I have established a diabetes day in my hospitals, so that people with diabetes can come over there. And then at that time, what we used to do is that we used to educate the patient. Before that, there was no diabetes education program running in the country. People will visit the doctors, they will just prescribe medicine, take them about sugar beverage, about sugar food, and just go away. So, and after the follow-up point, they will just will see blood sugar. So after this program, what we started that we try to educate the patient about the diabetes. We used to educate, we started to educate them about how diabetes can be prevented, how diabetes should be detected early, about screening, and this has helped a lot. This has helped a lot. And also one of the other problem is that there is no our local guideline to manage the diabetes. So diabetes is different from practitioner to practitioner. Some of you start with metformin, some start with sulfonylurea, and this different practice is also causing the problem. And after this Merck Foundation, the Merck Foundation has helped me to understand the diabetes proper, and now I have gained much deeper understanding of the diabetes, and I am able to tackle the problem certainly. So what I expect from a Merck Foundation is that Merck Foundation also support other practitioners. And we have got, I think this year also, we have got some postgraduate diploma doctors doing postgraduate diploma in diabetes from Nepal. And also I have also encouraged other people to join the course. And then I have also educated them also. So in this way, I have tried to tackle the problem. Regarding the second question about that, what impact has caused my clinical practice. After I started the diabetes day or diabetes in my clinic, I have seen that the number of patients has significantly increased, and the patient also feel much relief when they know about the diabetes, when they know how they personally can tackle the diabetes, how they can tackle, control their blood sugar, what should they do, like diabetes food cares, they have to do the daily diabetes food care, what food should about. So patient empowerment is one of the key aspects that I learned during the course, and that I have applied in my part. And I have seen that the patient satisfaction is there, and also more and more patients are coming and over there. In my OPDs. And also I was, after this, my MSc, also I will complete my MSc, I'm planning to establish a diabetes welfare clinic in which I, along with some other members, will try to raise awareness about the diabetes, about how to tackle in pre-diabetes stage, how to screen them. So that's part of my role.
Thank you very much, Dr. Sunil, for that wonderful ending. So a round of applause again to the doctors, and thank you very much for sharing your success stories. I now ask you to please take your seats. As we wind up this session, of course, I'm going to return the mic to the man of the match. Yeah, okay, yes. But otherwise, I would like to thank you all for your concentration till to this time, and for your, wish you all the very best of luck.
Thank you very much, Dr. Lucy, for moderating the panel discussion. So as Dr. Lucy said, we have come across the end of the session. So we would like to conclude this rich, memorable session with a vote of thanks to the speakers, panelists, and attendees for joining us and making this a resounding success. We would like to see you very soon for more knowledge sharing and learning opportunities. Thank you, everyone, and be safe and have a great day. Thank you all.